So it's 3, 2, 1. We are live now. We can start the session. Over to you, ma'am.
Good morning to all. Respected teachers, colleagues, dear residents, and my dear friends. It gives us immense pleasure to heartily welcome everyone to the second day of Virtual AFPICON Kerala 2022, the theme being Person-Centric Care, the Sweetest Pill. Without wasting much time, we'll move on to the first session of the day. Lubricate Your Shoulder Joints, Assessment and Management by Dr. Ansi Joseph. Dr. Ansi did her MBBS from Pariyaram Medical College, Kannur, and DPMR from Medical College, Trivandrum. She is a member of IAPMR, IMA, and KGMOA. Dr. Ansi is currently working in Kerala Health Services since 2013. And today we have Dr. Ramakrishna Prasad and Dr. Anup KJ to chair the speech. Dr. Ramakrishna Prasad is board certified in family medicine, ABA from USA, with expertise in infectious diseases and public health. In addition to residency in family medicine, he holds a master's in public health, infectious diseases and microbiology, and fellowships in HIV/AIDS, viral hepatitis, faculty development in family medicine from University of Pittsburgh. Besides significant faculty and leadership level experience in US and India, he has worked in Grenada, West Indies, Honduras, Central America, and Mozambique, South Africa. Currently, he heads the PCMH Restore Health, a patient-centered medical home and incubation center for innovation, people building, and collaborative problem solving. Dr. Ramakrishna Prasad also serves as the Vice President of AFPI Karnataka and the AFPI Chair for Primary Care Research and Policy. He's also associated with several networks focused on leadership in public health. And the second chairperson is Dr. Anup KJ. Dr. Anup has graduated from Alapi Medical College and has completed his diploma in family medicine from CMC Vellore. He has done fellowship in diabetes management from CMC Vellore and successfully completed MRCGP International. He is an alumni member of CMC Vellore FDP. Dr. Anup is currently working as a medical officer, Kerala Health Services, and has over 20 years general practice experience. So on behalf of AFPICON Kerala 2022, I once again welcome our speaker and honorable chairpersons to the session. Over to you, ma'am, Dr. Ansi Joseph.
Good morning, everyone. Am I audible?
Yes, ma'am, you're audible.
So without wasting much time, we can go into our session. Is the screen visible?
Yes, ma'am, it's visible perfectly.
Okay. So once again, good morning. Today, I'm going to present the session on shoulder joint. It's a shoulder pain. Lubricate your shoulder. It is assessment and management of shoulder pain at general practice level. So a few words about shoulder pain. Shoulder pain is one of the more commonly seen symptoms in general practice. And there is an annual incidence in the primary care setting of 14.7 per 1,000 per year, with a prevalence of 10 to 26%, with a slow recovery and recurrence seen in 25%, with a persistent pain seen in 40 to 50% of the patients, and it is more seen in females, with incidence increasing with age. So few words about the anatomy of the shoulder. So as you can see, shoulder joint is a synovial type of joint, ball and socket type, and it is formed by head of the humerus, then scapula, that is a glenoid cavity of the scapula. Then it is also surrounded by acromioclavicular joint, which is also a part of shoulder joint. So shoulder joint is acromioclavicular joint and glenohumeral joint. Then what is important in the anatomy that would help us in assessment of shoulder pain and management is that this is a anatomy that is important. That is, you can see here there's a capsule, and over the capsule you can see the this white area, that's a rotator cuff. Rotator cuff is outside the capsule, that is formed by the tendons of supraspinatus. Anteriorly, this is a subscapularis muscle and forms the it is inserted into the lesser tuberosity. Then posteriorly you can see the supraspinatus, infraspinatus, and the teres minor. All these tendons are inserted into the greater tuberosity. So these all the four muscle tendon forms the rotator cuff, which is a very important structure in the function and stability of shoulder joint. This part is the acromioclavicular joint formed by the acromion of the scapula, and this is the acromioclavicular joint. Okay, acromion of the scapula and clavicle. Then one important structure, that is the axillary nerve, that you should not forget, because usually in trauma this nerve is injured, which is most of the time which is missed in an emergency situation. Then coming on to the etiology of shoulder pain. A shoulder pain can arise from shoulder joint as such. It can be a referred pain from the surrounding structures, and there are some other conditions that can also lead to the presentation of shoulder pain. So what are the causes arising from the shoulder joint? So first, from the glenohumeral joint, we can very commonly seen condition is the frozen shoulder or adhesive capsulitis. Then the osteoarthritis of the shoulder, that is not that common. Then post-traumatic cases, which is very common, acute trauma, post-acute acute traumatic conditions causing dislocation, sprain, then fracture, slap tear, that is a labral tear, superior labral tear, anterior posterior aspect. Then chronic post-traumatic conditions, that is after a trauma, they can lead to post-traumatic stiffness of the shoulder, and there can be associated axillary nerve injury also. All these can cause shoulder pain. Then another condition is the rheumatoid arthritis. Then bony lesions like any tumors or cysts in the, especially in the head of the humerus or in the clavicle, you can see which can give rise to shoulder pain. Then you have to rule out that is infections, any septic arthritis, or an important infection in the Indian scenario, that is a tuberculosis. So you have to rule out that also. Then another structure in the shoulder joint that gives rise to pain is a rotator cuff. It's very common in general practice. So it can be post-traumatic cases like in acute rotator cuff strain, rotator cuff tear. Then it can present as chronic pain in rotator cuff tendinopathy following a trauma. Rotator cuff impingement syndrome is also common, which can be due to repetitive trauma as associated with overhead activity in certain occupations, like offset printing, press occupation, or weight loading in head, keeping both upper limbs up in an upright position. Then in sports like basketball or javelin throw, such sports people also can get this condition. Then if there is a hooked acromion also, there is a chance for getting rotator cuff impingement syndrome. Then another condition is a calcific tendonitis, that is also due to the degenerative changes in the rotator cuff, which cause calcium deposits in the rotator cuff tendon and leading to this condition. Then next is a bicipital tendonitis, a bicep strain. Then subacromial bursitis, inflammation of the subacromial bursa. Then acromioclavicular joint conditions like primary osteoarthritis, especially in overhead lifting activities. Then in secondary osteoarthritis of acromioclavicular joint, usually post-trauma or rheumatoid arthritis. Next section is the referred causes. That is pain arising from the neck. That is cervicogenic causes like cervical spondylosis, cervical disc disease, cervical radiculopathy. Next is a diaphragmatic referred shoulder pain. That is irritation in the diaphragm can cause referred pain in the shoulder. If it is a spleen that is causing the pain, it can be in the left shoulder, gallbladder in the right shoulder. Then pancreas can cause shoulder pain, pancreas diseases, peritoneal abscess. Then also, last but not the least, the referred cause is a cardiogenic cause. You have to rule out an MI, especially in acute presentation, if it is a left-sided shoulder pain. Then other causes, that is one of the most common other causes that is seen is myofascial pain syndrome. That is, a pain is originating from the muscles, especially the trapezius or the scapular muscles. It is also a chronic pain condition. Also, you have to rule out any breast lesions in females. Whenever the females are telling pain in the shoulder, just rule out any breast pathology is there. You have to also consider rarely can be thoracic outlet syndrome or a Pankos tumor leading to symptoms of Horner syndrome. Then rarely polymyalgia rheumatica and fibromyalgia, which are all diagnosis at a later stage of it's a diagnosis of exclusion. Then coming on to the assessment of the shoulder joint and shoulder pain. So when a patient presents with shoulder pain, history is very important because history itself can give a lot of information regarding the diagnosis. First of all is the occupation. Overhead activity is a notorious cause for, especially for rotator cuff pathologies. Then sports activities and other activities of the patient. Then acute, whether it is acute condition, that usually it can be a trauma or then a subacute condition, or if it is a chronic condition that is more than 3 months duration. Definitely rule out any traumatic incident, which is a red flag sign in the shoulder pain. Then about the pain, you have to assess the nature of the pain, how much severe it is, or what are the aggravating, relieving factors of the pain. Especially one important thing is night pain, especially in chronic cases, night pain is predominant, and also a night pain suggestive of tumors or tuberculosis. Then any other joint pain is there, any other joints are involved, you have to rule out any other inflammatory condition, rheumatoid arthritis. Then radiation of pain is also important. One important history that you have to elicit is the movement restriction, which is very prominent. Movement restriction is very prominent. It's a very prominent in a common condition, that is a frozen shoulder. Comorbidities, you have to rule out, you have to ask for comorbidities like diabetes, hypothyroidism, and dyslipidemia, which is specifically associated with the shoulder joint, frozen shoulder. And also you can ask for any history of epilepsy, whether the patient is having frequent epilepsy episodes. Shoulder dislocation is commonly associated in this condition. So this in the examination part, one important thing is you have to look for the tenderness of the local examination is important. Local examination, you have to rule out, in inspection, you have to look for local tenderness, any swellings, local rise of temperature to rule out any infection. Also, on palpation, you have to look for the range of movement activity. Okay, so the range of this diagram shows the range of movement of shoulder: flexion, extension, then hyperextension. This is a adduction, abduction, external rotation, internal rotation. Then one important thing that you should not forget, especially following a traumatic incident, you have to look for loss of sensation over the axillary nerve supply area. That is a military badge area. This is the area that is the lower half of the deltoid area. So if you are eliciting this sign, that is a loss of sensation of over this area, you can rule out axillary nerve injury at the very initial stage itself, and you can give care for the. You can prevent a lot of disability in that. Then one important thing is tenderness over other areas like neck, swelling over the neck. Then any fullness in the supraclavicular fossa that is usually associated with the Pancoast tumor. You can rule out such conditions. Then some specific tests for shoulder. That is an apprehension test. Here you are ruling out any instability in the shoulder, especially following trauma or in an epilepsy patient. You can do this test. That is, this is a position of the shoulder, and by examiner is applying pressure on the posterior aspect of the humerus, and the patient will feel pain and apprehension, suggestive of instability of the shoulder. This is a drop arm test, which is a test for rotator cuff. You are lifting the patient's arm at least up to 90 degrees, and then releasing the arm. The patient cannot hold in the position. The arm will drop suddenly, or at least the patient cannot maintain in that position. So that is suggestive of a rotator cuff injury. Then the painful arc test. So that is on abduction of the shoulder. There is pain. The patient will complain of pain at the between 60 to 120 degree of abduction, and this is suggestive of rotator cuff pathology. Next is impingement test. That is also very important clinical sign. Here, Neer's test. Here, the patient is asked to flex the examiner is flexing the shoulder after internally rotating it. So there will be pain. Hawkins test is also like that. This is a position for Hawkins test. Here also there will be pain due to impingement. This is a speed test for bicipital tendonitis. So just coming on to the algorithm showing the how to assess the shoulder pain, especially arising from the shoulder. So these are the first of all, you have to rule out any instability. Then if there is no instability, you have to locate from where the pain is arising, whether it is from the acromioclavicular joint or whether it is from the glenohumeral joint. That is usually seen in frozen shoulder and arthritis. So there will be global restriction of movement in frozen shoulder and arthritis, especially in frozen shoulder. And external rotation will be mostly affected initially in the frozen shoulder. Then if there is not much restriction in the movement, then you have to go for a painful arc sign and drop arm test to rule out any rotator cuff disorders. Then coming on to the investigations that you need to do in evaluation of a patient's shoulder pain. It is a first and foremost thing is X-ray. X-ray of the shoulder will help you to rule out many conditions. You can take X-ray in an AP view, lateral view, or 45-degree abduction. AP view, one important thing that I need to stress is avoid taking X-ray AP view in internal rotation, because it will give a false appearance of a cyst in the head of humerus. So it is always better to take AP view X-ray in external rotation of the shoulder. Then 45-degree abduction X-ray can in AP view can give us a good idea about the joint space and glenohumeral anatomy. Next is you can go for an RBS, TFT, lipid profile for a shoulder, frozen shoulder. ESR and CRP can be taken if you are suspecting infection or tumor. Then rheumatoid arthritis, if you are suspecting, you can go for RH factor. ECG can be taken if you suspect a cardiogenic cause. USG abdomen for any referred cause from the referred pain. And UST shoulder and MRI, it is a higher level investigations if it is needed, like in rotator cuff lesions or also in tumors. You can go for this MRI and ultrasound. So these are few pictures of X-rays, commonly some commonly seen conditions. It is in rotator cuff tendinopathy. You can see there is a sclerotic area in the greater tuberosity. That is seen in rotator cuff tendinopathy. And this is a picture showing there is loss of joint space and there is sclerosis in the adjacent bony area that is suggestive of osteoarthritis of shoulder. Then there's a diagram of a Pancoast tumor. Then this is a lytic area in the shoulder. So this is also important. Now coming on to the red flags in shoulder pain. This is very important. First you rule out the red flags and then you move on with your further management. So whether there's any trauma, whether there is a tumor, whether there's a chance of there's a possibility of an infection, or whether there is any sensory motor deficits. Now coming on to the management. The goals in management in a general care, in a primary care practice. First of all, you have to properly make the diagnosis. Without making the diagnosis, don't blindly jump into any conclusions and move on with their treatment, because shoulder is a very notorious area for many complications. So next is dealing with the red flags, if any. First, you rule out any red flags and then you move on with your management. The next part is the pain reduction. Pain reduction is also, which is a very important thing, because pain is disabling for any person with the shoulder pain. And return of function of the patient. If the patient is moving on with the condition, then it will definitely cause stiffness of the joint and it is really disabling to the patient. So a few words about the pain management. NSAIDs are the first line medicine that is usually given for pain shoulder, but not beyond 2 weeks, because beyond 2 weeks, if still pain is there, then you need to investigate further to rule out any other cause. So accordingly, you have to go. Then you can alternatively you can give tramadol also if NSAIDs are contraindicated, or if there is severe to moderate to moderately severe pain, tramadol is good if there is no other contraindication for that. Then heat application. You can apply heat in chronic case only, not in acute trauma, or if there is an axillary nerve injury. If you are applying heat to the local area, then there is a chance for burns, because there will be loss of sensation over the area. So these are the conditions, that is in acute condition, and also in axillary nerve injury. If you suspect an axillary nerve injury, don't advise any heat application. Cold application can be done for any acute case, but not in myocardial infarction, especially in the left shoulder. Then a range of movement, that is very important. We have to maintain the movement of the shoulder if you are diagnosing the case as frozen shoulder. Very important, you have to diagnose the case first. If you are so sure that it is a frozen shoulder, you can definitely go for range of movement exercises. That is, you have to maintain the function of the joint, movement of the joint. Definitely immobilization is very important in acute conditions, that is post-trauma conditions. In such cases, if you are not sure, and if you are advising mobilization, rotator cuff tear, injuries like that, then it can worsen the situation. Then one advice that you can give for chronic cases, of, especially if your diagnosis is confirmed with rotator cuff tendinopathy, avoid overhead abduction activities. Then strengthening of shoulder muscles are also important in chronic rotator cuff tendinopathy. One important thing that I want to stress here is avoid advising exercise without confirming the diagnosis, because certain movements, certain exercises are contraindicated in certain conditions. The next is a few tips that you can give to the patient. For any patient with shoulder pain, avoid sleeping on the affected shoulder, avoid weight bearing on the affected shoulder, shift activities to the unaffected side, avoid using pillow in neck problems. You can use a cervical pillow. Avoid, can modify their activities. accordingly. For example, then and in daily living activities, you can advise a patient front zip dress. That is, especially for shoulder, frozen shoulder, it will be very difficult for using back zips or back buckles. So you can advise a patient for front zip dress. These are the few exercises that if you're so sure about the diagnosis of frozen shoulder, definitely you can advise exercise. That is a wand exercise. That is with the help of, you are using a wand, and with the help of a normal upper lip, you are moving the stiff shoulder joint by using a wand. You can do flexion, extension, then external rotation, internal rotation, shoulder abduction, adduction, then scapular exercises, then pectoralis stretch, bicep stretch. All these can be given for a frozen shoulder. Also, this is a very good exercise for frozen shoulder. This is a pendulum exercise. This is the position of the patient, and patient passively, by moving his body, he can passively move the shoulder and maintain the range of movement of the shoulder. This is a wall ladder, finger ladder. That is, the patient can slowly increase the range of movement of the shoulder by using this exercise. Now, a few words about the referral. Now, any acute condition like trauma, you have to refer the patient immediately. And also, if chronic conditions that doesn't respond to initial management or that needs evaluation or rehabilitation, definitely refer the patient to physical medicine and rehabilitation department. There's a PMR department that is available. This department is present in almost all the district hospitals and certain taluk hospitals, and all the medical colleges also. Now, beyond. So, what is beyond this topic, or beyond the session, is the evaluation and diagnosis beyond your general practice level, and where we can try. Diagnosis is frozen shoulder or rotator cuff. You can go for intra-articular steroids. Then rehabilitation with exercises, physical therapy, ergonomics. That is a work site modification. If it is from the work occupation, you can modify the workstation. Then activity modifications can be advised. And later, if nothing is happening with all these conservative methods, definitely you can go for surgical interventions. And thank you for your patience.
Thank you, Dr. Ansi. Thank you, Dr. Ansi, for a wonderful presentation. I was curious. Obviously, shoulder pain is a very common occurrence in clinical practice. In fact, I recently had some shoulder pain, and I was thinking through the differential diagnosis in myself. Can you perhaps use a case in a minute or so? Give us a recent case and how you work through the case, which physicians like myself and others listening will be able to relate to and think through the process using a case. Thank you.
Thank you, sir. Very commonly seen cases of frozen shoulder. So how I approach a patient is, whenever a patient comes with pain, then history is important. Okay, then how one. Okay, I will explain one rare case that I found out in my practice. So a patient came with shoulder pain. It was about 6 months duration. So I was examining the shoulder. I looked for any local tenderness, swelling, etc. So I found a tingling sensation at the Erb's point, that is in the supraclavicular point. And she was also complaining of radiating pain from the shoulder to the upper limb. Then I asked her questions like, was there any cold intolerance? Because the Erb's point Tinel sign positive, that is there is paresthesia or electric shock sensation on tapping the Erb's point, that is supraclavicular point. That is more suggestive of any thoracic outlet syndrome. So I was curious about that. I did thoracic outlet syndrome test, like AdSense test, which was positive. Then Roos test is there, that was also positive. So there was neurovascular compression. So I did a MRI of thoracic outlet. It was positive, and I was referring the patient to medical college cardiothoracic surgery, and she's under their follow.
And thank you
So
so much. I
the,
I'll forget that case ever. It's 9:31, so I'm just wondering if we have the time, or do we have to move on to the next presentation? Perhaps Dr. Shobha or Dr. Krishna or Dr. Anup can guide.
Over to Dr. Anup, sir. Sir,
Okay.
any comments?
Okay. Only a few comments. I think Dr. Nancy has mentioned all the aspects regarding how to manage a shoulder problem at the GP level. And the only problem, I think, with the management of shoulder problems and in general musculoskeletal problems in GPs, the lack of awareness regarding the principles of physical medicine and incorporating into the practice. Most of them are managed not in the rational way. As such, most of the patients seek irrational alternative medicines, and the ongoing the disability seems to be ongoing. So it was a nice talk, and thank you for coming and enlightening us. Okay, we shall move to the next topic.
Thank you, Dr. Hansen.
Thank you, the presenter and the chairpersons. We'll move on to the second session. The second session is Moral and Ethical Values, Basic Bioethics in General Practice by Dr. Shobha P. Dr. P. Shobha graduated from Tirunelveli Medical College and completed her DNP in Family Medicine from Lourdes Hospital, Kochi. She has also gained a postgraduate diploma in Geriatric Medicine from IGNO. She is certified in the AHA's BLS and ACLS courses and has also completed courses in Palliative Medicine and Diabetology and is currently pursuing a course in Bioethics from UNESCO. She holds the MRCGP International and MNAMS degrees. Her special interests are in prevention of lifestyle diseases, primary care medicine, geriatric medicine, adolescent health, and community health activities, including organizing health camps and health awareness classes in schools, colleges, and in community. She is an active advocate against substance abuse and was involved in the formation of anti-tobacco initiative of her hospital titled ATTACK and the hospital's no tobacco policy. She is a life member of AFPI and IMA and now holds the position of Joint Secretary of AFPI Kerala chapter. So I welcome you, ma'am, Dr. Shobha P. And I also welcome the chairpersons, Dr. Ramakrishna Prasad and Dr. Anup KJ once again. Over to you, ma'am, Dr. Shobha P.
Warm greetings of the day. I am Dr. Shobha. I am a consultant in family medicine in VPS Lakeshore Hospital, Kochi. Today, I'll be dealing with the basics of bioethics in general practice. So when we hear the word ethics, a lot of terms comes to our mind. Moral values, honesty, integrity, honor, virtue, conscience, fairness, justice. So many terms comes to our mind. But ethics or bioethics is like an iceberg because only the tip of the iceberg is visible above the sea level. Just like that, bioethics is a very vast subject, the majority of which remains hidden and quite a lot confusing. So what will you be seeing today in this iceberg? We will be seeing the tip of the tip, a few terms, the principles to be followed, steps to solve a dilemma, forming a committee, different dilemma scenarios. The term ethics comes from the Greek word ethos, and morals comes from the Latin word for mores. The root meaning for both is custom, manners, or the disposition peculiar to a given people. Ethics is not a vague subject. It's not about always good. It is not always right. It is not about religion only. It is not going against the law. It is not universal, and it is not only feelings and emotions. Ethics is based on principles. What is good and bad, what is right and wrong. It's based on a value system. It follows the law, follows culturally accepted norms, and it's a science. So then what is bioethics? Moral issues arising as a result of modern medicine, medical research in life sciences will be considered under bioethics. Sometimes non-human biological environment is also included. It studies the philosophical, social, and legal issues, and it can be personal, organizational, institutional, or worldwide. Occasionally, and many a times, it can be life and death issues too. What is medical ethics? It is a study of moral values and judgments or issues in medicine. It encompasses its practical application in clinical settings and its history, philosophy, theology, sociology, and anthropology. What are the examples of research-driven ethical issues? Examples being stem cell research, cloning, genetic engineering, artificial reproduction, etc. Let's see a few of the historical points in ethics. Code of Hammurabi, given in Babylon in 1750 BC, dealt with the punishment given to doctors for wrong treatments. Most of the ancient ethical codes are given as oaths. We have heard of Oath of Hippocrates. It establishes the principles of beneficence and non-maleficence. There is prohibition on giving a potion to induce an abortion and giving any poison to end the life of a patient. It also deals with the sanctity of human life. Over the years, several ethical issues were dealt with as per the norms of the particular period. In modern times, we have heard of the Nuremberg Trials, which was conducted in 1947 against Nazi doctors who conducted heinous medical experiments during World War II. The first modern work of bioethics was written by Joseph Fleischer's Morals and Medicines, given in 1954. In 1962, an artificial kidney center was opened in the US. Here, the renal disease patients were much more than the dialysis machines, and a committee was set up to select the criteria for the selection of patients. Its life and death decisions gave it the name the God Committee. The first heart transplant was conducted by Dr. Christian Barnard in 1967. At that time, respirators were available, which would keep the hearts beating at the cost of the functioning of the other organs like brain. So the absence of all discernible central nervous system activity became a new criterion for death. In 1968, definition of brain death was developed by an ad hoc committee at Harvard Medical School for organ transplantation. If a person is incapacitated by illness, accident, or disease, or in case of premature newborn infant who is unable to say no, does this mean that his or her life must always be prolonged? Selective non-treatment of infants with Spina Bifida, debate about the appropriateness of a quality of life or a sanctity of life came up. The natural history of syphilis was studied in untreated Black men in Tuskegee, Alabama, a very famous case. And in 1972, revelations appeared about the unethical syphilis research. This study was conducted over a period of 40 years in which the Black men were left untreated, even though a very effective medicine in the form of penicillin was available against syphilis. So unethical. No consent was taken. They were not explained about any of the research which was taking place against syphilis. Nothing was explained to the Black men, but they were involved in this particular research study. Patients at the Jewish Chronic Disease Hospital in Brooklyn were injected with live cancer cells without their consent. And mentally retarded children at Willowbrook State Hospital in New York were inoculated with hepatitis virus. So where does the ethics come here? In 1975, a comatose Karen Ann Quinlan, basis of a landmark legal case about removal of life support. In 1978, baby Louis Brown was born. She is the first test tube baby. So here comes the artificial reproductive therapy, ethics related to that. Maybe no landmark in legal and ethical directives about the treatment of impaired neonates. The Belmont report articulated the ethical principles to govern research, respect for persons, beneficence, and justice. The Principles of Biomedical Ethics was a book written by Beauchamp and Childress in 1979. Bioethics is not independent of ethical theories, but it is not just applying a theory. There is an interplay between theory and case study that benefits both bioethics and the case. What are the applications of ethical theories? How can we apply them? It can be either be the straightforward application model. The ethical theory is the starting point. We just apply the theory to the case, or we can also utilize the physics or a car mechanic model in which we know that all of us know physics, and some of us know automobile repair too. But those people who are doing the repair are not actually using too much of physics in their mechanical work. The types of ethical theories are consequentialist theories, non-consequentialist theories, and agent-centered theories. Consequentialism, otherwise known as teleological theory. In Greek language, telos means an end or consequence. So actions are determined and justified by the consequence of the act. Consequentialists consider all the consequences of what they are about to do prior to deciding the right action. This answers the question, what should I do and why should I do it? The utilitarian approach says that we have to give the maximum benefit for the maximum amount of the people concerned. Deontology or duty-based approach. In Greek, deon means duty. This considers that some acts are right or wrong. It is independent of their consequences. This was promoted by Immanuel Kant. Doing what is right is about having the proper intention and doesn't deal much with the end result. Here an example, a practitioner, he has to give the patients detailed information on the pathology of their condition. If the person believes in the consequence of his or her action, he'll be respecting the wishes of the patient because patient may get stressed out, patient may get anxious. So he or she may be revealing that much information which is required. But if the person believes he or she has a duty to reveal whatever is available with her or him, with the practitioner, irrespective of the anxiety of the patient, and considering it as a duty, they may reveal all the knowledge, all the information to the patient. So nothing is right or wrong here, depends on the type of theory which we are utilizing. In agent-centered theory, this tells about the virtue approach. It argues that ethical action should be consistent with ideal human virtues. Its focus is on the character or the goodness of the person, what kind of a person ought to be. This approach is prominent in East Asia, especially by Confucius, to act virtuously in an appropriate manner. Compassion, honesty, prudence, dedication were given importance. Ethical principles. These are autonomy, truth or veracity, beneficence, non-maleficence, and justice. Autonomy. What is autonomy? In this, the patient has freedom of thought, intention, and action when making decisions regarding his health. For a patient to make fully informed decision, he or she must understand all risks and benefit for the procedure and likelihood of success. The right to participate in and decide on a course of action without undue influence from externally. Self-determination, which is a freedom to act independently. Individual actions are directed towards goals that are exclusively one's own. The autonomous person may freely choose loyalties or systems of religious beliefs that may adversely affect him. But the physician has a duty to respect the autonomous choice of the patient, as well as a duty to avoid harm and to provide a medical benefit. But the physician should give greater priority to the respect of patient's autonomy than to other duties. However, at times this can be difficult because it can conflict with the paternalistic attitude of many healthcare professionals. In the case of a child, the principle of avoiding harm of death and the principle of providing a medical benefit that can restore the child to health and life would be given precedence over the autonomy of the child's parents as surrogate decision makers. Truth. Truth always triumphs. We have a duty to tell the truth. We have to be honest because this also helps in autonomy. That is the ability of the person to take a decision, informed decision. Beneficial, above all, do no harm. Avoid harm to the patient or others in society. Interventions create a positive outcome, but may have a harmful effect also. This is called as double effect. For example, use of morphine to alleviate pain, but it can cause respiratory depression. Justice, that is justice deals with the distribution of scarce health resources, the decision of who gets what, treatment based on fairness and equality. Burdens and benefits of new and experimental treatments are distributed equally among all. So the four main areas that healthcare provider must consider when evaluating justice is fair distribution of scarce resources, competing needs, rights and obligations, and conflicts with law. How do individuals decide what is ethical? So we can have either rational approaches like using the various principles, deontology, consequentialism, or principalism, virtue, ethics, etc. Non-rational approaches will be like obedience, following any authority. Blindly, we are following someone who is telling us to do something, imitation of a role model, or it can be just a desire, that is a subjective approach. A gut feeling or our intuition is telling us to do something, or because of habit or past experiences. There is an ethical issue when there are conflicting values, beliefs, goals, or responsibilities. Persons or their rights are not being respected. Fairness and justice is being affected. There is an uncertainty of the right thing or something about morality. The choice between two equal, usually undesirable alternatives. Most moral justifications of research involving human subjects will invoke non-consequentialist principles like respect for autonomy, that is, getting an informed consent, and justice, that is, fair selection of research subject. And consequentialist considerations like benefits and risk to the subjects, obligation not to harm others, non-maleficence, net balance of benefits over harms, that is utility, distribution of benefits and harms fairly, that is again justice, obligations to keep contract, fidelity, obligations for truth, veracity, obligations to disclose information or to respect privacy and protect confidential information. Coming to the framework for ethical decision making in practice, we have to identify the problem. Ethical issue is to be identified, technical facts, moral parameters, legal constraints, relevant human values, and previous cases are studied. Develop an alternative course of action to identify relevant ethical principles for each alternative, recognize ethical assumptions for each alternative, determine additional emerging ethical problems. Select one alternative course for action. Justify the selection of your alternative. Defend your selection upon ethical grounds. Then consider objections to the alternative selected. Objections arising from factual errors or faulty reasoning or conflicting values. Discuss the proposed solution with those whom it will affect, that is, the stakeholders. Make your decision and act on it. Evaluate your decision and be prepared to act differently in future. Coming to ethics committees, decision making in healthcare often involves more than just medical facts in the case, and ethical principles and values will be the determining factor in which course of action is to be taken. Many healthcare facilities are nowadays having ethical committees. It is a multidisciplinary team. It has 12 to 15 team members. There will be a chairperson, 1 to 2 persons from basic medical sciences, 1 to 2 clinicians, staff nurse, 1 legal expert, 1 social worker or representative of an NGO, 1 philosopher or ethicist or a theologian, 1 lay person from the community. The functions of the committee being education to committee members themselves and continuing education and in service to the facility staff and to the community, development and review of laws, standards of care, institutional policies and guidelines and their applications, like say, for example, withdrawing and withholding nutrition and hydration, do not resuscitate orders, utilization of the facilities, resources, etc. And the case consultation is done with family members, patients, healthcare providers, staff, and even the clergy. It may provide information about ethical principles relevant to the case under discussion, help to clarify what options are open, provide information about relevant policies of the facility, and make a recommendation that is advisory in nature. A few ethical questions for discussion are: should children with serious birth defects be kept alive? Should a woman be allowed an abortion for any reason? There can be several reasons. When you take a separate scenarios in its entirety, we can see that we are not able to make a decision. Lady may be going for a divorce. She finds that she is pregnant. She is coming to you when she is about 6 months, 3 months, 4 months. So what we are going to do? What is the ethics behind it? Does the fetus have a right of its own? Does it have a soul? There are several things to be considered. Should organs for transplantation be able to be purchased? Nowadays, we know that organ transplantation is a big business. where lots of money is involved, but somebody is getting financial benefit and some other person is getting an organ by which he can survive. So what are the ethics involved there? Should people suffering from a genetic disease again be allowed to have children, allowed to be married and then have children? Should individuals be allowed to use scarce healthcare resources when death is inevitable? People on ventilators. So what should we do? When is the end of life happening there? Should a parent have a right to refuse immunizations for his or her child? End of life issues are several: advanced directives, surrogate decision making, refusal of treatment, conflicts with caregivers, foregoing life sustaining treatment, DNR orders, etc. This is one case which had come up recently in the Supreme Court of India. Aruna Ramchandra Shanbag, many of us have heard of her, versus Union of India, and the decision is given on 7th March 2011 by the bench consisting of Justice Markandeya Kajju and Gyan Sudha Mishra. The details are given in the link. In this, Aruna Shanbag was a nurse in a hospital in Mumbai. She was raped and she was sodomized by an attendant, and a cycle chain was used to strangle her, and she was left to die. When she was found in the morning, she was unconscious. She came out in a persistent vegetative state, and then she survived for about 40-45 years. But before 2011, one social activist wanted her life supposed to be stopped. But when the Supreme Court of India had constituted a bench of 3 doctors, these 3 doctors found that she is able to respond. She responds to she indicates her wishes. She responds to commands. She makes noises and all that. So in that way, she was allowed. She was not given any. She was not given any right to die. She was allowed to live, and later on, she died a peaceful death due to natural causes. UNESCO has got a very important role to play in the field of bioethics. So UNESCO has given a universal declaration on bioethics and human rights. Here, there are several provisions given in the form of articles like Article 1, which gives the scope for the ethical issues, ethics, which addresses ethical issues related to medicine, life sciences, and associated technologies as applied to human beings. And Article 2 gives in details regarding the aims, like to provide a universal framework for principles to guide the actions, to promote respect for human dignity, and to protect the human rights. And several other clauses are also given. The principles being Article 3 deals with human dignity and human rights. Article 4 deals with benefit and harm. Article 5, autonomy and responsibility. Article 6 deals with consent. Persons without the capacity to consent are coming under Article 7. Article 9 tells us about privacy and confidentiality. Article 10 deals with equality, justice, and equity. So all the other articles up to Article 17, then Article 18, 19, 20, 21 deal with the application of the principles. Specifically, Ethics Committee is being dealt under Article 19, and promotion of the declaration is coming under Articles 22 to 25, and the final provisions being given under Article 26 to 28. So I am now coming to the end of my presentation. Thank you for your patient listening.
Thank you, Dr. Shobha. We have, I think, 5-6 minutes. I'm going to ask you a similar question as I asked the previous speaker. Can you share with us a recent case scenario where you were confronted with an ethical dilemma, and how did you approach that?
Yes, Dr. Prasad. Usually what happens is on patients on ventilators, it's very difficult for us to make a decision. Like the patient's family members would want the patient to be on the ventilator for a long duration of time. They don't want the supports to be removed. But at the same time, 1 or 2 persons, maybe their relatives may be there. They may be thinking an aspect of the financial disadvantages, liabilities. They have to even sell their houses or even land, etc. So how we can go about this? So sometimes what happens is the patient himself would have indicated something to the relatives. Like he would have told something that I don't want to die a very dog's death sort of thing. He doesn't want to burden other people, his relatives, etc. So if you're having some sort of an indication like that, we can go by that. Or suppose if there is no such indication, then we have to. It's a very difficult process because once the patient is on ventilator, his heart is beating, his brain functions are minimum functions are there. So we're not able to take a decision at all. So what we do in that case is we have to balance the benefits, the beneficence, as well as the non-maleficence. Like in Aruna's case, when we are examining that bench of neurologists had examined her in detail, they were able to find that she is able to make some, she can give some indication. She's not on ventilator, of course, but I'm just saying, I'm just extending that. She is able to give some indication by grunting, by making noises. We just can't say that she is not alive. She has that life. Similarly, the patient on the ventilator is also having some heartbeat is there. So we just can't remove that support. So that is where this the topic of euthanasia also becomes relevant. Passive euthanasia will be withdrawing the support. Active is like we are giving something to kill the patient. It's a very difficult situation for us to analyze. But we have to balance the benefits, risks, as well as the autonomy of the patient, what he or she may have expressed previously. So in that manner, we have to keep on developing new alternative plans. As I had mentioned in the solving of the ethical dilemma, we have to keep different plans of action. So by that means only we can reach to a final decision whether to do, whether to take a particular action or not.
Thank you, Dr. Shobha.
Yes, thank you.
Okay, I'd like to add some comments regarding ethics and about ethics and the general practice.
Sure.
What I find is that applying ethical practice principles in the general practice in clinical scenario in Indian aspect is too complicated due to the low awareness among doctors and patients, and obviously the lack of patient-centered care. Even in properly run family practice, it is a challenge, and the right to privacy of the patient is still not a reality, I feel. And in complicated cases like discussing cases like sexually transmitted disease in families within the framework of bioethics is very much challenging. And it is these topics are rarely discussed in conferences like this. And I like to thank Dr. Shobha for selecting it and enlightening it about it. Thank you.
Yes, thank you. Thank you, Dr. Anup. Yes, I would like to add this point here. Here, you can either think it in the terms of your duty, that you have to explain the whole condition to the patient. The patient may become anxious, the bystanders become anxious, etc. But you are not worried about that. You are taking it as your duty to explain everything. It can be either that, or you can make use of the other theory, that is consequentialist theory, where you are concerned more about the end result also. So this is all a kind of a balancing situation. Ethics is basically more or less a balance of various factors. That is, it's very important for us to know that, and to learn that, how to balance that various, using the various principles, using the various methods. Yes, that's important. Thank you, Dr. Anupan. Thank you, Dr. Prasad.
Thank you.
Thank you, Shobha Madam, for that wonderful talk. I would also like to thank Dr. Ramakrishna Prasad and Dr. Anup KJ for their valuable comments. Next, we move on to the next session. We move on to the next session, which is Catching the Crab Early, Guidelines for Early Cancer Detection in General Practice. And the speaker is Dr. Matthews Marine Matthews. Dr. Matthews did his MBBS from the Government Medical College, Kottayam, and DNB Family Medicine from the Lutz Hospital and Postgraduate Institute, Kochi. He has worked with WHO as an external monitor for pulse polio immunization in Idukki district in 2015 and was part of the organizing committee AFPICON 2019 and 2020, and also part of the Skill and Aid in Surgical Workshop AFPICON 2020. He has received accolades for the second best undergraduate project in community medicine and has received the Young Doctor Award at AFPICON 2019 and FMPC 2019.
Dr. Matthews was first in the quiz competition AFPICON 2020. Now, along with pursuing MA in philosophy from the Christ University, he works as a consultant for the Snehagram project of chameleons, taking care of the medical needs of children affected with HIV. He was active in online and offline consultancy by the AFPI Task Force, Health Bangalore and Bengaluru Archdiocese during the COVID pandemic. Dr. Matthews is very much passionate about family medicine and providing care for the marginalized. I also invite the chairperson for the session, Dr. Danya S. Pillai and Dr. V. Srinivas. Dr. V. Srinivas is a family medicine physician located in Hyderabad city, and he studied MPBS at the Osmania Medical College and later joined the Durgabai Deshmukh Hospital and Research Center at Hyderabad and successfully completed DNB Family Medicine in 2008. He continued his professional studies and received PDDHS Diabetology and PDDCC Clinical Cardiology in the FCGP. Recognizing his services, he was appointed by the NBE as the chief examiner for the FAT practical examinations in the area of family medicine. He was also faculty for the DFM and FCC courses conducted by the Apollo Midvarsity. He published several articles and recently co-authored a book entitled Family Medicine 5 Minutes OSCE for DNB 2020. In 2004, the Indian Medical Association recognized him as the best student in FCGP, adult immunization and surveillance, screening of cardiovascular risk factors in primary care, assessment of metabolic syndrome in primary care are some of his areas of interest. At present, Dr. Srinivas is the president of AFPI Telangana State Chapter and also a member of the National Executive AFPI. He is also the Director, Academics of AFPI. Dr. Danya S. Pillai is currently acting president of AFPI Kerala Chapter. She is a founder secretary and a past joint secretary of AFPI Kerala Chapter. She is a member of the Geriatric Society of India and Indian Academy of Palliative Care. Dr. Danya is interested in promoting and teaching primary care with special interest in geriatric care. She has worked in India and abroad as a family physician, presently working as consultant geriatric and family medicine, SP Fort and SP Wellford Hospital, Trivandrum. Over to the speaker, Dr. Matthews.
Am I audible?
Yes, you're audible.
Okay, I'm sharing the screen.
Okay, yeah, it's loading.
Okay.
And now it's visible. Can you please make it into full screen? Yeah,
Yeah,
perfect.
yeah.
Thank
Okay.
you.
Good morning, all. Today our topic is catching the crab early. I have some brothers from the fishermen families, and they tell me catching crab is very tricky. The first thing that you have to do is take hold of the pincers and tie them off, so that otherwise you will get a tattoo for sure. As family physicians, it is a similar scenario with cancers. What we have to do is that we have to recognize early, we have to screen them, otherwise our patients will suffer. We have a lot of ground to cover, so let us proceed on. And our Murtag starts on the chapter of prevention with this quote from Louis Pasteur. When meditating over a disease, I never think of finding a remedy for it, but instead a means of preventing it. Screening is secondary prevention, and it can be compared to sieve model, where we pick up patients from a common general population in the pre-symptomatic phase, either people with disease or people with risk we are taking, and further we are administering diagnostic test after screening so that we can pick up the disease. Principles of screening was initially given out by Wilson and Junger in 1968 and was taken up by WHO. It gives the guidelines regarding which diseases can be screened. The first thing is that the disease should be an important health problem, and the natural history of the disease must be well understood. It should be recognizable at an early age. The treatment should be better if we pick up the disease at an early age, and suitable and acceptable screening tests should be present. And if we pick up the disease, adequate facilities should be there to cope with the disease. And for incidence onset of diseases, we have to screen them at intervals. And one of the most important thing is that we have to do less harm while screening the disease, as well as we have to think about cost. Cost should not overcome the balanced against the benefit. And this is from our own Rakel. It says that even though we have more time, we should not screen for every disease that is under the our scenario, because when we screen a population, we have negative and positive results, and appropriately we can give assurance to the patient, but there is also chance of of false assurance, unnecessary investigations, unsuccessful treatments, and like that, there is overdiagnosis and overtreatment. So we have to be careful which all diseases we are going to screen. Coming to Indian cancer scenario, we know that there are cancers which are screenable, and in Indian cancer scenario, Globocan 2020 mentions that it is breast cancer which is most prevalent, followed by lip and oral cavity cancers and cervical cancer, then lung and colorectal. When coming to male population, it is lip and oral cavity cancers, followed by lung, stomach, colorectum, and esophagus. In females, as we know, it is breast cancer which is most common, followed by cervix, cervical cancer, ovary cancers, oral cavity cancers, and colorectal cancers. And a word about literature in screening in family practice. Primary care providers, we are the links of between the population and much of the rest of the health sector. We give timely, appropriate care. And research from Australia as well as Malaysia gives us that 85% of cancers are diagnosed by primary care provider, and almost 60% of patients in a survey reported that they are more likely to screen when reminded by their GP. So RACGP puts down reminders are the only prevention rated as very effective. If we remind the patients, they will screen. 5-year survival rate of a cancer is almost 90% if screened very early, but if screened late in the metastatic age, it comes down drastically to 21%. So which cancers need to be screened? According to the screening principles that we mentioned, these are the 4 questions that we should ask. Does the cancer have serious side effects? Is there a detectable and long preclinical stage? If yes, will treating of the cancer improve the outcome? Is that treatment available and accessible to the population? Now coming to the first cancer, which is screenable, that is breast cancer. In India, every 4 minutes, one woman is diagnosed with cancer, breast cancer. 1 in 28 women is likely to develop breast cancer. It becomes 1 in 22 in urban population. 37.7% newly detected cases are in 25 to 49 age group. And compared to Western population, we have reduced survival, increased incidence, and younger age. Coming to cancer screening, the first thing that comes to our mind is clinical breast exam and self-breast exam. There is a contradicting evidence between Indian studies and Western studies. In Western studies, they are showing that there is no clear benefit of either CBE or self-breast exam. They even recommend against this. But in Indian scenario, there were 2 RCT trials, Trivandrum and Mumbai RCT trials, and National Cancer Grid recommend CBE in age group 40 to 65 years every 2 years, or at least 1 to 3 times in life. It is valuable, practical, and cost effective. So our position should be, we should not overly emphasis on cancer breast screening, but we can give a breast awareness through teaching them the nature of their breast, and they have to come seek clinicians' help if they find any change. So in examination, we have to examine, we know the routine breast examination, breast, axilla, and nodes. We have to examine any areas of abnormality we have to look out for. We have to visually examine as well as palpate in multiple positions, and we have to look for lymph node examination, and we have to give light, medium, and deep pressure while examining. And it is better to go in a vertical strip direction. Start at one end and go in vertical strip pattern. And we have to palpate with 3 middle fingers in dime-sized circles. This is the ideal examination pattern. Coming to the king of breast cancer screening, that is mammogram. Mammograms are low-dose X-rays of breast. But most of our young women have dense breast tissue, as seen in the mammography picture shown here. It is very hard to recognize changes, early changes of cancer in a dense breast tissue. In that, we now use full-field digital mammograph or 3D mammography, tomosynthesis, where it is more sensitive to even in dense breast tissue. And in dense breast tissue and in young young females, we can go for ultrasound imaging as well. We can combine ultrasound with mammogram. We have to get the report together. MRI scans may be used, but it is always used in addition to mammogram. And it is better to opt, all the evidence suggests that it is better to opt for them only with high risk of family history and with a high genetic risk. WHO is against promoting population-based screening in breast cancer. So they are dividing it into average risk, moderate risk, and high risk. Average risk is basically without a family history of breast cancer. Moderate risk is without a proper high risk family genetic history or family history, but one of the relatives, some of the relatives have been diagnosed with breast cancer. And potentially high risk is with high risk of genetic incidence, and many relatives on the same side are diagnosed with cancer in younger age group, and male relatives are diagnosed with cancer and with breast cancer and ovarian cancer together. And there is definite evidence of gene mutation. And what are the guidelines in mammogram screening with mammogram? In average risk, it is recommended that all the guidelines recommend that mammogram is done every 2 years from age 50 to 74 years. And only American Cancer Society recommends it from 2 yearly from age 55 years. Before that age, 45 to 55 years, American Cancer Society recommends every year. And we have to associate it with breast awareness. We have to educate them regarding the nature of breast changes in the breast. In moderate risk cancer, it is in the same age group, 50 to 74 years, it is recommended that mammography is done every 2 years. And in those women with moderate risk, if a woman has a first degree relative age less than 50 years diagnosed with breast cancer, we have to do screening annually from 40 years. In high risk patient, it is always individualized care, and we have to start screening at 30 years, and including regular clinical breast examination, annual screening with mammography, MRI, or ultrasound, genetic testing, and we can even go for chemoprophylaxis. And this is a study that I have mentioned, a BMJ study showing that those with high risk genetic mutation, BRCA1 or 2 mutations, before the age group of 30, before 30 years, it is risky that we give them mammography. So MRI is better preferred in that age group. There is 100 patient screening results available in Canada Task Force reports. In that, it say that there is benefit definitely, but there is also a risk that we have to explain to the patients. Every 2,000 women screened over 10 years, one will avoid dying of breast cancer, but every 10 healthy women will be treated unnecessarily in the, when 2,000 women are screened. An extra 200 women will experience important psychological distress. So this points to the fact that we have to explain both the risk and benefit while screening. Coming to carcinoma cervix, India accounts for 1/4 of global risk of carcinoma cervix. Every 8 minutes, one life is lost. And cervical cancer screening is very low in India, almost 2.6 to 6.9% only. And we know that there is a long natural history, so it becomes an ideal cancer for screening. HPV infection, most of the women, now almost 90%, heal within 2 years. After 10 to 30 years, the rest of the population might go into metaplastic change, and 0.8% develop a cancer. So this long period of natural history is there. So we have to screen. Treatment of precancerous lesion will reduce cancer-specific mortality of cervical cancer by 20 to 60%. Screening every 3 years reduce the risk of cancer by 70%. If caught at earliest stage, chance of survival is more than 85%. And even once in a lifetime screening between 30 to 49 years prevents 40 to 50% of cervical cancer. This is why we have to screen. And what are the screen tests available? We know that cytology is there, pap smear and liquid-based cytology, visual inspection with acetic acid and leukocytin is there, and molecular tests are there, HPV testing is there. So in conventional cytology, we know this diagram from our MBBS days. There is squamous columnar junction with high metaplastic changes. From there, we are exfoliated cells are taken, and in a pap smear, we are staining them in a slide, and we are looking under microscope. This is a normal look of cervical os area, squamous columnar junction. And liquid-based cytology, liquid medium is centrifuged, and the cell sediment can be taken for microscopy, and supernatant may be used for HPV testing. We are familiar with pap smear. I'm not going to details of how to take a pap smear. It is available in YouTube also. And it is classified based on Bethesda and WHO classification. And coming to visual inspection with acetic acid and leukocytin, acetic acid will coagulate those areas with high chromatin, and it will give an aceto-white stain, and the blood vessels cannot be seen. In the first picture, we can see that blood vessels can be seen. This is normal squamous columnar junction, whereas in the second picture, we can see white aceto-white area, a coagulated area, which is abnormal. And in the third picture, that is staining with leukocytin, all the area with glycogen-rich cells, squamous epithelium, will stain mahogany brown, and all the areas with metaplastic change will stain mustard yellow. And coming to molecular testing, HPV testing is mandated in women more than 30 years of age. Why this age group? We know that HPV infection is common in younger age group, but it resolves in most of the women. That is why we screen more than 30 years. Even a single round of HPV test followed by appropriate management of the screen positive women could reduce the cervical cancer mortality by 50%. High negative predictive value is there for the test. So prolongation of screening interval up to 10 years is possible if we are using this test. We usually screen for DNA, mRNA, and protein. And what are the American Cancer Society guidelines? They suggest that every 3 years, at least by the age of 21 years, we have to screen for cancer. And less than 30 years, it is pap smear yearly or liquid-based cytology 2 yearly. More than 3 years, if we are getting 3 consecutive negative pap smears, we have to screen every 2 to 3 years after that. And after at 70 years, if we are getting 3 consecutive normal pap smear and no abnormal results within past 10 years of screening, we can stop screening. After hysterectomy, there is no need for screening, except in women with previous reports of CAN 2 to 3. There we have to continue screening for, until we get 3 consecutive negative results. We know that I have already mentioned that the cancer screening in India is very less. That is why National Cancer Grid India is recommending limited and narrowed down guideline for limited and optimal resource settings. Our target is 30 to 65 years. Test with BIA and HPV DNA if possible. And at least 1 to 3 times in a lifetime, we have to screen. And if we are getting 2 consecutive negative tests in 5-year intervals, then after that we can screen every 10 years. And at 65 years of years or older, we can stop screening if we get consistently negative results over past 15 years. If the testing is negative, we can follow up in 12 months. And if it is abnormal, we have to go for colposcopy. And according to specific tests that are used, if we are using VAA, if it is negative, routine screening every 3 to 5 years. And if it is positive, definitely management and follow up with VAA after 1 year. If HPV DNA test is used, if it is negative, we need to screen only after 5 to 10 years. If it is positive, we have to go for cytology, colposcopy, or VAA, and accordingly we have to treat and follow up with HPV testing after 1 year. And coming to cytology, if it is normal, we have to go to routine screening every 3 to 5 years. And if it is positive, we have to go either for colposcopy. If less risk lesions are found, we have to go in for routine screening. If high risk lesions are found, we have to give definitive treatment and then follow up. Then colposcopy is negative, we have to go for routine screening. Then if we are suspicious of high risk malignancy, we have to go for definite management. Coming to oral cancers are also at the rise in our population, especially in people who use tobacco, alcohol, arachnid, betel quid, with or without tobacco, HPV infection. These are all high-risk population. And in this population, we have to screen for cancers. It is the simplest screening available. Only we have to look we have to give a proper oral visual examination in good lighting. We have to look out for hidden areas, gums, teeth, lateral tongue margin, soft palate, and floor. And we have to pull tongue side to side. If you are doing this simple test, visual examination, we can reduce the cancer up to 34%. That is through random study. And what are we to look for? These are the pre-malignant lesions we have to look for. First one is leukoplakia. We know that it is a white, patchy, plaky, similar to orocandidiasis. But in orocandidiasis, we can flake away the lesion and we'll get a bleeding mucosa underneath. In erythroplakia, it is red plaque-like appearance we can see. And oral submucous fibrosis is very common in North India, where betel chewing is common. But since migration is happening, we can also find that very commonly in Kerala population also, where the patients will present with marked trismus. And it is very hard to open. And when we look, there are lacy bands inside the mouth, white bands. And non-healing ulcers, especially those ulcers which are not healing after 3 weeks, 21 days, we have to be suspicious and we have to take a specimen for a definite diagnosis. Along with that, we have to go for suspicion. We have to counsel against substance abuse and also teeth and mouth self-examination along with screening. And National Cancer Grid recommendation is that in age group more than 15 years, we have to screen. And frequency of screening is at least 1 to 3 times in life and every 5 years, preferably every 2 years. If negative, we have to review in 12 months in risk population. And if positive, we have to confirm by punch or excision biopsy. Now coming to colorectal cancer, it is also in rise in India, but we don't have specific cancer screening guidelines in India. So I am taking from RICGP, Canada Task Force, and NICE guidelines. They strongly recommend for asymptomatic adults to be in the age group of 50 to 74 years who are not at high risk for colorectal cancer to be screened with fecal occult blood testing, either guaiac-based or fecal immunochemistry test every 2 years, and a flexible sigmoidoscopy every 10 years. And for high-risk population, that is with previous colorectal carcinoma or polyps, inflammatory bowel disease, signs and symptoms of colorectal cancer, family history of colorectal cancer in one or more first-degree relatives, or adults with high-risk hereditary symptoms like familial polyposis coli or Lynch syndrome, they advise screening with colonoscopy and genetic testing. Now coming to lung cancer, it is also very common in India, but we don't have any screening guidelines. United States Preventive Services Task Force advice for in the age group of 55 to 74 years, in those with 30 pack-year smoking history, or those who have quit less than 15 years ago, they recommend annual screening with low-dose CT up to 3 consecutive years. In all other age groups, they do not recommend for any screening. And prostate cancer is a highly debatable area. And at present, no guidelines recommend for prostate screening in age group less than 55 or in any age group. In less than 55 years or more than 70 years, they do not. There is strong recommendation against. In age group in between 55 to 69 years, then there is a weak recommendation against. That is, if at all we are screening, we have to discuss with the patient very much, because there is no added evidence of added mortality benefits in screening prostate cancer. And what about tumor markers? What are the tumor markers that we can use? Only alpha-fetoprotein is used for screening. That is, it should be measured 6 monthly in those at high risk in hepatitis B or C cirrhosis. This is BMJ review. No other tumor markers are used for screening. Coming to the end of the session, the cancer miracle that we look for, it is not cure, it is prevention. Cancer is becoming the leading cause of death in our country, and then cancer prevention will become our leading cause of life. And as early as 1907, Dr. Charles Childe says about cancer screening, we have to pick up cancers early, and that is a treatment, that is a cure, that is we are getting. In the Alice in Wonderland, there's a dialogue between Red Queen and Alice. Alice is worried about she's not getting up to the mark when running. And she says, now here you see, it takes all the running you can do to keep in the same place. If you want to get somewhere else, you must run at least twice as fast as us, because this is another country. So our country is changing. Cancer is on the rise. If we are to pick up pace with the cancer, as family physicians, we have to screen in much efficient way. We have to know what to screen, what not to screen. Thank you.
I invite chairpersons to discuss on the session.
Thank you very much. Yeah, it is very, Dr. Matthews has dealt very elaborately. Am I audible, madam?
Yes, sir.
Yes,
sir.
you're audible.
Yes, yes. Dr. Matthews has dealt very extensively and comprehensively, and it is really very, very informative. Actually, such topics should be should be presented in every state, either both in the state and national conferences. If he hasn't, Matthews, did you register for our national conference? You present it. It's a very wonderful presentation.
Thank you, sir.
You have dealt regarding the basics of principles of screening, and along with that, Indian cancers scenario of various common cancers and the screening in family practice, and along with these American Cancer Society and Canadian Task Force guidelines and Indian guidelines also he dealt very extensively. Regarding one addition, even in such presentations, we can, even though it doesn't come under screening for the detections, you must deal with HPV vaccine, because there are so many doubts. Gardasil, Cervarix, is Gardasil 9 is available or not? Whether boys can be given this cervical vaccine. Though that may be included, I suppose, but that it is out of exact in this settings. So may I know what is your outpatient, when you are working in outpatient, what is your experiences, and do you suggest any health packages? Because the awareness, increase the awareness of the public is very important, and modify the lifestyles, because suppose in case of lung cancers, we should ask them to stop smoking, and several posters, leaflets, all these information, IEC activities, information, education, and communication activities are also very important. Any health packages you suggest? And in one of your slides, in American guidelines, you mentioned 30 pack years. I don't know, is it the latest guideline? Is it 30 or 20? It's very nice. Thank you very much, Matthews. Dr. Danya, could you please add, because there are no questions in the chat box, I think. If any, you just please add.
Matthew, am I audible?
Yes, madam.
Yeah, it was an excellent presentation, Matthew. I mean, you have touched the important points of the basics of cancer screening. Again, like what Sir was asking, would you be, screening patients or doing some health packages or so when a patient comes to you? Especially we have in Kerala or in the southern part of the states, a lot of people come asking for, having a doubt in their mind that, do I have cancer? What are the tests we need to do? Basic things we need to do to detect whether we have any type of cancer. It's a very common question we find in the OP.
I think, Madam, I think Sir asked one question. I have to clarify. It is, I think it is 30 pack years itself, sir. If I check I have taken from any guidelines. It is, it is a U.S. Task Force guideline. United States Preventive Services Task Force guideline. They have mentioned 30 pack years, sir. And in India, we don't have guidelines specifically for that. And regarding any package, just do I suggest, because all the screening now, people are much worried about whether we are over-diagnosing and over-treating also. All the guidelines outside India suggest that we don't have to go for routine population-based screening. We have to discuss with the patient. We have to alleviate their concerns on the basis of evidence. So in our population, I think those people we have to pick up, especially breast cancer is, if we take one cancer, breast cancer, it is the most commonest in women. We have to screen those people who are at high risk, because if we have to take a proper family history, if we might not go for genetic testing. Genetic testing is only for those less than 1% only of women are having genetic predisposition. High risk comes under high risk category. So in those only we have to go for genetic testing. That also we have to do it early. But all others we have to take a proper family history and then screen. And for cervical cancer screening, it is mandatory that we have to pick up cervical screening. And because our cervical screening is very much less, we have to implement that at least 1 to 3 times in a lifetime can drastically reduce cervical cancer. Once it comes, it is very hard to treat, as we know from our own practice. And do I see regular patients in cancer? No, my practice is very small and more with HIV care. So HIV-based children. So I don't see routinely. But lung cancers, I have seen in population with smoking history, and oral cancers also are very common in people with coming with persistent bitter chewing. That is what I think. Was I clear, sir? Madam?
Yes, yes. Yes, it's very clear. And
Don't have any questions on the chat box. No questions.
Matthews, one aspect I feel, even endometrial cancer also should be added. And even though it is in the detection of the cancer guidelines of American Cancer Society, endometrial cancer is been added. And in my experience also, there is no proper guidelines and coordination. And if there is a vaginal bleed, and if the patients come to go to the gynecologist, they themselves do science and do the hysterectomies. They do the biopsies. Sometimes the case gets missed, and they don't even ask for a CT scan or PET scans or even surgical oncologist, because we do before doing the surgery, we don't know where the lymph nodes are affected or not. Because on the table itself, sometimes we may have to send the sample, and so many things are being missed, and so many lives are lost. This is also, I feel, endometrial cancer is also one of the important aspects. It is being missed by the gynecologists, actually.
Father, sir, can I add one resource? That is, RICGP has a green book and red book. It is very useful for us, whom we have to screen. It is a very good resource for knowing more about this, I feel.
Okay, thank you, Matthews. Dr. Danya,
Thank you, Matthews.
As there are no questions in the chat box, shall we move on to the
next session?
Thank you, Dr. Matthews. That was a very crisp, informative, and comprehensive session. Next, we'll move on to the next session, which is Nocturnal Aneurysis, Managing the Parent and the Child by Dr. Ali Zamil. Dr. Ali Zamil graduated from the KSH Medical Academy, Mangalore, After working a couple of years as a registrar in internal medicine at Dhanalakshmi Hospital, he completed his post-graduation in community medicine in 2015 and then PGDFM from CMC Vellore in 2017 and MRCGP in 2019. He has served as family physician at KMCT Medical College, running the Urban Health Center and the Fast Track OP for the 5 years. Dr. Ali is currently working as a consultant family medicine and Chief of Staff at the Mitra Care Clinic, Kasaragod. Over to you, Dr. Ali Zamir. And I also invite the chairpersons for the session, Dr. V. Srinivas and Dr. Danya S. Pillai.
Good morning, everyone. Is my screen?
Yes, it's visible.
Can you see the slides?
So press that third option, just slightly left of the play button. The third one, yeah.
Yeah. Is it visible now?
Yes, it's visible.
Okay. Good morning, everyone. I would like to, at the outset, I would like to thank AFPI Kerala for giving me this opportunity to present this interesting topic during this August conference. Thank you. So without wasting much time, we'll directly jump to the topic. It's quite an interesting one, nocturnal aneurysis. So we'll be looking at what nocturnal aneurysis is, how to approach a child or a patient with nocturnal aneurysis, and how do we manage these children and also the parents, because it's the parents who usually come with the anxiety and difficulties in managing these children. So moving on. What is aneurysis? Like most medical terminologies, the word is actually derived from a Greek word, aneurin, which means to void urine. Basically, aneurysis is the act of involuntary urination, which can occur either during during the daytime or at night. The International Children's Continence Society describes aneurysis as discrete episodes of urinary incontinence occurring during sleep and in children aged 5 years and above. According to the DSM criteria for diagnosing aneurysis, they say that the following criteria has to be met. That is, repeated voiding of urine into bed or clothes, whether involuntary or intentional, and the behavior either occurs at least twice a week for at least 3 consecutive months or results in clinically significant distress or social, functional, or academic impairment. And this behavior occurs in a child who's at least 5 years old, and this behavior of aneurysis cannot be attributed to the physiological effects of substance, a drug, or any other medical condition. And if you see that, if you look at how normal continence is achieved in children, usually the continence is achieved during the daytime initially, and then later they move on to develop continence at night. So by the second year of life, children usually have the ability to control the external urethral sphincter voluntarily, and they can initiate voiding even in the absence of the desire to void. And by 4 years, most children with normal bladder function would have acquired this ability. Now, this is again showing the percentage of children who achieve continence by day and night at various ages. So we can see that by 3 years of age, most children, majority of them, 98% are dry by day, achieve continence during the day, and around 78% are dry by night. And if you look at the epidemiology, by 5 years of age, around 15 to 25% of children still wet their bed. And as the age increases, or with increasing year of maturity, the number of the prevalence of bedwetters decreases every year by 15%. And by the age of 12 years, around 8% of boys are still aneurytic and around 4% of girls are aneurytic. Now, from this, we can make out that aneurysis is more common in boys rather than girls. And by adolescence, only 1 to 3% of adolescents still wet their bed. And among these children who are aneuretic, that is 15 to 25% of children who are aneuretic, among them, around 15 to 25% have secondary aneurysms. But invariably, the treatment for secondary aneurysms and the approach and management remain similar to primary aneurysms. Now, moving on to what are the types of aneurysms. So, as said earlier, it can occur during the night time or during the daytime. So, based on that, it can be called as nocturnal aneurysis or diurnal aneurysis. And if it's occurring both at night and during the daytime or during the waking hours, it's called nocturnal and diurnal aneurysis. Now, also known as non-monosymptomatic. We'll have a look at what that means. So, again, it can be classified as primary aneurysис and secondary aneurysис. Primary is when the child has never achieved continence. And secondary aneurysис is when the child has had a period of dryness at least for 6 months, and then the child starts to have the episodes of aneurysис. So I have mentioned non-monosymptomatic and monosymptomatic. So these are another way of classifying aneurysис. So monosymptomatic aneurysис means in children without any lower urinary tract symptoms and without any history of bladder dysfunction, whereas non-monosymptomatic means in children with other lower urinary tract symptoms. They may have other underlying pathologies. So moving on to what are the causes of aneurysис. So primary aneurysис, the usual majority of the time, it is idiopathic. So if no cause can be identified, the important pathophysiologic factors include a disorder of sleep arousal, nocturnal polyurea, and a low nocturnal bladder capacity. So disorder of sleep arousal studies reveal that children with aneurysис do not wake up normally in response to an auditory signal. So this finding confirms a problem in sleep arousal. Nocturnal polyurea. Again, there are some studies which say that nocturnal polyurea is seen in some children, but not all. And although nocturnal polyurea is important in the pathophysiology of aneurysис, overproduction of urine per se cannot be the sole causal factor. So nocturnal polyurea in children with aneurysис may be multifactorial. So possible causes for nocturnal polyurea include increased fluid ingestion from the time a child arrives home from school through the afternoon and evening to bedtime. We have seen that most children who come back home are hungry and thirsty. That is because they don't maintain adequate hydration during the school time, and also many children avoid eating during the daytime at school and come back home and have their water and food. So reduce fluid ingestion from the time child wakes up through the wakes and through the school day. Low nocturnal secretion of ADH. Now that is seen in some children with aneurysис, not all. And increased nocturnal solute secretion. That also occurs when the child is eating more towards the evening and the night time. Another factor is small nocturnal bladder capacity. Small nocturnal bladder capacity is also now known to play a role in the pathogenesis of aneurysис. The other cause for primary aneurysис could be overactive bladder or dysfunctional voiding. Now, this is more common in among girls in preschool or elementary school, and they usually present with urinary frequency, urgency, squatting behavior, and daytime wetting and aneurysис. Now, this squatting behavior is a common and distinct symptom of overactive bladder or dysfunctional voiding, and it is a learned response in an attempt to suppress an unexpected and unwelcome detrusor contraction. The other thing is, the other cause could be cystitis. Again, infection. There may be other signs of infection in cystitis, and it is a common cause of aneurysис and an aggravating factor also associated with other causes. And cystitis can, as we all know, can present at any age. The other thing is constipation. Constipation is again could be a common cause for aneurysис. So these children could also present with fecal encopresis or fecal incontinence. So constipation can cause both primary and secondary aneurysис, and is also a common aggravating factor that should be considered when other causes are present. The other cause could be a neurogenic bladder. It can result from a lesion at any level in the nervous system, including the cerebral cortex, the spinal cord, and the peripheral nerves. As many as 30%, 37% of children with cerebral palsy have aneurysms. So patients with myelomeningocele almost have always have aneurysms. Other spinal cord abnormalities can also present with aneurysms. The other cause could be urethral obstruction. It can be congenital, as with posterior urethral valves, congenital stricture, or urethral diverticular, or it could be acquired, as with a traumatic or infectious stricture, or with meatal stenosis after circumcision. The other cause could be an ectopic ureter or diabetes insipidus. Diabetes insipidus is actually a very rare cause. Ectopic ureter is due to the insertion of the ureter in a location other than the lateral angle of the bladder trigone. And last but not the least, psychological. I have put this cause as the last one in primary aneurysms because the psychological effects are usually due to the aneurysm itself, rather than the psychological problem causing the aneurysms in primary aneurysms. So moving on, secondary aneurysms. Secondary aneurysms, as I mentioned earlier, is seen in children who had already had a period of aneurysms and then, continence, and then they develop aneurysms. Again, I have gone through all these earlier because the causes are similar. So sleep disordered breathing is another cause for secondary aneurysms. So obstructive sleep apnea. So these children may have adenotonsillar hypertrophy. So these things have to be ruled out in during examination. So constipation, small nocturnal bladder capacity, overactive bladder, and acquired neurogenic bladder. Psychological. Now here in secondary aneurysms that I have, it is slightly has a major role in as a cause for secondary aneurysms. So this could be because of the birth of a new sibling or parental discord when there is parental divorce and things like that. So these could lead to a secondary aneurysms. So I recently had a patient who presented with fecal encopresis and also urinary incontinence, a girl child. So when we actually went into the depth of the matter, the reason was psychological because the parents were divorced and the father had remarried and the child could not adopt or adapt to the new mother. And there was also a history of physical abuse. So all these factors could actually, present as aneurysms. So we'll have to go into the depth as far as history taking is concerned. And diabetes mellitus also, the thing is, diabetes mellitus as such may not present as aneurysms, but it could be because of suboptimal control of diabetes mellitus in a child who is already diagnosed with DM. So moving on, the impact of aneurysms. Now this is very important because most of these children who are aneuritic, they have low self-esteem. This could be probably because teasing at home, teasing by the parents, teasing by other family members, teasing by children at school. There could be abuse, physical abuse. That could be a cause of aneurysms itself, or children could be abused because of the aneurysms. And sometimes, I don't know, many a times even, children are punished for for bedwetting. So, and these children usually have lower quality of life because many times these children are actually hesitate to move to their friend's house for a sleepover, and they are hesitant to travel because when their parents are going for a trip or a vacation, these children are actually hesitant because they are scared of wetting the bed, causing an embarrassment to themselves and their family members. They have the anxiety. So quality of life in these children are reduced. And obviously parental discomfort. Now, recently again, I had a child, the child was brought by the parent and the mother was, quite annoyed with this condition because she had to wake up multiple times at the night. She had to change the sheets, change the child's clothes. So parental discomfort is actually another impact of aneurysms in children. And as I mentioned earlier, psychological issues are more likely an effect of aneurysm rather than a cause. So how do we approach these children and parents also who bring their children with nocturnal aneurysm? As always, a meticulous history is very important, and we need to assess the daytime voiding pattern, in the sense how many times do they void during the daytime. A usual voiding, usually children void urine around 4 to 7 times. That is normal frequency. And if it is more than 7, then that is increased frequency, and usually less than 4 times is decreased frequency. So a daytime voiding pattern has to be assessed. Toilet training history, usually by 3 years of age, toilet training would have started. Hydration history, again, how many times do they drink water? Do they drink water at school? Do they do they drink water after coming back from school? Whether they drink water during the night time. So all those things have to be taken into account. And number and timing of episodes of bedwetting. That is, when do they wet the bed? Is it immediately after sleeping, or and how many times they wet the bed at night? All those things have to be taken into account. Again, sleep history should include the times the child goes to bed, falls asleep, and awakens in the morning. And the parents should be asked to make a subjective assessment of the child's depth of sleep. The presence of restless sleep, snoring, and the type and frequency of nocturnal arousals. It could be due to nightmares, sleep terrors, or sleepwalking. All these things should be determined. Whether the child has experienced periods of dryness, and the circumstances of these episodes should also be determined. A nutrition history should include the timing, quantity, and type of fluid and solid food intake during the entire day, not merely after supper. And many children with aneurysms do not drink, as I mentioned earlier, appreciable amounts of liquids during the school day, arrive home from school thirsty, and drink most of their fluids in the 4 or 5 hours before bedtime, a pattern that favors nocturnal production of urine. So that has to be assessed. The other thing is behavior, personality, and emotional state. Very important. So moving on to next slide. So as I mentioned earlier, the detailed history has to be taken. So again, after that, another most important is a comprehensive physical examination. A general physical examination, including anthropometry, has to be taken. Inspection of the external genitalia for structural abnormalities, palpation in the renal and suprapubic areas for looking for renal masses, looking for an enlarged bladder or feces, palpation of the abdomen, a thorough neurologic examination of lower extremities, including gait, muscle, power tone, sensation, reflexes, and plantar responses, inspection and palpation of the lumbosacral spine, looking for tuft of hair or any other abnormalities, assessment of the anal wink or the perineal response, that is related to the prudental nerve. So a comprehensive physical examination is important. Now, once that is done, moving on to, after ruling out the other causes, underlying pathologies, so we would like to move on to the investigation. So in primary nocturnal aneurysms, not many investigations. So if you look into the blood investigation, we can do a full blood count. And if the patient is present with constipation, we have to rule out hypothyroidism. So TSH can be done. Apart from that, to rule out DM, we can assess the blood sugars. Again, as I said earlier, DM itself may not present as aneurysms, but it could be due to suboptimal control. So urinalysis, if the child has symptoms suggestive of cystitis, and a culture has to be done, and ultrasound of the kidney, ureter, and bladder before and after voiding. Now, other studies are indicated if the child has other symptoms of voiding dysfunction, urogenic bladder, urethral obstruction, and so on. So that includes uroflowmetry, voiding cystourethography, and MRI of the spine, especially if there is abnormal urologic finding during the examination. Moving a bit fast, and urodynamic studies and cystoscopy if there is signs or symptoms of urethral obstruction or a urogenic bladder. So moving on to management, the most important reason for treating aneurysms is to minimize the embarrassment and anxiety for the child and the frustration experienced by the parents. So most children feel very much alone with their problem. So if there is any family member, now again, genetics is also important, because nocturnal aneurysms can be genetic. It is usually transmitted in an autosomal dominant fashion. So family members who have history of aneurysms should be encouraged to share their experience and offer moral support to the child. So knowledge that family member had the same problem can actually be therapeutic for the child. So preliminary management involves behavioral modification and positive reinforcement. So behavioral modification, both the child and the parent has to be involved. So there should be a positive, we should try to inculcate a positive attitude and motivation to be dry, a caring and patient parental attitude. Now, this is very difficult because most of the time the parents are frustrated, and a consistent follow-up from our side to assess the results once we start the treatment, and explanation of a probable causes of aneurysms. So this can actually allay the anxiety of the parents. So we should ask them what do they have in mind as to what the causes of the aneurysms, and those concerns should be assessed. And there should be a keen eye on a daytime voiding pattern. Encourage the children to void upon awakening at common transit times and before leaving home, school, and always before bed. During the voiding, the child should relax, use optimal posture, and take time to empty the bladder completely. And they should drink liberal amounts of water during the day and maintain optimal hydration. And thirst should be prevented. Parents should take the child to the bathroom to void before bedtime. There should be a fixed hour for bedtime to ensure adequate sleep. After 3 months of behavioral modification, if there are no results, then alarm therapy or pharmacological therapy should be the next option. And RCTs have shown that these are actually reliable. And if it is behavioral modification is successful, it has to be continued 1 month before stopping. Moving on to the alarm therapy and pharmacological therapy. Now, another thing is bladder training is not recommended as it is not effective. So alarm therapy should be considered for every patient. It basically increases nocturnal bladder capacity and enhances the arousal. There are many alarms available. So these basically come with a sensor, a cord, which is attached to the alarm unit, and it can be fastened to the clothes of the child. So this sensor would detect even if there are few drops of wetness or urine in the child's undergarments. And then the alarm would ring and the child would wake up and the parent would take the child to the bathroom. And when this is done, some replace aneurysms with nocturia and others sleep dry. So many of them improve after the first 2 weeks, and others may take several months. So here again, motivation is the key because the parents have to be involved in this as well. Moving on, the next is pharmacological therapy. So these can either be combined with alarm therapy or can be administered alone. So the most important one is desmopressin acetate. It's an ADH synthetic analog, and these are available as a tablet, orally disintegrating tablets, or a nasal spray. Nasal spray is actually avoided. So dosage is 0.2 milligrams, titrated to maximum of 0.6 milligrams 1 hour before bedtime. And it has an immediate onset of action, so it can be given intermittently or as a long-term measure. So usually we give a 3 months prescription, and then if it is working, actually, we need to actually stop it for a month and see whether the child can achieve continence without the medication or not, whether it's successful or not. The most important thing here is a serious adverse effect. It can be due to hyponatremia, which actually can cause seizures. And so sodium has to be checked prior to initiating the treatment and after 1 week of therapy, then after 1 month. The other one is imipramine. Now, I would not go into details of this because WHO does not recommend imipramine because of the side effects, and overdose can be fatal. The other drugs which are actually supportive are anticholinergic agents, oxybutynin, tolterodone. This can also be given in children with OAB and neurogenic bladder. The most important thing is long-term monitoring. So they have to be assessed frequently to assess the response. And another thing is when to refer. So when they have known or suspected physical or neurological problems, parents who have difficulty coping with bedwetting, and possibly the child is being abused, and refractory aneurysms. Also, moving on to the last slide, that is the conclusive slide. So nocturnal aneurysm is basically a family problem. It can be treated by a family medicine specialist. So we need to look out for underlying pathologies and treat the same. We have to work closely with the parents and the child and address concerns and provide relief, and also know when to refer. Thank you so much for patient listening.
Hello, am I audible?
Yes, ma'am.
Yes.
Yeah, thank you, Ali, for that wonderful presentation. You've touched almost all aspects of aneurysms. As far as the etiology is concerned, I just want to make one point where there is one population which is becoming very commonly seen in the last few decades. That is children with neurocognitive disorders who have this particular symptom very common. And this becomes a very, as you have mentioned very rightly, it has become a very stressful situation for the parents. As you see a lot of autism and the autism spectrum disorders, aneurism is a very common symptom among them. I must say that more than the pharmacological therapy, as you mentioned correctly, the behavioral therapy is the most important aspect to educate the parents and the caregivers. Excellent presentation. Thank you so much. Srinivasan sir, if you have any question.
Yes, thank you, Dr. Jamil. It is a very excellent presentation. You have dealt all the issues, physical examination, taking about the history, and what are the causes of primary and secondary aneurysis. And in the chart, the causes of the primary aneurysis, faulty toilet training also should be added. Faulty toilet training should be added best. Now you have dealt in your presentation very well, and because it is also one of the important causes of the primary aneurysis. And as Dr. Danya has clearly told, neurocognitive disorders and attention deficit hyperactive disorders, these should be along with the autism and these attention deficit hyperactive disorders should be there. At least for the diagnosis of this aneurysis, few points while taking the history, few points you should take into account. One is the bedwetting. The second one is old enough to be toilet trained. Third is precipitating problems such as diabetes or urinary tract infection, and frequent passing of stools, encopresis, attention deficit hyperactive disorder, family history of aneurysis. And these features should move us, should direct us to the diagnosis of the aneurysis. These are the important features by which you can diagnose the aneurysis. Essentially and very well dealt. Thank you. Thank you, Jamil, for the excellent presentation.
Thank you, Dr. Ali Zameen. That was a very enlightening and informative session. I also thank the chairpersons for sharing the session.
Good morning, everyone. We now proceed to the inaugural function of Virtual AFPICON Kerala 2022. The theme being person-centric care, the sweetest pill. We welcome all the dignitaries. We invite Dr. Prashant, Event Treasurer, AFPICON Kerala 2022 for the prayer song.
Aneshwara Atmashandidayaka Sandadam Vanam Vartuvat Varun Sadaram Ishwara Aneshwara Atmashandidayaka Sandadam Vanam Vartuvat Varun Sadaram Deepamai Nalamai Nadamai Prapadamai Deepamai Nalamai Nadamai Prapadamai Mannilum Manassilum Valvum Nirandaram Mannilum വാക്കിലും മനസ്സിലും വാഴും നീ നിരന്തരം ഈശ്വര അനശ്വര ആത്മശാന്തിദായക.
We invite Dr. Indu Raji, Organizing Chairperson, AFPICON Kerala 2022, to welcome the gathering.
Ma'am, you're muted.
Okay, good morning to all. It's my pleasure to welcome everyone to the annual state conference, AFPICON Kerala 2022. The theme for this year is Person-Centric Care, the Sweetest Pill. It is about treating a person, receive healthcare with dignity and respect, and involve them in all decisions of health. With all these words, I am extremely delighted to pronounce the chief guest for the day, our Honorable Health Minister of Kerala, Mrs. Veena George. I am grateful to you, ma'am, for accepting our invitation and to be the part of this event, in spite of your busy schedule and especially the ongoing COVID situation. On behalf of Kerala AFPA, AFPICON 2022, a warm welcome to you, ma'am. On behalf of AFPA Kerala chapter, I would like to welcome Dr. Raman Kumar, National AFPA President, the person who is committed with his persistent efforts has led family medicine to a different level. Welcome to you, sir. I would also like to welcome Dr. Vandana, our National AFPA Secretary. She has been an active member of AFPA and has been working immensely for the upliftment of family medicine. Welcome to you, ma'am. Now let us welcome Dr. Danya, AFPA Kerala State President. I would also like to thank you for trusting me and giving me this wonderful opportunity to host this conference. Thank you, Dr. Danya, and welcome to you. Dr. Rashmi needs no introduction, our ex-president AFPA Kerala and now the treasurer National AFPA. I'm immensely fortunate working with you, Dr. Rashmi, and thank you for the guidance at every step in making this conference a success. Dr. Shahzad, Kerala AFPA Secretary, a person with patience, dedication, and perseverance, and an inspiration to the youth too. And thank you for inspiring us, Dr. Shahzad. Welcome to you too. Dr. Jisha, Organizing Secretary, AFPA Midzone Secretary, Kerala Chapter. Jisha, I always see you with a humble tone and a smiling face, but full of energy and fresh thoughts. I am ever grateful to you for your valuable support. Welcome to you, Dr. Jisha. On behalf of AFPA Kerala Chapter, I would like to welcome our distinguished guests, speakers, chairpersons, delegates, and all the members of my organizing committee and the event platform Imagica team. Once again, thank you.
Thank you, madam. We welcome Dr. Danya S. Pillai, State President AFPA Kerala, for giving the presidential address.
Good morning, dear all. Respected Chief Guest, Honorable Minister for Health and Family Welfare, Srimati Veena George, Dr. Raman Kumar, Dr. Vandana Bajaj, Dr. Rashmi S. Kaimal, Dr. Indu Raji, Dr. Shahzad, Dr. Jisha, dear speakers, delegates, and all the dignitaries present here. I am immensely happy to be here before you on this occasion of the 6th annual conference of AFPA Kerala Chapter AFPICON 2022. We were planning on a physical meeting this time, but considering the present extension of the COVID pandemic situation, we had to go ahead with a second consecutive virtual conference this year too. AFPI, since its inception few years back, had been very actively involved in upbringing the primary healthcare system in the state, which was started under the leadership and guidance of Dr. Raman Kumar sir, our national president. The state activities under the leadership of past presidents, Dr. Bijay and Dr. Rashmi S. Kaimal, has been the development of family medicine in Kerala. The 6th annual conference has some important highlights pertaining to family medicine, like the event inaugurated by our Honorable Minister, the topic giving importance to the person-centric care, a wide range of interesting topics selected from pediatrics to geriatrics, rendering mostly by our young family physicians practicing in the state. I would like to thank our chief guest for sparing her valuable time with us, the National Executive Board members, all state leaders for your guidance and support, and each one of you who have been instrumental in making this event possible today. Special thanks to the organizing committee members, speakers, and delegates. Best wishes for the day. Thank you. Good day to you.
Thank you, Dr. Danya ma'am. Now I would like to invite the chief guest of the day, Srimati Veena George, Honorable Minister of Health and Family Welfare, Kerala, for delivering the inaugural address.
Good morning. ഈ യോഗത്തിന് അധ്യക്ഷം വഹിക്കുന്ന ബഹുമാന്യായ യോഗാധ്യക്ഷ ഡോക്ടർ ധന്യ എസ് പിള്ളൈ, സ്റ്റേറ്റ് പ്രസിഡന്റ് AFPI കേരള, ബഹുമാന്യായ ഡോക്ടർ ഇന്ദു രാജീവ്, ഓർഗനൈസിംഗ് ചെയർപേഴ്സൺ, ബഹുമാന്യരായ ഡോക്ടർ രാമൻ കുമാർ, ഡോക്ടർ വന്ദന ഗോപാൽ, ഡോക്ടർ രശ്മി എസ് കൈമൾ, ഡോക്ടർ ഷഹസാദ് എമ്യു, ഡോക്ടർ ജിഷ വി, AFPIയുടെ ബഹുമാന്യരായ ദേശീയ സംസ്ഥാന നേതാക്കൾ, യോഗത്തിൽ സംബന്ധിക്കുന്ന ബഹുമാന്യരായിട്ടുള്ള ആരോഗ്യ പ്രവർത്തകർ, പ്രിയപ്പെട്ട സഹോദരി സഹോദരന്മാരെ, AFPI കേരള ചാപ്റ്ററിൻ്റെ 6ാമത് ആനുവൽ കോൺഫറൻസ് ആണ് ഇവിടെ നടത്തപ്പെടുന്നത്. കോവിഡ് സാഹചര്യത്തിൽ വെർച്വലായിട്ടാണ് ഈ മീറ്റിംഗ് നടക്കുന്നത്. ദ്വിദിന കോൺഫറൻസ് ആണ് ഈ വർഷം ഒരുക്കിയിരിക്കുന്നത്. ഈ കോൺഫറൻസ് ഈ രീതിയിൽ സംഘടിപ്പിച്ച എല്ലാവരെയും പ്രത്യേകമായിട്ട് അഭിനന്ദിക്കുന്നു. I take this opportunity to congratulate all the organizers of the 6th Annual Conference of Academy of Family Physicians of India Kerala Chapter. This conference is actually aimed at giving updated professional information to qualified family physicians and general practitioners. And I would like to place a special appreciation note because in this pandemic situation it's highly appreciable to conduct such a conference in a virtual mode. And I learned that when I went through the brochure, the conference highlights topics related to family medicine and primary care, and actually that forms the backbone of healthcare system in Kerala. And when we mention the healthcare system of Kerala, it includes both the public and private medical care systems. And at this time I acknowledge with respect the dedicated work done by our family physicians and doctors who were in front line managing the pandemic for the past 2 years. ഈ കോവിഡ് കാലഘട്ടത്തിൽ ജീവത്യാഗം ചെയ്ത, ജീവൻ വെടിയേണ്ടി വന്ന ആരോഗ്യ പ്രവർത്തകരെയും ഈ അവസരത്തിൽ ഓർക്കുന്നു. ഈ കോൺഫറൻസ് വളരെ ഫ്രൂട്ട്ഫുൾ ആകട്ടെ എന്ന് ആശംസിക്കുന്നു. അത് കൂടുതൽ ഈ കാലഘട്ടത്തിൽ ആരോഗ്യമേഖല വലിയ വെല്ലുവിളികൾ നേരിടുന്ന ഈ കാലഘട്ടത്തിൽ പ്രത്യേകിച്ച് നമ്മുടെ ആർദ്ര മിഷൻ്റെയൊക്കെ ഭാഗമായി ഒരു ഫാമിലി ഹെൽത്ത് സെൻ്റർ കോൺസെപ്റ്റ്, അതുപോലെ കുടുംബ ഡോക്ടർ എന്ന ആശയം നടപ്പിലാക്കിക്കൊണ്ട് നമ്മൾ മുന്നോട്ട് പോകുമ്പോൾ അടുത്ത 5 വർഷത്തെ സർക്കാരിൻ്റെ പ്രവർത്തനങ്ങൾക്കെല്ലാം ഗുണപരമായിട്ടുള്ള എല്ലാ നിർദ്ദേശങ്ങളും നിങ്ങളെല്ലാവരും നൽകണമെന്നും അഭ്യർത്ഥിക്കുന്നു. ഈ കോൺഫറൻസ് ഏറ്റവും ഫലപ്രദമാകട്ടെ. എല്ലാ ആശംസകളും നേരുന്നു. I wish every success to this program. And with these words, I would like to declare that this conference is inaugurated. Thank you very much.
Thank you, Srimati Veena George.
Good morning.
Now we would like to welcome the National President, AFPI, Dr. Raman Kumar, for giving us the keynote address.
Thank you, AFPI Kerala, for organizing this wonderful conference. I send my warm wishes from all over India for doing this a very important academic activity which we have been continuing, especially in Kerala, year after year, without any break, irrespective of the 2-3 years of pandemic. So really applaud and appreciate efforts put in by the organizing team. So thank you, Dr. Indu, Dr. Dr. Shahjad, Dr. Dhanya, all organizing committee members, all faculty and participants for participating in this conference as we are going through this third wave of COVID pandemic now, and it's still challenging. We are still passing through this the greatest challenge of all humanity in recent decades or century, we can say. And as it has evolved from this period, that family physicians, as Madam Health Minister just now emphasized, that they are the frontline providers, as well as they are the backbones of the healthcare delivery system, not only in Kerala, but all over India and all over world. And as we have seen in a multi-system, multi-organ, disease, like COVID, what we have seen, primarily it is a viral infection, but that impacts multi-organ system in our body. And only a generalist provider, like competent family medicine specialist, can do justice not only to one individual's health, but also to the whole family, because we have seen during COVID period, post-COVID period, spectrum of symptoms, clinical presentations, and variable outcomes in different patients, different population groups. Even epidemiologically, it has been different in Kerala, southern part of India, than it is in northern part. So there has been wide range of variations for what we have been seeing across India, and such variations clinically, when we manage, it's only family physicians, a skill which we can, do best justice and best outcomes, I can say. So even as I'm sitting and addressing this meeting, we all have been, seeing patients of new variant Omicron, which is slightly milder, but still we have to be very, very watchful. We have lost our colleagues, professionals, healthcare workers during past 2 waves, and we should be very, very careful when we are providing, although the vaccination coverage has gone up, but still there are challenges, still hundreds of people are dying every day. So this is an apt opportunity, and the theme of this conference is person-centeredness in that we provide, and it is one of the fundamentals of family practice, family medicine discipline. And if I try to explain a bit in the context of COVID, so every person is having different symptoms, duration of symptoms, intensity of symptoms, a spectrum of symptoms, and every, although the standard treatment or guidelines remain same for everyone, but the treatment has to be personalized. What treatment has to be given on 5th day for a, say, young person or an old person with multiple morbidities has to be fine-tuned, titrated according to the need of the person. And if this is not done, if we apply the uniform protocol to everyone, it may be catastrophic to many people. So a personalized touch is required in managing these cases, managing the clinical situations that even vary on day-to-day basis. Symptoms differ on 5th day to 7th day to 14th day. And what we were saying in the second wave with the Delta variant is different from what we are seeing now with Omicron variant. So personalized, person-centered care is very, very important, not just in COVID, but also in other disease situations, whether we treat thyroid, diabetes, all kinds of fevers, febrile illnesses. All these have, wide variation in their presentations. So personalized care is very important. And above all this, all members of the family can be treated by family physicians. So with these words, I know we have a very good scientific program lined up today, and we have other dignitaries to speak now. So I send my best congratulations and best wishes to all of you and for the success of this conference. And we are very happy to see how AFPICON Kerala has evolved and leading not just AFPI, but family medicine movement across India. So thank you all. Thank you for inviting me here. Thank you very much.
Thank you, Dr. We invite Dr. Vandana Agarwal, National Secretary, AFPI, for the felicitation speech.
Good morning, everyone. Am I audible?
Yes, ma'am.
Good morning, everyone. My best wishes to the, congratulations and best wishes to the Kerala team, past President Dr. Reshmi and present President Dr. Dhanya, and the organizing committee for organizing such an wonderful conference, which is person-centric and very much required in this pandemic. We are going through the third wave. So I really appreciate this conference, and my regards to the chief guest, Honorary Minister of Health and National President Dr. Raman, Dr. Shahzad, Dr. Indu. So I'm really feel proud and honored to be here and be part of this conference. And I am also a part of this pandemic, and currently I'm COVID positive, yes, going through the Omicron. Despite that, I have been working day and night despite my illness. I'm very sure, so everybody else, whoever is there, primary health physicians, despite their health and despite their work schedules, I think they're giving their services to the community throughout. And yes, we primary care physicians are the front line and the torch bearers of this, major part of this healthcare being provided to the community. So yes, together we have been really doing wonderful, and I congratulate all of you. Thank you so much.
Thank you, Dr. Vandana Agarwal. We invite Dr. Reshmi S. Kaimal, National Treasurer, to felicitate the event.
Good morning, all. Am I audible?
Yes, ma'am.
Yeah. So why should I give a felicitation to my own team? I still don't understand. But being part of the national executive, I think it is my duty to felicitate the AFPI Kerala team, my own team, for first of all, congratulating the team for going ahead with a conference even in this pandemic situation. The virtual conference twice in a succession is very difficult to manage. Hopefully, we'll have a physical conference next year, fingers crossed. All congratulations to Dr. Dhanya and Shahzad for leading the AFPI Kerala as they are leading it now, and Dr. Indu, Dr. Jisha, and the entire organizing team, my friends, colleagues, all residents and speakers for making this a huge success. Hope the remaining academic feast also excites you, and thank you for inviting me for this felicitation speech. All the best. Thank you.
Thank you, Madam. We invite State Secretary AFPI Kerala, Dr. Shahzad MU, for delivering the felicitation address.
Good morning. Yeah. First of all, I'm very grateful to be a part of this event and to be working with a very enthusiastic organizing team here. AFPI Kerala has been very serious in its academic activities, and AFPICON Kerala has been one milestone event that we have always been fond of, our our annual state conference. This year again, due to COVID, it's virtual, just like last year. But just like Dr. Reshmi had said, we are very much looking forward to having a physical event the next time, hopefully. And apart from the academic events, we have also been very closely in follow-up with the policymakers of the state for uplifting the specialty in the state. And yes, the specialty has gained momentum. It has gained a lot of momentum in its recognition for the past few years. And it's a delight to see a lot of new faces with very positive and assuring attitudes. On behalf of AFP Kerala, I sincerely thank our national leaders and state leaders, especially Dr. Raman sir, Dr. Vandana madam, Dr. Mohan sir, for their constant wholehearted support in all our ventures. I extend my best wishes to the organizing team and all the participants who are here for this academic feast. Thank you.
Thank you, sir. Next, we welcome Dr. Jishavi, Organizing Secretary, AFPICON Kerala, 2022, for giving vote of thanks.
Good morning, everyone. The job is stored upon me today is to give my sincere thanks to all of you. First of all, I would like to thank our Honorable Minister of Health and Family Welfare, Dr. Ms. Srimati Veena George, who has given us some time, given us her time in the midst of this ongoing pandemic. I'm sure she is having a very busy schedule, but she took up our invitation and she joined us for this inaugurating our conference. I'm really grateful to Veena Madam for giving her giving us her kind words. Next, I'd like to thank Dr. Raman sir. Raman sir has been the pillar of family medicine in India since its inception, and he is very active in all of our academic activities. Whenever we call him for whatever academic activities, he joins us and he supports us, and his support gives us, makes us want to do more. So I sincerely thank you, Dr. Raman sir, for joining us here today. I'd also like to thank Dr. Vandana ma'am, who's our National Secretary. Ma'am has also joined us as a chairperson also for this event yesterday for our talks. And ma'am has been an inspiration to all of us young doctors who have joined family medicine. When we see her practice and when we see her talk, on behalf of AFPICON Kerala organizing team, I would like to thank you sincerely, Dr. Vandana ma'am. Next, I would like to thank Dr. Danya ma'am, our state president. Ma'am has been ma'am has been with us since the beginning of this conference, and it was we planned it and we organized it. And ma'am, it was under ma'am's guidance that we are able to organize this conference here today. I'd like to extend my thanks to Dr. Vandanya ma'am on behalf of the organizing committee for AFPICON Kerala 2022. And I'd like to thank Dr. Reshmi madam. There is no words that I can say that are enough to thank Reshmi ma'am's support for all of us who are family physicians here in Kerala, ma'am. And even on the national stage also, ma'am is now in the national FPA. And ma'am is always there to push us when we are, not doing enough. Is always giving us support and advice. I'd like to thank Dr. Reshmi ma'am for her support. And I'd also like to thank the Kerala chapter, and he has been the person, whatever you need, you just call Dr. Shehzad and he's there for us. So I'd like to thank Dr. Shehzad for joining us here today for this inaugural ceremony. And I would also like to thank all the organizing team who has helped us do this conference, get it on without trouble. And I'd also like to thank all the speakers and chairpersons, all the residents who have participated in the quiz posters, and all of you on the audience who are listening today. I'd like to thank everyone for their for supporting us today. Thank you, everyone. Thank you.
Thank you, Dr. Jisha. With that, we come to the end of the inaugural function. Let us move on to the next session.
Our next session is why person-centered care is the sweetest pill, and our speaker is Dr. Sunil Abraham. Dr. Sunil Abraham is a professor and head, Department of Family Medicine and Low Cost Effective Care Unit, Christian Medical College, Vellore. After completing his MBBS from Calicut Medical College, he worked for a year in a rural mission hospital in Umri, Maharashtra, and then in internal medicine department in Christian Fellowship Hospital, Odinchitram in Tamil Nadu. He was convinced of the need and God's call to take up family medicine and joined the DNB Family Medicine course there and qualified in 1998. From the year 2000, he has been working in CMC Vellore, initially in the rural Rusa Hospital, and from 2001 in the low-cost effective care unit, a 48-bedded unit for the urban poor. He has worked as a GP in Melbourne, Australia for 3 years in a GP training practice. His areas of interest include teaching family medicine for the urban poor, and whole person medicine. He's currently the course coordinator of family medicine in CMC Vellore, examiner for DNB in family medicine, and is also the coordinator for webinars for family medicine, National Board of Examination. We welcome you, sir.
Thank you very much, Dr. Anu. I suppose I can share my screen now, right?
Yes, sir.
Okay, thank you very much. I really congratulate the organizing team for organizing this conference. You know, it is, I'm sure you'll agree if I say it is a difficult time in the healthcare field for doctors, for patients, for families. It is certainly not an easy time, and we are struggling. And to have a conference in the midst of it, really appreciate that. So with the changes that are happening around us every day, I just got a text from one of my colleagues saying, sir, I got fever, cough, sore throat. I'm probably COVID positive. I will not be coming for work. And we are hearing this every day, right? So with this thing happening, how can we still enjoy medicine? You know, as the title says, what is the sweet pill that we have, which keeps us going in the midst of all that is happening here? Okay, let me go. I would say in my own journey in family medicine, right, the time when I heard about family medicine as a medical student in Calicut, when I decided to do family medicine in 1994, and I completed my training in 1998, there has been a transition in my understanding of what family medicine is, what this specialty is about. Because as many of us, I did not have a teacher of family medicine when I did my family medicine training. I did not have a textbook of family medicine. My understanding of the specialty has changed. Now, initially, I still remember, this is what I thought was family medicine is. You are a multitasker. You learn a little bit of medicine, a little bit of surgery, a little bit of ortho, a little bit of psychiatry, and you try to solve different problems. And in my mind, I thought, okay, this is what I'm supposed to do. Still, I still remember the hospital where I trained, Christian Fellowship Hospital, Odinchitram. You know, you will have your different rotations, right? And you go to the different places, you have specialists in each of these rotations. And the specialists are excellent. You know, they are well trained, they know this stuff, and they're willing to teach. But they have the knowledge in that particular field. And you learn to do that, one of these, you know, and you learn to do that well, to the best you can within the time that you get. And the challenge was that neither they nor me knew what is family medicine or what the end product should be. So I would learn one skill, go to the next one, learn another skill, and go through everything without learning what is family medicine. We had one person at that time, Dr. Raj was there, and he of course taught us what was family medicine. But even then, my understanding was not much, it was minimal. I would go through, and I remember one day in the OPD, I was sitting, they said, look, there is a shortage of doctors in pediatrics. I was in medicine. So can you please go and help out in pediatrics? So I went and helped in pediatrics. They said, ortho, there is a shortage of doctors. Can you go? So I went to ortho. Then they said some other departments. So in one day I sat in 4 OPDs, because I thought, hey, this is good. I can do multiple things, which is good, by the way. I'm a generalist. I like to think, I'm not like my wife, who is a pediatric ENT specialist who does cochlear implants. That is her subspecialty. But I am a generalist. I like to think broad and wide. And I think family physicians, we are tuned to think like that. So my understanding was this, which over the years has changed to become different. So this is what I did 3 weeks ago in my department. We in the ward, I had a patient with diabetic ketoacidosis, another lady with pyelonephritis. There was another young man who had a type 1 diabetic with a toe infection, needed a ray amputation. So we gave ankle block and we did the amputation. There's a lady who had a delivery. There's another young man with uretary calculus. There was another person with enteric fever. There was another man with COPD, cor pulmonale. One lady with fever, and they have the typical scab, the scrub type of scab. Mesenteric ischemia, one patient came who had to be referred to the main hospital. Child with bronchopneumonia, another man with alcohol abuse. Now we see the breadth of cases. This is all in family medicine in our hospital. And we see that and we say, this is exciting. We love doing this. I mean, we manage from, as we say, womb to tomb, right? We do all those things. And I think that is fantastic. But family medicine is more than that. Absolutely. If you look at the unique selling point as family physicians, you think about India now. You think about the challenges that the healthcare is going through. You think about the challenges that patients are going through. What is your unique selling point as family physicians? What do I hate to use the word customers for patients, but this is what I got from the net. So what do our patients want? What do our competitors, again, I don't like the word competitors, but that is a reality, especially in Kerala, and other specialists trying to block the specialty across the country. It's a reality. And what is that you do well? What is unique? Our department sees about 450 patients a day. And then we have to send away patients because no appointment slots, no doctors available. Why is it that when you have a 2,200 multi-speciality, top-rated hospital in the country, but so many people are coming to family medicine? It's not because we are great doctors, I still remember 2014 when we wanted to start the new Shalom Family Medicine Center. The medical superintendent said, you put the name family medicine, nobody's going to come. But that has changed now. We started in one more family medicine center for the glory of God last year, and patients are coming and more patients are coming. So what is your unique selling point as family physicians? What is it that you offer which other specialists cannot offer? What is it that patients are looking to you, which they are increasingly saying, we are not getting this in hospitals? And I would say it is your focus, not just on the diseases, but on the person of the patient. Patients are looking for personal doctors. Patients are looking for doctors with whom they will have a long-term relationship. You ask my colleagues in CMC, patients will come to the clinic and say, is Dr. Venkat there? No, there are 3 other doctors. No, I want to see him only. And they'll go back. They'll come again. Why? Because they know him. They know our people for months and years. And that focus on the doctor-patient relationship is what family physicians do very well. It's what which makes the specialty special and excellent. So from multitasker in my journey, what I started as, oh, I should do multitasking. I see my understanding of family medicine as that I'm a fellow traveler in life of people in their various stages who happen to be my patients. That's the way I look at my practice now. I see about 40 patients a day, but I'm not just seeing 40 patients, I'm seeing 40 people. And persons coming in different stages of life. And you walk with them. What do you do with the patient who's got rheumatoid arthritis? Who says, doctor, will this not get better? Says, sorry, no, it goes ups and down, let's control it. Or to the diabetic who says, I've been taking these tablets for 15 years, doctor. You walk with them. And they share their life with you. They share their problems with you. They share their joys with you. I had one patient who came and told me last week, I had a grandchild. Doctor, I have a grandchild now. And you know what? I've named him after you. He's a Muslim patient. He said, I named him Muhammad Salim. No, Salim Ibrahim. It is close to your name of Sunil Abraham. So I named him Salim Ibrahim. I said, what a joy. Some of these patients you get to know over time. That's special about family medicine. So I see my work now as traveling with people who happen to be my patients throughout their phases of life. So how does it translate into daily practice? How does patient-centered medicine translate into daily practice? Well, let's look at history taking, for example. In traditional teaching, you say, in third year, we were all taught, take the presenting illness, and you had to do it in the chronological order. If there is fever, cough, and body pain, what started first, you had to find out, it has to be presented in order. Good thing. And then, of course, the past, personal, family, social, economic status, and all is usually just mentioned. But the focus of the history taking is on the clinician with the book and is like interrogation of the patient. And if the patient interrupts, no, just tell me this, you all did that, I have done that. And that history taking, even though it is history taking, it is like an interrogation, which is often not patient-centered. It's focusing on the symptom and the disease. Okay, what fever, cough, body pain. What is the type of fever? Is it, what is the pattern of fever, etc., etc. And the patient tries to tell you, no, tell me about the fever. What about the cough? What is the color of the sputum? How much of sputum? Is there a diurnal variation, etc.? And you ask this because you are like a detective, sitting there, you're asking the questions, and the focus on you getting the right details. But when it's patient-centered history taking, the first question you ask is, what can I do for you today? Like on Friday, I had a patient, man in his 60s, no, maybe 70. Yeah. He has diabetes for more than 20 years. He had ischemic heart disease. 2001 had a stent, and then 2016, it got blocked. He had another stent. So he's coming to CMC after 5 years. I could get all those notes from the EMR. So I sat with him. I told him, look, from your notes, these are the things you had in the past. That it itself blows him away, that I took time to look at his past history. And I said, what can I do for you today? So the focus is on you, the patient. And I think that's one thing we had to, here's one person who's come and you're asking, hey, hello, what can I do for you today? Why have you come today? And you have to listen without interruption. We are not looking for chronological listing of symptoms. You sit, listen, okay, what can you do for it? And they just talk. And you listen. And you listen without interruption. The patient will speak what is important to him or her. And you listen. Listen not just with your ears, but with your eyes. There is active listening, because even as you're listening, your mind is active and you're trying to find out, okay, what is going on here? Now, what does the symptom mean? What is the patient trying to tell you? See, the patients might be having symptoms for a few months. They get about 5 minutes or so to talk to you. So how much we must be listening? And you keep on asking anything else till the patient says no. Now you might think, if you do that, it's going to go for a long time. Absolutely not. There is research evidence that it will not take more than 1 to maximum 2 minutes in most of the patients, if we just keep quiet and ask them what else. There'll be some patients who take off. That always happens, but most of them don't. But after this, of course, you have to ask leading questions, because 75% of your diagnosis comes from your history. Then, of course, there is something called the 3-stage assessment, which I hope all family medicine residents learn. To understand the person of the patient. First is, of course, the clinical diagnosis. And as clinicians, as family physicians, we must be excellent in our clinical diagnosis. We have to be good clinicians, able to take a good history and do a good clinical examination, because that is something that is missing these days. I had a lady who said, she's a diabetic hypertensive, etc. She said, I got this pain here in my hand. I went to the orthopedician. So the orthopedician was sitting behind a screen and he had a tab with him. And so he's asking, what are the things you have? Okay, do these 5 x-rays and come back. Didn't even touch her. So she came back with 5 x-rays. There's nothing wrong with you. Take this pain medicines. She had Finkelstein's sign positive, which is there in decuvant synovitis. That was a problem. Just simple clinical examination. Tell you, patients are looking for doctors who will talk to them, touch them, examine them, and tell them what is going on. So we need to be good clinicians. So we need to have a good clinical diagnosis. For example, periarthritis of shoulder, whatever. The second thing is the individual diagnosis. That means, what is a patient's illness experience? What does this patient feel is going on, which is different for different people. For example, the patient with shoulder pain might be thinking, am I having a heart attack? Because these Googled shoulder pain could be ischemic heart disease. They freak out, they come to you. So what is a patient's idea? What are their concerns? What are their expectations? We don't do that for every patient. But when you ask these questions, patients are so happy. They love it that you are willing to listen. And the third thing, of course, is the contextual diagnosis. What is the context of the patient? What is happening in the family, job, finances? What is the impact of the disease on the context and the context on the disease? For example, in the past few months, we've been getting a lot of IT professionals working from home. The amount of trouble they're going through, they got pain, they're getting anxious, some of them are depressed, sleep patterns are changed, backache, multiple things. But understanding the context, understanding the challenges of the COVID pandemic, how that has impacted the family, death in the family, all those things we should know as part of the 3-stage assessment. Now, you say, is this practical? Can we do this in practice? As I said earlier, I don't do it for every patient, but getting to know your patient is not an option in family medicine. If I see 40 patients a day, I might do a 3-stage assessment maybe for 2 or 3. But many of these patients, I know their background. I know what is happening. I have one lady whose son is in Australia, diabetic, living alone at home, and her insulin, controlling her sugars, helping her And we every time she comes, we have a chat about how the sun is, what is happening here. Understanding the patient, not just the HbA1c or the blood pressure or whatever, but understanding the context of the patient. So that is patient-centered history taking, but there is also the patient-centered management. Traditionally it is history, physical investigations, diagnosis, and treatment of the problem. What is the problem here? Pneumonia. Okay, what antibiotic? Give this, go, next. But for us, management of the patient, it is not just treatment of the disease. This patient might have diabetes, hypertension, hypothyroidism, obesity, COPD, osteoarthritis of the knee, etc., which is what many of our patients are having now. But he's also a person who has come to you. And that is what makes family medicine sweet, because we look at dealing with individuals. So as family medicine specialists, our primary focus is on the patients. And I want to say this again, patients are looking for personal physicians they can trust. Main factor, the trust factor, is so much of lost, but they're looking for physicians they can trust, who will walk with them and their families in the journey of the different stages of life. Patient-centered health and the long-term relationship that is formed is the core and foundation of family medicine. My dear colleagues, thank you again for inviting me to give a talk. I'm happy to take some questions, but I want to tell you something. You have not taken a specialty that is inferior to other specialties. I tell you, somebody was telling me last week that at least one or two medical colleges in Trichure, the DM cardiology seats are going vacant. People are not taking it up because it's not easy to get a job after that. You talk to people who have finished family medicine and you have started private practice or whatever, from day one, you're going to get patients because people are looking for doctors like you. This came on the AFPI t-shirt a few years ago, but I firmly believe that family medicine rocks. Thank you very much. I'm happy to take any questions.
Thank you, sir. Thank you, sir, for enlightening us with the very theme of our conference. Person-centric care, the sweetest pill. Thank you, sir, for that excellent and informative session. Let's move on to the next session, which is a panel discussion. What it means to be a family physician in Kerala. The speakers are Dr. Reshmi S. Kaimal, Dr. Robi Prasad, Dr. Shahzad M.U., and Dr. Prashant S. Let me introduce the speakers. Dr. Reshmi S. Kaimal did her MBBS from Government Medical College, Kottayam, and DNB in Family Medicine from Lutz Hospital, Kochi. Course in Essentials of Palliative Care. Dr. Reshmi is a senior consultant and the head of the Department of Family Medicine, Lutz Hospital, and Postgraduate Institute of Medical Sciences and Research. Since 2020, she is the National Treasurer of Academy of Family Physicians of India. She was the Vice President of AFPI Kerala Chapter from 2014 to 2017, and the President of AFPI Kerala Chapter from 2017 to 2020. She was the organizing chairperson of the 3rd National Conference of Family Medicine and Primary Care, FMPC 2017. Dr. Reshmi was awarded the AFPI Member of the Year in 2017. She was a faculty in FMPC 2015, 17, and 19. She was also a faculty in the annual Kerala State Conferences of Family Medicine. Her special interests include family medicine PG training, domiciliary care, and health awareness classes. We welcome you, ma'am. Dr. Robi Prasad. Dr. Robi did her MBBS from Calicut Medical College, and she completed PGDFM from CMC Vellore and has successfully completed MRCGP. She has been practicing as a family physician for the last 15 years. Currently, Dr. Robi runs Dr. Robi's Family Clinic at Kozhikode for the past 3 years. We welcome you, ma'am. Dr. Shahzad M.U. Dr. Shahzad graduated from Trivandrum Medical College and did DNB Family Medicine from Aster MIMS Hospital, Calicut, and has also completed MBA in Hospital Administration. He is currently working in the health services as family physician at Family Health Center, Kudimanna, Malappuram district. He is on deputation as District Nodal Officer, Quality Assurance, Malappuram district. Apart from being a passionate family physician, he is also experienced in critical assessment of hospital operations, quality assurance, and accreditation activities of government hospitals. Currently, Dr. Shahzad is Secretary FPI Kerala. Dr. Prashant did MBBS from Government Medical College Kottayam and completed DNB Family Medicine from Medical Trust Hospital Kochi. He has worked as specialist in medical oncology department at Aster Medicine and as consultant family physician at Anwar Memorial Hospital, Alwa. He has done oral presentation at 15th Wonka World Rural Health Conference 2018. Currently, Dr. Prashant is working as consultant family physician at Vatiyat Hospital, Perimbau. We welcome you, sir. The moderator for this session, Dr. Anand K. Dr. Anand completed his undergraduation from Government Medical College, Kolkot, and his postgraduate course in family medicine from Malabar Institute of Medical Sciences, Kolkot. He is presently posted as Casualty Medical Officer at GH Talasheri in Kerala, Government Health Services. He is an executive member and faculty of Trauma Care, Kannur, and advisory board member of Kannur Dementia Care Society. He was the organizing secretary of the first state conference of the Kerala chapter of AFPI held in 2015 and organizing chairperson of AFPICON 2020. He has chaired sessions and has been faculty at various conferences of family medicine, besides playing organizing roles in both national and state conferences of AFPI. Welcome you, sir. Over to you, Dr. Anand.
Thank you. Firstly, let me express my gratitude in inviting me to moderate this panel discussion. Today's panel discussion is about the scope of family medicine in Kerala, or as the title suggests, what it means to be a family physician in Kerala. Family medicine has been around for more than 2 decades, 3 decades, but then the relevance of family medicine is getting more prominent each day. People tend to look out for family physicians particularly, and because people have started understanding what it really means to go and meet a family physician, what the effect of consultation is. And in that context, this panel discussion tries to bring out the various opportunities that are available for family medicine specialists in Kerala in various job profiles. We have with us, as the introducer has spoken, we have with us Dr. Rashmi S. Kaimal, Dr. Rob Prasad, Dr. Prashant, and Dr. Shahzad. I would like to first invite Dr. Rashmi as working as a consultant, includes with experience and a person who has been private tertiary care sector. Welcome, madam. Please take over.
Yeah, hope my screen is visible and I'm audible.
Yes, ma'am.
Yeah. So when this discussion about this panel discussion came up, my doubt is how relevant is family medicine in an academic or tertiary care institution. I think most of the audience here would be wondering. Family medicine is called a community-based, family-centered specialty, and what is the role in a tertiary care institution or an academic institution for family medicine? So I would like to go through this presentation simultaneously with explaining my journey through this over the last few years after I graduated, after I did my PhD. So what are the doubts that can come in anyone's mind? Why would a person coming to a tertiary care hospital seek a family physician's care when he had a choice of all specialties under the same roof. The next question is, what category of patients should be seen by a family medicine specialist in a tertiary care hospital? And the third very important question is, how can a family physician in a hospital provide patient-centered care in the context of the patient's family and community? Now, these questions were initially asked by doctors, staff nurses. I have seen people standing outside my OP looking at my board and asking, what is family medicine? What is family medicine doing in a hospital? And some people just barge into my OP thinking that it is an extension of the emergency department because I sit next to the emergency department. So there have been confusions regarding what we are doing in a tertiary care hospital. And we should not be reduced to a preventive health checkup unit. Those were the challenges. A family medicine OP should not be, the management, sometimes the hospital administration tends to limit us to a preventive health checkup unit or an employees or a staff clinic or a geriatric or palliative care unit. So we need to show that we can do much more than all these things in a tertiary hospital, which is very challenging, especially in a hospital in a city like Ernakulam, where there are 5 general medicine physicians, 3 pediatricians, 2 surgeons, 3 gynecologists. What is a family physician doing there? So with this, I can tell what we have done, the services that we do, and I hope it will be an inspiration to people who doubt the relevance of family medicine in a tertiary hospital. So first thing was a general OPD. I'll explain later what we do in a general OPD and what type of patients come. Then domiciliary or home care, community outreach clinics, medical camps. Medical camps can be supervised and organized by a family physician. School health, because medical camps, we know the population of an area and we know what their common problems are, and we can conduct a camp in such a way. School health, health education classes, health awareness classes, and of course, being an academic institution, we also conduct training and research in family medicine, which is a very important aspect in our hospital. So now the general OPD in a tertiary care hospital, general family medicine OPD. There are many patients who come to the registration counter or reception of the hospital with undifferentiated or multiple complaints. They don't know what to tell the staff. What is your complaint? Means I have this pain, that fever, this, that. So many complaints they might be having. So sometimes what happens is the first word that comes out of the patient's mouth is chest pain. And immediately the staff asks, you want to see a cardiologist? So they don't know who is a cardiologist. They'll say, okay, fine, we'll see a cardiologist. Or the other set of people who would have Googled and found that they themselves need a cardiologist. So there are other people who don't know, there are a category of people who don't know how to express their symptoms, undifferentiated or multiple complaints. Sometimes the registration staff calls me and asks, a 5-year-old child has come, madam, with pain in the leg. So can you see that? I said, okay, fine, send it to me. So they don't know, they cannot, the patients who cannot recognize whom to see, that is one area. Now, don't misinterpret as family physician is there to being a traffic police. It is like we can solve these problems. So such patients come in a tertiary hospital. That is one of the ways that we can see patients. The other way is a fast track OPD for patients unwilling to stand in long queues before other specialty OPDs. It might be a primary care issue. It need not have an expertise of a subspecialist. So they need not wait before the other specialty OPDs. They can very well see in a family medicine OPD. Then there are non-emergency patients presenting to the emergency department. That is why the administration has strategically placed the family medicine OP near the emergency medicine department, so that there are green cases, there are non-emergency patients who present to the emergency department who do not need an emergency care, and thus they can reduce the burden of the emergency department. Also for patients attending to the subspecialty OPDs for routine reviews, they need only to adjust their medications or to have their other concerns addressed. So they can be seen by the family physician. I also see women and child health issues, and minor surgical procedures are also carried out, like IND, sebaceous cyst excision, all those things. The most important thing when you work in a tertiary care hospital is a coordinated care with other specialists. You are also a specialist. I purposefully mentioned other specialists. You are a family medicine specialist and you can coordinate with other specialists. You are not inferior to them. There are some areas where your expertise is there, and in areas which you think somebody else's expertise is needed, you have to have a coordinated care with other specialists. You refer to them, discuss with them, they send the patient back. I always make it a point to tell my patients when I refer to someone that please come back and tell me what they said. And they very dutifully come back and tell. And they also ask me, the doctor suggested this, should I do that? That is the role of a family physician in a tertiary care hospital. Now coming to the domiciliary care, it is not just restricted to the palliative care patients. In a city like Kochi, there are so many flats and apartments, big houses where only elderly people are there. The sons and daughters will be NRIs, they will not be there. So they have multiple issues. It is not just a palliative care patient. It ranges from a minor issue like a pain or a cough or a fever. They would need to communicate to a doctor, and there is nobody to bring them to a hospital. It is not, there can be patients with financial issues also, but they may be, there is one set of patients who are financially well off with all facilities, but there is nobody to bring them to a hospital, or there is no time for the caregivers to bring them to the hospital, or they are not they're not mobile enough to be brought to a hospital. So we see all these patients at home. A team of doctor and nursing staff goes, and we cater to patients of different socioeconomic strata, from very financially poor to the financially rich, and the administration has given me the freedom to decide the fee range for this home visits. Of course, it's a private tertiary care hospital, so it is nothing is free there, but the freedom to decide the fee according to the financial status. Now, the community outreach clinics, that is also very relevant in a tertiary care hospital, because we can have satellite clinics in other areas from where we can see patients, we can resolve some of the issues, and if not, we can refer them to the main hospital where their problems can be addressed. We can direct them to the correct subspecialist. Also, the satellite clinics, there are a provision for dispensing medicines and lab services. We provide affordable healthcare to people who have less access to the main hospital. Most of our peripheral centers are located in island and rural areas. So these are in a teaching hospital like ours, these are run by the PG residents. They have a community posting there, and whatever issues they see, they inform me, and if they cannot handle it themselves, and that is how we manage it. So now this can be done in any tertiary care hospital, provided you have an understanding administrative team and a very well dedicated team of family physicians. So I do not think that there is no relevance. It is not a paradox. Family medicine in a tertiary care hospital is not a paradox. We can do many things in a tertiary care hospital. So what are the lessons that I've learned over these years? Training in family medicine centered at hospitals with dedicated department is definitely better than running around in other departments and being used as cheap labor. So that is one area in a tertiary care hospital. Community-oriented training can be provided through the satellite clinics, because the specialty is a community-oriented specialty. The different facets of family medicine, like continuous comprehensive care, patient-centered care, community-based care, preventive care, and health education, can be incorporated into a tertiary care setting like this for the benefit of patients and community. Thank you all, and I hope at the end of the panel discussion, I can take questions for the same.
Thank you, Dr. Rashmi. Yes, that was a very clear presentation of what a family physician specialist can do in a tertiary care center. The relevance of family physician has been clearly described. A lot of clarity has come up with that as far as working in a tertiary center for a family physician is concerned. Next, I'd like to invite Dr. Robbie Prasad, who happens to be my classmate during my MBBS days. Welcome, Dr. Robbie. Dr. Robbie runs her own clinic, Dr. Robbie's clinic in Calicut, for the past almost a decade. Over to you, Dr. Robbie.
Greetings to one and all. At the outset, I would like to thank the organizers for giving me an opportunity to talk on this specific subject, like what it means to be a family physician in Kerala. Whether it be Kerala or any other part of India or any other part of the world, I believe being a family physician is a totally different feeling. And whatever ideas I am sharing here today is all based on my experiences in my own clinic. I have a small clinic of my own. It's named Dr. Robbie's Family Clinic. I've been practicing as a family physician in my locality for the past 15 years. And for the past 3 years, I've moved into my new setup, which is my clinic. And I have an attached pharmacy and a lab that is outsourced. So whatever I'm going to share today is all based on the experiences I've gained as a practitioner for the past 15 years. And some of the experiences, especially when I started this clinic of my own. It is actually great to own a clinic of your own. Whatever be the setup, it need not be a very hi-fi setup. Whatever you can afford, whatever it be. But being independent is very important. And when you have an independent setting of your own, your experiences, everything is totally different. So whatever I'm sharing today is based on my experiences here. So first, I would like to talk about the rewards of being a family physician. So as all of you know, you are able to provide diverse and comprehensive care to all your patients. So it's not like any other specialist. Each patient you see is different. Each case you see is different. Reaching a diagnosis is a real challenge for us because the diversity of cases that we see, nobody can imagine. So when you're a cardiologist, only those people refer to you or come to you, you know it is a cardiac problem. So we are not like that. We have to hunt and reach a diagnosis. So providing diverse and comprehensive care is important. A reward, definitely a reward that we get as a family physician. Now, preventive care. Preventive care, I feel most of the patients don't appreciate the preventive care that we give. Definitely, we in this primary care setup are the ones who provide the maximum preventive care to the people around us. So by controlling the hypertension and diabetes, we are eliminating actually a lot of myocardial infarctions and CVAs and strokes. So, but people rarely appreciate it, or people, they don't understand that preventive care means a lot. When you prescribe a statin to a patient, the patient is reluctant to take it because he feels he doesn't have cholesterol. Though he's a diabetic, he's not willing to take a tablet for cholesterol. He says it's normal. Why do you have to take it? So you have to take time to tell him that by taking the statin, there are a lot of benefits. It's going to prevent an MI for you or a CVA for you. So that is our role in that preventive care. And I feel rather than more than more than the acute cases that we see. We have a lot of patients who are on regular visits to us. So this preventive care is an ongoing process in our clinics, in our practice. And then establishing relationships with patients and their families is very, very important. And I think that's the most rewarding thing that we get as a family physician. So that relationship, the rapport that you build with these patients and their families are sometimes very, very strong. Like I had even patients who come to us from casualties. There was a patient who had torsion testis, and he was advised orchidectomy, a young guy, and his mother came running to me from the casualty to ask me, take an opinion whether you have to go forward with the surgery or not. So that is the kind of rapport you need to build up with your patients. So establishing relationships is most important thing as a family physician. Most rewarding, definitely, when people recognize you from elsewhere. A lot of things like establishing relationship, the rapport with the patient is one of the most important things in your practice. Continuity of care, as I said, patients come back to you according to the kind of rapport you have with the patients. They'll definitely come back to you. Like wherever you refer them, wherever to whichever specialist you refer the patient, they'll ultimately come back to you with the prescription to see what is being done, to tell you what is being done, whether that has to be continued. So continuity of care, and we are able to provide the continuity of care also. Like you can regularly follow up your patients, those with hypertension, chronic illnesses, everything. You on a regular basis, you are able to you're able to see them and take care of them. And of course, you can receive ongoing feedback from them also. So feedback is very important, because from the feedbacks you can know your faults. You can improve your practice. You can stop making the same mistake. Definitely. So that feedback is immediate also. Even according to the rapport that you have built with the patient, even if the patient develops a drug reaction, the patient will definitely come back to you. If that rapport is not there, the patient will definitely go to a second person, another doctor, saying that that doctor has given me such and such a medicine and I have developed a reaction. But if you have a good rapport with the patient, that patient is definitely going to come back to you. So feedback is very important. Flexibility and control of practice. That is like for especially for lady practitioners like me, the flexibility and control of practice is a major thing in running a clinic like this or doing family practice, because I have people at home who are sick. So sometimes I may not be able to practice the whole day. So I take bookings I take patients only by appointment. So when they call, I can tell them that I'm not available. So, and control of practice also. You can control the number of patients you see. If I want to see 100, I can see 100. But then I need family time. I need time for my personal things. So everything can be controlled. So flexibility and control of practice is always there. Job satisfaction definitely is there, because I've worked in other settings also, like ECHS, Excelsior Polyclinic. So I've worked in such settings. There people come to you just for referrals. They don't need they don't want you to listen to their problems, or they don't want you to diagnose anything for them. They just need referrals. And it was not at all satisfying. And that is the one major reason why I left it. And I left it for good, I guess, because I built up my own clinic and my own practice. So job satisfaction is definitely there. Those people who need to see you will come to you. Otherwise, they won't come to you. And job security, of course, when you're running something of your own, nobody's going to chuck you out of anywhere. So job security, definitely. Acquiring and maintaining skills and knowledge. Each patient is different. Each day you're learning new things, so you can polish your skills. Of course, when you refer, you get a feedback from the specialist also. When you have good rapport with these specialists, they often, most of them write letters, thanking letters, everything is there. So building up rapport with the doctors around you is also very important. And gaining experience also, and mentoring. Challenges that you often face. One is definitely workload. That is there in any setup, not only in a clinic or in your general practice, even if you're working in a government setup, you know the workload. There the workload is much more than what we have. So workload and time pressure, definitely that is there everywhere. Meeting demands is another thing. Once you develop a rapport with your patients and your relatives, they expect something from you. Definitely, especially when you do home visits and then going to confirm deaths. All this, sometimes they come and call you in the night, thinking that you'll come, you'll go with them and confirm. I have had calls at 1 o'clock, 2 o'clock in the night, but then I cannot go at that time. So meeting the demands is definitely a challenge. So sometimes you might have to have conflicts with some people. So that is always there. So always you may not be able to meet the demands of everybody. Medical legal issues, definitely when you're sitting alone, it will be difficult. When you don't have anybody to discuss the case with, always you should have the numbers of a lawyer who deals with medical legal issues, or forensic person to ask an opinion whenever, in whichever case you don't know. So that is very important. Then ability to embrace uncertainty, I guess, is the most important quality of a family physician. You don't know what you are seeing. So from scratch, you have to begin and you have to reach a diagnosis. So that is there. Maintaining records when you're running a clinic, then definitely you have to maintain records. And taxes and licenses. Taxes, I don't know what to say. You have a lot of taxes coming in, like professional tax for yourself, your clinic, if you're a pharmacy, for that, the staff members. And throughout the year, you will have some taxes or the other. And of course, licenses should be up to date. Licensing procedures are actually very, very cool. But mostly it is complicated by the health authorities themselves, especially the health inspectors and all these people. Then mostly they complicate all these things. So all these are challenges when you're running your own clinic, when you're practicing in your locality. Of course, you have to maintain standards of treatment and insufficient financial compensation. That is most important. That is very, very important. Sometimes it becomes very important. Like when you are not financially stable, sometimes when you come into touch with patients who are very poor, so many of them will be very poor. You understand from what their looks and from what they're telling you, and you may not be able to collect your fee, or maybe you'll have do some blood tests for them for free. You might dispense some medicines for them free. So financial compensations may not be rewarding always, but then you have to be ready for that. And difficulty in meeting overheads, electricity bills and water bills, all these are, again, I'm telling you, all these are experiences that have come after I have started this clinic. So all this, not only as a family physician, even if you're a general practitioner, all these are coming as challenges. And balancing personal and professional life is another thing, but that is also very important. So being a family physician is equally challenging and rewarding. Being a good doctor, your time is what the patient needs. So be a very good listener. Patients, 80% of them come to you to talk to you, just to talk to you. In my clinic, I have very, very old people, most ladies and gents, with a lot of stressors, and they just want to come to you and talk to you. So be a very good listener. Community services become very important. When you practice in a locality as a family physician, you have to do community services. You have to do home visits and camps. You'll have to do all this. Disaster management is yet another thing, especially during floods. All of us were doing a lot of work. So all this comes, all these things comes as a part of your duty as a family physician. Of course, your attitude matters. Wherever you're practicing, whether in a corporate setup or in a private clinic or a small medical shop, or wherever you are sitting, your attitude matters. So if you are ready to serve, nobody can do anything to you. If you are ready to serve, you will have patience and you can run everything very, very smoothly. And you should be confident of your competency. That is yet another thing. You don't need to see what others think about you. You don't need to see what the specialists say. Nothing you have to worry about if you're confident of your competency, if you think you are doing the right thing. And you should be comfortable handling multiple patients with multiple medical problems. And you should be able to educate your patients as well. Education is a very, very important duty of a family physician. So when whoever comes, you educate them about quitting alcohol, smoking, etc. You should be able to educate them about their illness as well. So because only when you educate them, the preventive aspects will come into play. and make timely referrals. Should never hesitate to refer a patient when you feel that you cannot do it. So timely referral is the most important thing. Timely referral, because everything cannot be handled by SLO. So the most important 4 A's that becomes important for a family physician. You should be available, you should be affordable, you should be affable, and you should be able. Affable means you should be very friendly, you should be easy to talk to. That is very important aspect of a family medicine practitioner. So all the 4 A's are very important to us. So I hope something I was able to convey to all of you in my sharing all these ideas with you. Thank you so much.
Thank you, Dr. Robbie. I think family medicine, as it was envisaged, the classic concept of family medicine is of a doctor working in a locality taking care of families in and around that locality. Of course, now the scope has widened. Family medicine has found its place in various sections of the medical field, not only as a private practitioner, but in hospitals and in various other sectors also. But here, Dr. Robbie, by sharing her experience as a family medicine specialist working in a locality adjacent to a home and caring for families, seeing them over and over again over time, and building up a good rapport, providing continuous care. That has really highlighted the classic concepts of family medicine here. Thank you, Dr. Robbie, for sharing your experience with us. Next, I invite Dr. Prashant, who is working as a family physician in Bhatia Hospital, Perumbavoor. I invite Dr. Prashant to share his experience with us.
Good afternoon to all. First of all, I would like to thank AFPI Kerala and AFPICON Kerala 2022 organization for giving me this opportunity to participate in this panel discussion. And it is my first panel discussion, so kindly bear with my errors. I would like to take this opportunity to discuss with you my experience as a family physician till now. I completed my DMD in 2017 from Medical Trust Hospital, Kochi. So like all the postgraduates, I was thinking about getting a proper family medicine job after completing my PG. But incidentally, I got a job call from one of the multi-specialty hospitals in Kochi for working in their medical oncology department as a specialist. As one of my seniors was working there and she was leaving, and they wanted another person to replace her. So I was confused. My thoughts were like, this is my first job opportunity. I haven't finished my PG yet. So what to do? Then after thinking for a long time, I thought this medical oncology department is something that it's a specialty that we are not exposed to, that we are little exposure during our UG or PG period. And so I thought it's an opportunity to acquire knowledge which might help me later in my practice. So I decided, okay, I will join there. And so I joined there and started working there. But even after joining, I always wanted that I want a proper family physician job and I continued to search for the job, and I had sent my resumes to almost all the hospitals in and around Kochi. At the same time, I used the opportunity to increase my knowledge and about oncology and palliative care while I was working there. And finally, after 1 year, I got a call from another hospital in Alua for working as a consultant family physician. So without thinking, without any thoughts, I just resigned my job in medical oncology and just joined there. But I couldn't continue there for more than 2 months. I had to resign because of some issues with management. And again, I became jobless. So, like everybody, obviously, we need a job for living, for earning a living. So I thought, okay, I sent my resume again to all the hospitals, but no reply came. I thought of joining back in medical oncology, and I was about to join, but at that time I got a call from one of the hospitals in my hometown that they need a physician in their hospital. The moment I heard the word physician, I told them I'm not an internal medicine specialist, I'm a family medicine specialist. So, are you sure you want me as a physician in your hospital? I asked them. Then their reply was like, we are more comfortable with a family physician in our hospital. And hence, that's why we called you. Okay. So I thought, okay, let's give it a try. And hence, I joined my present hospital in 2018. And now about my present hospital. It's a secondary care hospital with 100 beds and mediocre ICU. When I joined there were around 4 gynecologists, 4 pediatricians, 2 general surgeons, 2 orthopedicians, 3 ENT specialists, 1 dermatologist, and 1 senior internal medicine specialist. This was the total doctors in my hospital. Now I had to work in the medicine department as a physician. So I went and met this senior internal medicine specialist. It was more than supportive to me. She said, it's a great thing that you have selected this specialty, and it's an upcoming specialty, and try your level best to practice the family medicine while you are working here. So I was very happy, and a unit was assigned to me, and I started my practice. So after I started my practice, I started getting all sorts of patients. I was seeing almost all the medical patients coming to the hospital with medical cases like this fever, cough, diabetes, hypertension, everything. The other specialists were also approaching me for giving fitness to the surgery, and the gynecologists were sending gestation diabetes mellitus, pregnancy-induced hypertension, all those cases to me. I was managing them, and I started treating bedridden patients and was conducting home visits during my free time, and slowly I created a patient log. Then people started coming to me with their family members. One day I saw 5 patients from a single family with different problems and different age groups. Some patients started showing their gynecological, pediatrical, and surgical issues also to me, even though the other specialists were available in the hospital. So I established a family practice, and I'm also my place is well known for having a number of migrant workers, and I also am having a patient load among the migrant workers also. Maybe because I'm speaking a little bit of Hindi also. That might be the reason, I don't know. Anyway, so the tertiary care hospitals I had worked earlier is now sending me patients who are natives in my town and getting treatment there to manage their non-specialty problems according to them. I'm getting terminally ill patients like CKD, CVA, post-chronic malignancies, etc. from these hospitals for terminal or supportive care. And I'm happy that when the patient load increased, my hospital hired another family physician who was my junior in Medical First Hospital. And together, we were in charge of the COVID patients who are coming to our hospital. And together, we have treated around 500 COVID patients till now. And overall, I am doing my level best at present to practice family medicine in the best way that is possible for me, and hope to continue that in the coming years also. Thank you for your patient listening.
Thank you, Dr. Prashant. Next, thank you, Dr. Prashant. Your presentation was good in the sense that how the growth of a family physician from a secondary care center, like the hospital you're working, the ability to convince both the management and the patients who have come to you, and how the families started trusting you, and how you were able to expand your patient base. So that that really shows that it's possible to establish family medicine even in secondary care centers. Next, I would like to invite Dr. Shahzad, who's working in the Kerala Health Service Department, to share his experience as a family physician. Welcome, Dr. Shahzad.
Thank you, Dr. Anand. I hope I'm audible.
Yes.
I'll share my screen. I have the screen is visible now. All right.
Yes. Yes.
So, thank you first of all for choosing me to talk and represent the family physicians working in the health services department in Kerala. Being a family physician in the government sector is, I think it's one of the most challenging jobs as far as a family physician is concerned, working in the state. I joined the health services 4 years back, right after my post-graduation, without a big gap. So I actually joined the services knowing the restrictions and the limitations which a government job would offer me, and it was just a leap of faith. Let us go to what actually a doctor, not a family physician, what a doctor feels like to be in a health services department. So regarding the nature of the work, first of all, it depends on the cadre which you select. You join as a general doctor, as a designation of an assistant surgeon, and thereby after a few years, you get to select your cadre according to your qualifications, and then you can either go for a general cadre, which is just a duty of a general medical officer, or if you have a specialty, you can choose your specialty cadre accordingly, or if you want to work in the administrative cadre without a clinical touch, then you can go for an administrative cadre provided you have the qualification for that. And your work and your job nature mainly depends on which cadre you take. And as far as the work timing is concerned, I should say it's relatively comfortable provided the work hours you are assigned to. But as a government doctor, you are ideally on 24 hours duty. So that is what makes it difficult, and that is why a government job is considered stressful, because it's not just the clinical hours that you work which is counted. You are ideally on 24 hours duty, 24/7. So, and again, the work timing depends on which post you are working in. like even while joining, if you are working as an assistant surgeon, as a general medical officer, you are mainly assigned with the conducting the OPDs and the related stuff in the concerned hospital, be it a PHC or a CHC, community health center, or a major hospital. And if you are working, you can be even assigned as the job of a casualty medical officer. Again, there the work timings is different. You will have prolonged work timings at a stretch, maybe 8 hours or more, depending on the shift you take, and you accordingly adjust your leaves depending on the work hours you have. So now, considering the pay, you actually pay decently for the hours you work, but your pay is not based on your skill. It's rather based on the years of experience that you have. I mean, the years of government service. So if you think you are a well-skilled person, you have a very much enthusiasm to put in your skills, you should be passionate about getting about being able to put in your skills and being helpful, and but you should not be expecting the returns in terms of pay. And of course, there are stresses like the first thing, depending on the nature of work. You can have administrative tasks even if you are a medical officer at a PHC. You can be a single medical officer at a PHC. If you have even if you have a team of doctors with you, you can have additional administrative tasks. So that gives you again political stresses which are out of context of your clinical works. So those stresses come to your home actually. Even while you're at home, it takes a lot of time from your home time. And of course, to say there are no corporate stresses, but you do have stresses in terms of political stresses as well as other stresses from the job. And you have a lot of privileges. The first thing to mention is definitely the pension, but then now the pension schemes have changed. Again, it's not as attractive as before. You have ample leaves, and you have a provision to have home-based private practice, and which gives you a good connect with the community around you. So this is generally how a doctor feels to be in a health service department. And this is what I feel, this is why kind of what I expected when I joined. And the scope of services you have in a government setup, of course, the outpatient, and depending on the hospital setup, you can also have inpatient services. You are definitely very much directly connected with the national health programs because you are the deliverant, and outreach sessions are a major chunk of your work, which includes outreach visits of any institutions around you. Whichever institution needs your involvement or needs your service, you are bound, and you can offer any services you can. This includes old age homes visits, destitute home care visits, destitute care homes visits, and palliative visits, school health visits, immunization visits. Whatever you can think of, any outreach sessions you can take up. And regarding the awareness classes you can provide any type of awareness classes to the public. Any new issue comes up in the community, any new disaster comes up in the community, you're bound to give awareness regarding the situation to the public at large. And of course, community participation. Whatever job you do in a government setup, you are always in contact with the community. Be it the hospital, you have a hospital management committee there, which has representatives from political parties, the locally relevant political parties, and even the residents around the hospital and the neighboring area. So they have a big role in maintenance of the hospital, of the government hospital, and you have you have to be in constantly good terms with them to have a good job atmosphere. So these scope of services definitely, it definitely looks like what a family physician should be having ideally. But of course, there are some catches. So let's take it from the family medicine perspective. I've just put out a few principles of family medicine, which we are very much interested in delivering in our practice, day-to-day practice. And there are a set of assets that the government health services can provide, and of course there are barriers which are the prime concern for us in having a good practice of family medicine in a government setup. The first thing what comes to our mind is giving a comprehensive primary care and a person-centered approach. So in both of these, what counts most is the personal competence. So if we are personally competent and if you are personally interested in giving a comprehensive primary care and being person-centered in all our activities, I have felt it's not so difficult. It's not so difficult, and I think it's rather easy to have a person-centered approach, because the clients you have in a government setup, they can easily trust you as a doctor. They easily trust you as a doctor, and you have that privilege to maintain a very good rapport with all the persons around you. But and even in the OPD, considering the types of cases we have a wide variety of, you can expect any type of health problems that is coming up to you, any type of problems that you can imagine of. And you can be of help to them in a lot of ways, because the government has facilities for all types of health problems. The only thing is that you should know where to send the patient, you should know how to send the patient, and you should know whom to get the patient to. But of course, the main barrier to this thing is that we are having a very huge patient load in the government health services, whichever hospital you're working. There are only a very few hospitals in the rural most areas where you have a comparatively convenient or comfortable rather patient load, so that you can actually put in all the effort for a patient. So regarding the coordination of care that you give, our network of field-based health workers are the biggest asset when we consider this thing. So these field-based workers include the health inspectors, the junior health nurses, and the ASHA workers, ANMs. All these are there to support you in your work, and whatever service you deliver from the hospital, it gets continued to the community through these workers. And if you have a very good set of field workers, you are fortunate enough to have consider that as a very good team, because along with them you get a good community participation in whatever thing you do, whatever service you offer. So considering the evidence-based healthcare that you provide, of course, the government has standard treatment guidelines. The government provides regular trainings on various matters on a regular basis. And even when it comes to newer issues or recently we have the COVID pandemic going on. Any COVID update, you ask the government official, he is updated about that. And we have all that. And in addition, we are connected with the national health programs. There are more than 14 health programs. Actually, we have only a few health programs that are mainstream, and those mainstream health programs are very much taken care of by the government facilities. So you have all that, but then again, the standard treatment guidelines are not much looked into by the, I should say, the doctors in the government health facilities. We know what we're doing, but compliance to the standard treatment guidelines, I think that's a doubtful thing, because we don't get much time to check every standard treatment guidelines every now and then, and it gets updated only once in a while. And regarding the national health programs, like I said, we have a few mainstream health programs. Those are taken care of well, but then there are other health programs which are rarely looked into. Some health programs like the blindness control program or deafness control program. These are actually this could be implemented into the most peripheral centers, but then unfortunately we are not being able to put in complete efforts to do justice to these health programs. So regarding the equitable resource utilization is a major problem, is one big problem in the government health service. Actually, the motto of government service is to provide affordable and accessible services to all citizens of the country. But I should say the resource utilization is improper and inadequate due to many reasons. And we are actually working along with the local self-governing bodies when we take any services we look into, and that gives us enough support to put in our efforts. The family and community-based care is one important thing that we are always looking into. Again, the field-based workers help us there, and a very good community participation is there, like I said, in all our activities. So that is taken care of well. Continuity of care, you have the network of field-based workers there, and you have provisions to refer patients to higher centers whenever needed. But this referral system is disorganized. One thing is because not just the peripheral centers which are overwhelmed with the patient load, the tertiary centers are again overwhelmed by the patient load, and you don't have a proper back referral system or a properly designed referral system to have a continuity in treatment when you're sending a patient to a higher center and to get him or her back. So that is a big problem there. And again, you're providing all the things. Suppose you're a family physician working in your center, you're making the system better there in the hospital, you're implementing new things, innovating new ideas, and you create a work culture there which has not been there, and after a matter of maybe 3 to 5 years, you get transferred from that place. So there's every chance that the work culture you bring out there gets destroyed in a matter of months or maybe years at most. So maintaining that work culture is a big challenge, and then you go to a new place, you have to build the culture there, you have to make the system better there. This is all because we don't have a system in place to implement the family medicine concept properly. So the dark side, just summing up, we don't have a proper career path in family medicine in the government sector. Yes, there is no dedicated post for the FM specialty, which is the major problem we have. And because of that, we have an unclear path from the FM family medicine perspective, but you have alternative paths to choose depending on your interest. Once you get into the health service, there are a lot of paths you can choose, and your interest might vary from time to time. And I personally chose the quality assurance related work because I was interested in that, but I also try to maintain a family medicine perspective by doing my job as a family physician in the center I'm posted. Right now, I'm totally deputed as a nodal officer, but then I hope to get back into my parent hospital to work as a family physician as well. I definitely look into that. And regarding the quality of care, like I said, there is no dedicated family medicine OPD. So this creates an unawareness of the specialty among the population, and the specialty is actually underutilized. The skills and the scopes of the specialty is totally underutilized. And that is why just before Dr. Robbie had said she had worked in a government setup, but then while sitting there, you have a lot of things to do for your patients coming to you, but then they come to you maybe just for a referral. You get disappointed just by their attitude. The patient comes to you, he or she has some problems that we can genuinely take care of, and I believe much better than if the patient goes to a tertiary center. But because of this unawareness and because of this unawareness of the specialty among the laymen, our specialty, the scopes of our specialty is being underutilized. And whether being able to deliver a person-centric care is questionable. We have a heavy OP load, and this makes a very inadequate consultation time. Again, a very bad deterrent for maintaining a person-centric care. Another thing is whether we can have a continuity of care. Yes, we are prone to have a discontinuity of care. One thing is because we don't have a dedicated family medicine OPD. So the next time a patient comes, he or she might not be coming to us. The patient might go to a different doctor or a different OPD or a different hospital. And another thing is, like I mentioned, we have a disorganized referral system. We have provisions for referral, but then the referral system has to improve a lot. And like I said earlier, the workplace transfers. So in a nutshell, there are many positive things. There is a lot of scope to be happy that you're working as a government doctor. I personally feel very satisfied in those terms to deliver accessible, affordable healthcare for all patients that you meet. Not just patients, for all the clients that are, qualifying for any services that the government has to provide. Now you can have a work-life balance provided you find time for that, provided you put in the right effort to maintain a work-life balance. There is nothing that can take you away from that. But you have to put in effort so that you find time to live. And regarding the job security and privileges, like I said, the job is secure. Of course, there's no question about that. And you have a lot of privileges which comes along with a government job. Now, like I discussed before, the career path is yet to establish, and to maintain a good, proper quality of care is difficult. To sum up, government health services is a very fertile ground to practice family medicine, but the policies are yet to turn positive for the specialties. And we have given our representation by AFPI to the government of Kerala, and we are constantly following up it very closely, and we are definitely hopeful, and we have seen very positive responses. Thank you.
Thank you, Dr. Shahzad, for that briefing on the scope of family medicine and Kerala health services. Yes, I agree with most of your points. Patient load is a big concern. So quality tends to get compromised, though certain other features like continuity of care, comprehensive care, affordable and accessible healthcare, etc. are there. Some other lacunae does remain in government circles. And as I always keep saying, government approval automatically translates into public acceptance. So when we have an official acceptance from the government to include family medicine in specialty in healthcare, health services, that public will start realizing the presence, and more people will start asking for family medicine OPDs and approaching family medicine OPDs. So this is evident from the attitude public show towards family medicine OPDs in private sector, as Dr. Rashmi, Dr. Robi, and Dr. Prashant have shared, as they have spoken their experiences. So let's hope that Kerala Health Service Department and the government takes note of our the representation that we have given to the government, and hope something positive turns out. I'd like to see if there is any messages. As of now, I don't see any messages in the chat box, any questions. And does anyone in the panel, any of the panelists want to tell more about this, elaborate any more points? You're welcome.
Hello. Since the panel discussion is over, I would like to tell a few more things. That is, like about the continuity of care, that I think most of us did not stress. Maybe Dr. Robi and Dr. Prashant stressed. But Dr. Shehzad said that it is nearly impossible in government setup sometimes. And in tertiary care hospitals also, you may be wondering whether the patient comes back to a family physician for the same, for other complaints. Yes, it happens. Even in tertiary care hospital, they come to you for other opinions. I think I should tell an anecdote because time is there. Dr. Anand, can I go ahead?
Yes, please, madam, please.
Yeah, there was a patient, a young male, around 30-year-old, who came with a neck swelling, and they did not recognize that it was a swelling. They were just telling that there is a fullness of the neck. And then on examination, I found that it was matted lymph nodes. And we had to do a biopsy, and I referred to the surgeon. After seeing the surgeon, the patient came back to me and said that I didn't understand what the surgeon said. He just told something, and he wrote me a sentence on the prescription paper saying FNAC. So what should I do? What is it? The surgeon didn't tell anything. So I had to explain from the beginning, yes, this is a lymph node, this has to be done, this has to be done, this has to be done. Okay, fine. So they agreed to do the procedure, testing. And then finally, after the test came, they went to the surgeon again because the surgeon had called for the review, and they went to the surgeon again, and the surgeon said, okay, post it for this and this. So he came back again and asked me, madam, doctor, what is this? I didn't understand. What is my diagnosis? What do I have? So then I said it is a tuberculous lymph node, and now since it has become an abscess, this has to be done, this has to be done. And meanwhile, you have to be started on ATT, which the surgeon did not explain at all. And I had to start on ATT. Then the wife said, we are very poor, we are from Vadagara, and we are here for some other thing. So I said, I explained about the government setup for treating tuberculosis, and I wrote them a referral letter to the district tuberculosis center, parallelly going with the other things. Then they again, after some time, when the surgeon called for the next review after the procedure and all, they went to the surgeon again, and he told them, who told to start these medication, this because he was totally outdated in the TB treatment, and he was telling the old guideline and all. And then the patient got confused again. But every time the patient came back to me to cross check what was right. So then I told, okay, this is a new thing. You have to take treatment for like this. And even now, this happened in 2018 maybe. And even now, this patient comes to me every time he comes from Vadagara to Cochin. He finished his anti-tubercular treatment on time. Everything was done, and now he's very much healthy and working well. His wife had a delivery. They came to tell me that the wife is pregnant. They came to tell me that the delivery is over. Now the wife comes to me for all minor gynecological issues. And one day they called and asked in my OPD, are you, madam, will you be there on that day? I said, yes, I have shown some other doctor, but I just want an explanation. So can I just get an explanation from you? Only for explanation. I said, okay, come, I'll give the explanation for that. So that is how it works in a tertiary care, even in a tertiary care hospital where there are other specialists who may be managing the main issue, but the main issue for the patient is not the diagnosis. The main issue for the patient is they should know what is happening to them. They should know how it can be tackled. They should know, they should have somebody to explain to them. There was also another case of melioidosis fever who is again visiting me every month now. The same thing, the communication skills that we have learned, I think we can put into practice even in a tertiary care setup with all the other specialists and all the other challenges that we have. That's all I have to say.
Yes, thank you for sharing that wonderful experience, madam. Yes, this is one common feeling that most people who practice family medicine, regardless of whether they have a qualified degree in family medicine or not, that attitude matters, and any doctor who has this attitude will have such incidents to share. This is very heartwarming, and the essence of being a doctor, we realize that the essence of being a doctor is really fulfilled. And one thing, continuity of care is possible in health service especially when you're working in primary health centers or community centers, where you tend to meet the same person, same family members over and over again. So that is possible to a good extent. And as Dr. Shada has very beautifully illustrated in one of the slides, the assets and the barriers and the targets. And that slide very well reveals how far it is possible and how far it is not possible to achieve the goals of family medicine. Anything else to add, Dr. Robbie, Dr. Prashant?
Dr. Anand, actually, I totally agree with what Dr. Rashmi is saying. Like most of the doctors, they don't take time to explain to the patient. Actually, I won't be able to switch on my video because my net is not very great. So what Dr. Rashmi said, most of the doctors, they don't take time to explain to the patient what's happening. And we are the people who do it actually. And that is why, that is the most positive thing about us. And very happy to hear that Dr. Rashmi is doing so well in a tertiary care hospital, because I always believe that we don't have much to do in a tertiary care hospital. But from what she said, I believe we can do wonders everywhere. And that's very, very, very heartwarming to hear. Thank you so much, Dr. Rashmi.
Yeah, I think this panel discussion is an eye-opener for even members of AFPA and other family physicians.
Definitely. Yes, the juniors who are attending
various sections. Yeah, especially for juniors. Yeah.
Yes, juniors.
Anything else to add? We have almost 20 minutes more to go till 1:30. We have time. I don't see any message. Any doubts? Kindly forward all your doubts. As
I'm Dr. Ishmi. I have another doubt to Dr. Prashant. My doubt is, it is not a doubt actually. Can you say a few encouraging words to the young family physicians? Because you have very clearly explained how you were going through a job hunt. So what you learned from that about how people perceive family medicine in Kerala and how am I muted? Did you hear me?
Madam. Can I?
Yeah, I'll tell again. I just wanted Dr. Prashant to elaborate to the young family physicians about your job hunt and what they should be careful when they search for a job that fits their degree, postgraduate degree, without getting stressed or without getting dissatisfied.
Madam, actually, I had already said that I was I was almost made up. I had made up my mind that I should be a family physician. I didn't want to work anywhere else. So when I had finished my PG in 2017, it was very difficult for me because as FM was not that accepted at that time, I think. So I actually went to another hospital also during my job hunt. They had a vacancy, and I approached them, and they told me like that, the medical director there, she told me that you are a good family physician. I know that my many colleagues are family. She was a sister. Many colleagues are family physicians, are working in North India, and they are doing good job. But the physicians in our hospital are not keen in appointing a family physician in their department. Like that, they told me. So I encountered so much such problems during my job hunt. So my advice to the new upcoming postgraduates is that you should not compromise their degrees to work in a place which do not recognize you as a family physician. You should work in a place that they should appreciate your work as a family physician. Only you should work in those areas that they accept you as a family medicine specialist.
Okay, thank you, Dr. Prashant. Any other feedback? Please share any questions in the chat box if there are any doubts, any clarifications. If there isn't any questions, then should we think about winding up the session?
Hello, Dr. Anand. Just put a few.
Can someone give an opinion on this?
Hello, I hope I'm audible.
Yes, yes.
Yes, one thing about being just like what Prashant said right now, that to work in a hospital where we are being recognized as a family medicine specialist, to recognize what work we do and to recognize our skill sets. So I had mentioned that among the laymen, the awareness of the specialty is developing. It's low, but it's developing. We have been able to show our presence by many means. And even though the awareness is low among the public, we also know that the awareness is low even among the colleagues, among the doctors, what family medicine is and what actually it is. I have even had spoke with doctors who had even one doctor had come to me and he had asked me whether we're dealing with any genetic diseases or something like that, because we are named as family medicine. So something related with, something that goes as a trait or familial inheritance and etc. That is a level of awareness among doctors. So, but then while working in a government setup, what I feel is that I had been working in a family health center for the past 4 years. Had recently transferred from one center to the other, both are family health centers. And both of these places, they appreciate the work what we do. Because like I said, we get all kinds of health problems to the OPD. So these are colleagues there, my colleagues there, they used to, whenever a difficult case comes, they show no inhibition to ask us or get our help, because they feel we know something more from a different level, and they ask us our help regardless of what the disease is. Even the patient might be coming with something the patient wants to maybe consult a super specialist or something. But then even if that is the case, the colleagues there, they discuss the problem with us and they get our inputs. So it's very rewarding to see that our colleagues, after a while working with them, if they genuinely find interest in knowing what all we know and what all we can do, they would definitely accept what family medicine is, because it's not encroaching into other specialties. It's something different. So they definitely do accept, and I hope that it will be much more brighter in the future. So even if there are hospitals that does not, or if there are atmospheres that does not accept family medicine, I know of some places, but then we are definitely hopeful that the things will change, because once someone works there and once someone realizes what we are actually intending to do in a genuine manner, they will definitely accept us. And regarding the representation we had given to the government, the one thing that we're short of is the numbers. In the government sector, we are short of numbers of the qualified family physicians. So there are restrictions for what all we can ask for as a specialty, because we are small in numbers. But then again, we have given a representation to include our specialty in whatever possible means they think it's wise to do. And they have assured us to involve us in further discussions, if possible, that comes up in the government level. And we have assured our presence there. And one thing we have suggested is to include our family medicine, the specialty, at the level of community health centers, or a better term recently which is being used is a block health center. That is a family health center. There is a family health center which is a block family health center, one such center in a block, in a health block. So these places are ideal to have develop an organized referral system, wherein we can actually take care of a wide variety of health problems with our OPD, with the help of our OPD. And we can actually help the tertiary systems to decrease their load, because a lot of referrals, unwanted referrals rather, are being sent to the tertiary centers, which could have been managed in primary care setup, if such health problems could have been managed better by those doctors, or by the doctors working in the primary care setup. So such referrals can be actually well filtered while working in a block family health center level. Another thing we have suggested is to incorporate the family health, family medicine department at the major hospital levels, which does not replace the general OPD there, but it definitely helps the general OPD there. And our department, the family medicine specialty, can be a supervising department of the general OPD. So that way we can actually work out, just like Rashmi Madam had said, how family medicine works in a tertiary setup in a private hospital. This can be actually adapted to a government tertiary setup in this way, so that the general OPD can be improved a lot in terms of the quality of care given. Just to add this point, thank you.
Yeah, as Dr. Shahzad said, the representation, the general OPDs right now in health service department is being run by assistant surgeons who might have qualification in other specialties but are working as assistant surgeons. So instead of being run by assistant surgeons, if there is a qualified family medicine person, he or she can be interested to run the general OPD. So that has to be seen as a specialty. General OPD has to be seen as a specialty, and maybe if the government permits, that can be renamed as family medicine OPD. And as Shahzad said, maybe a single person might not be able to handle the full load. She can be assisted by surgeons. That is one option. And another idea is to start evening OPDs, family medicine OPDs, during the evening hours or afternoon hours in major hospitals, because otherwise the casualty is overburdened. Casualty is overburdened by all non-emergency cases also, and also due to so there a family physician to a good extent can cover and solve most issues which are not restored. And in primary health centers and community health centers, family medicine can take up the lead role, provided we have adequate numbers. So hope the government and the AFPI can and come to a amicable solution and improve the scope of family medicine and health services also. Any more points to be added? Dr. Rashmi, then can we wind up the event session?
Yeah, yes, I think.
Yeah, I think that leaves us a little bit more time for lunch. The next session is to resume at 2 o'clock. I think Dr. Indu is dealing with numbers, formulas in practice. So we have close to 40 minutes left. I think we'll wind up the session for now. Thank you to all the panelists, Dr. Rashmi, Dr. Prashant, Dr. Robbie, and Dr. Shahzad, for beautifully illustrating your experiences and coming out with valid and very eye-opening viewpoints on in your respective work areas. Thank you to all the listeners. Thank you, one and all.
Thank you, Dr. Reshmi ma'am, Dr. Robi ma'am, Dr. Shahzad sir, Dr. Prashant sir, for being part of an excellent discussion on what it means to be a family physician in Kerala. Thank you, Dr. Anand sir, for being the moderator for this session. Thank you, one and all. Now let's all break for lunch. The post-lunch session will start at 2 p.m. sharp. Thank you.
Affection lies in small details. Comfort lies in small details. Confidence lies in small details. Comfort lies, beauty lies in small details. Welcome to Microlabs, where health lies in small details. It was with this core value that Microlabs was incepted in 1973 by the late Mr. G.C. Surana. Today, Mr. Dilip Surana and Mr. Anand Surana bear the torch of creating a healthier world by making Microlabs a growing transnational organization. Ranked 10th in prescriptions and 20th in sales. Microlabs has a brand portfolio that comprises many top-notch brands in various specialties. We focus on building mega brands which trifurcate into the acute, chronic and specialty segments. Our numerous products range from oral solids, oral liquids and topicals to injectables in specialties like cardiology, diabetology, CNS and many more. The Indian market is a key operating area, reaching out to a large customer base of 200,000 from super specialty to family physicians. Our reach spans from metros to towns, living up to the core value of providing good quality medicines at affordable prices. Mr. Dilip Surana, CMD of Microlabs Limited, received the Dynamic Entrepreneur of the Year in 2010. Microlabs Limited won the Company of the Year. And amidst our proud achievers is Dolo, an award-winning brand highly prescribed for fever management. Even as we take great pride in our achievements, we take pause to also give back. making significant contributions towards the betterment of society. From the Micro Knowledge Academy, where scientific programs, CMEs, etc. are conducted for the medical fraternity, to the Sri Parshva Sushil Dham in Bangalore, managed by a trust founded by Mr. G.C. Surana, to the Surana College, an initiative by the managing trustee, Mrs. Archana Surana, carrying forward the vision of providing high-quality education at undergraduate and postgraduate levels at a nominal fee. Today, we at Microlabs are fueled by a single zealous vision of attaining the $1 billion mark by 2016. We are confident that we shall achieve our ambitions because attention to details is given utmost priority. Thus, at Microlabs, safety lies in small details. Clarity lies in small details. Dedication lies in small details. Perfection lies in small details. Microlabs. Health lies in small details.
Heartiest congratulations to AFPA Telangana team for hosting the 5th National Conference on Family Medicine and Primary Care. I'm immensely privileged and honored to be part of this event. The theme of the conference, Post-COVID Strategies and Strengthening Primary Care and Public Health, cannot be more appropriate. It's a well-established fact that the countries with a strong primary healthcare system have better health outcomes and health indices. For some reasons, primary care sector in our country is ignored over the years. But the ongoing pandemic has brought the limelight back on the importance of a strong primary healthcare system. While the media and the public was applauding the tertiary care hospitals for the way they handled critical cases, the primary care workforce have been working silently and relentlessly doing their best. It may be noted that the primary care physicians are the most vulnerable link in the chain of transmission, being the first point of contact, and they have played a key role in containing the epidemic effectively at every level. Whether it was COVID testing and contact tracing, treating and monitoring the home isolation cases, or even vaccination at public sector has seen the primary care physicians taking the lead. It's commendable the way the primary healthcare centers have organized themselves for the ongoing vaccination drive. Through this conference, we wish to impress upon the policymakers to empower and involve the primary care physicians, especially the AFPI, in all such decisions-making, policy and implementation process, to push family medicine and primary care to the level which it truly deserves in India. Thank you.
We are in the midst of severe health crisis. Thousands of people have lost their lives. We, the family care physicians, primary care physicians, are in the forefront of the healthcare services. We work continuously for days together, away from home and away from our children. During this process, many of our doctors have lost their lives. They sacrificed for the cause of the suffering, the cause of the patients. We have made significant changes in clinical practice. We stood by Hippocratic oath to look after the communities that we live in. And today, the main goal of us is to defeat the pandemic, consolidating the gains that we have achieved so far. We would like to advance further for a better healthcare system. With this lofty aim, we are organizing our national conference where all the issues related to the healthcare system will be discussed, and we will rededicate ourselves to the cause of the patient care and the well-being of the people. Thank you.
Affection lies in small details. Comfort lies in small details. Confidence lies in small details. Beauty lies in small details. Welcome to Microlabs, where health lies in small details. It was with this core value that Microlabs was incepted in 1973 by the late Mr. G.C. Surana. Today, Mr. Dilip Surana and Mr. Anand Surana bear the torch of creating a healthier world by making Microlabs a growing transnational organization. Ranked 10th in prescriptions and 20th in sales. Microlabs has a brand portfolio that comprises many top-notch brands in various specialties. We focus on building mega brands which trifurcate into the acute, chronic and specialty segments. Our numerous products range from oral solids, oral liquids and topicals to injectables in specialties like cardiology, diabetology, CNS and many more. The Indian market is a key operating area, reaching out to a large customer base of 200,000, from super specialty to family physicians. Our reach spans from metros to towns, living up to the core value of providing good quality medicines at affordable prices. We believe that an eye for small details paves the way for better quality work. We value every vial, every medicine that leaves this organization. As a result, our quality control measures have received several accolades. Attention to detail is the soul of our R&D. Our dedicated R&D centers have 1 API and 3 formulation centers. The research team consists of more than 200 scientists, pharmacists, analysts, chemists, and microbiologists. Microlabs has bagged prestigious regulatory approvals from the USA, Australia, New Zealand, Canada, South Africa, the UK, Colombia, Indonesia, and WHO. Ample testimony to our world-class quality. Understanding and managing people lies in small details. The Micro Leadership Academy is one such place where internal talent is identified and groomed to lead the company to exemplary success. It is this attention to details that has led to many achievements. Mr. Dilip Surana, CMD of Microlabs Limited, received the Dynamic Entrepreneur of the Year in 2010. Microlabs Limited won the Company of the Year. And amidst our proud achievers is Dolo, an award-winning brand highly prescribed for fever management. Even as we take great pride in our achievements, we take pause to also give back, making significant contributions towards the betterment of society. From the Micro Knowledge Academy, where scientific programs, CMEs, etc. are conducted for the medical fraternity, to the Sri Parshva Sushil Dham in Bangalore, managed by a trust founded by Mr. G.C. Surana, to the Surana College, an initiative by the managing trustee, Mrs. Archana Surana, carrying forward the vision of providing high-quality education at undergraduate and postgraduate levels at a nominal fee. Today, we at Microlabs are fueled by a single zealous vision of attaining the $1 billion mark by 2016. We are confident that we shall achieve our ambitions because attention to details is given utmost priority. Thus, at Microlabs, safety lies in small details. Clarity lies in small details. Dedication lies in small details. Perfection lies in small details. Microlabs. Health lies in small details.
heartiest congratulations to AFPA Telangana team for hosting the 5th National Conference on Family Medicine and Primary Care. I'm immensely privileged and honored to be part of this event. The theme of the conference, Post-COVID Strategies and Strengthening Primary Care and Public Health, cannot be more appropriate. It's a well-established fact that the countries with a strong primary healthcare system have better health outcomes and health indices. For some reasons, primary care sector in our country is ignored over the years. But the ongoing pandemic has brought the limelight back on the importance of a strong primary healthcare system. While the media and the public was applauding the tertiary care hospitals for the way they handled critical cases, the primary care workforce have been working silently and relentlessly doing their best. It may be noted that the primary care physicians are the most vulnerable link in the chain of transmission, being the first point of contact, and they have played a key role in containing the epidemic effectively at every level. Whether it was COVID testing and contact tracing, treating and monitoring the home isolation cases, or even vaccination at public sector has seen the primary care physicians taking the lead. It's commendable the way the primary healthcare centers have organized themselves for the ongoing vaccination drive. Through this conference, we wish to impress upon the policymakers to empower and involve the primary care physicians, especially the AFPI, in all such decisions-making policy and implementation process to push family medicine and primary care to the level which it truly deserves in India. Thank you.
We are in the midst of severe health crisis. Thousands of people have lost their lives. We, the family care physicians, primary care physicians, are in the forefront of the healthcare services. We worked continuously for days together, away from home and away from our children. During this process, many of our doctors have lost their lives. They sacrificed for the cause of the suffering, the cause of the patients. We have made significant changes in clinical practice. We stood by Hippocratic oath to look after the communities that we live in. And today, the main goal of us is to defeat the pandemic, consolidating the gains that we have achieved so far. We would like to advance further for a better healthcare system. With this lofty aim, we are organizing our national conference where all the issues related to the healthcare system will be discussed, and we will rededicate ourselves to the cause of the patient care and the well-being of the people. Thank you.
Affection lies in small details. Comfort lies in small details. Confidence lies in small details. Beauty lies in small details. Welcome to Microlabs, where health lies in small details. It was with this core value that Microlabs was incepted in 1973 by the late Mr. G.C. Surana. Today, Mr. Dilip Surana and Mr. Anand Surana bear the torch of creating a healthier world by making Microlabs a growing transnational organization. Ranked 10th in prescriptions and 20th in sales. Microlabs has a brand portfolio that comprises many top-notch brands in various specialties. We focus on building mega brands which trifurcate into the acute, chronic and specialty segments. Our numerous products range from oral solids, oral liquids and topicals to injectables in specialties like cardiology, diabetology, CNS and many more. The Indian market is a key operating area, reaching out to a large customer base of 200,000 from super specialty to family physicians. Our reach spans from metros to towns, living up to the core value of providing good quality medicines at affordable prices. We believe that an eye for small details paves the way for better quality work. We value every vial, every medicine that leaves this organization. As a result, our quality control measures have received several accolades. Attention to detail is the soul of our R&D. Our dedicated R&D centers have 1 API and 3 formulation centers. The research team consists of more than 200 scientists, pharmacists, analysts, chemists, and microbiologists. Microlabs has bagged prestigious regulatory approvals from the USA, Australia, New Zealand, Canada, South Africa, the UK, Colombia, Indonesia, and WHO. Ample testimony to our world-class quality. Understanding and managing people lies in small details. The Micro Leadership Academy is one such place where internal talent is identified and groomed to lead the company to exemplary success. It is this attention to details that has led to many achievements. Mr. Dilip Surana, CMD of Microlabs Limited, received the Dynamic Entrepreneur of the Year in 2010. Microlabs Limited won the Company of the Year. And amidst our proud achievers is Dolo, an award-winning brand highly prescribed for fever management. Even as we take great pride in our achievements, we take pause to also give back, making significant contributions towards the betterment of society. From the Micro Knowledge Academy, where scientific programs, CMEs, etc. are conducted for the medical fraternity, to the Sri Parshva Sushil Dham in Bangalore, managed by a trust founded by Mr. G.C. Surana, to the Surana College, an initiative by the Managing Trustee, Mrs. Archana Surana, carrying forward the vision of providing high-quality education at undergraduate and postgraduate levels at a nominal fee. Today, we at Microlabs are fueled by a single zealous vision of attaining the $1 billion mark by 2016. We are confident that we shall achieve our ambitions because attention to details is given utmost priority. Thus, at Microlabs, safety lies in small details. Clarity lies in small details. Dedication lies in small details. Perfection lies in small details. Microlabs. Health lies in small details.
heartiest congratulations to AFPA Telangana team for hosting the 5th National Conference on Family Medicine and Primary Care. I'm immensely privileged and honored to be part of this event. The theme of the conference, Post-COVID Strategies and Strengthening Primary Care and Public Health, cannot be more appropriate. It's a well-established fact that the countries with a strong primary healthcare system have better health outcomes and health indices. For some reasons, primary care sector in our country is ignored over the years. But the ongoing pandemic has brought the limelight back on importance of a strong primary healthcare system. While the media and the public was applauding the tertiary care hospitals for the way they handled critical cases, the primary care workforce have been working silently and relentlessly doing their best. It may be noted that the primary care physicians are the most vulnerable link in the chain of transmission, being the first point of contact, and they have played a key role in containing the epidemic effectively at every level. Whether it was COVID testing and contact tracing, treating and monitoring the home isolation cases, or even vaccination at public sector has seen the primary care physicians taking the lead. It's commendable the way the primary healthcare centers have organized themselves for the ongoing vaccination drive. Through this conference, we wish to impress upon the policy makers to empower and involve the primary care physicians, especially the AFPI, in all such decisions-making, policy and implementation process, to push family medicine and primary care to the level which it truly deserves in India. Thank you.
We are in the midst of severe health crisis. Thousands of people have lost their lives. We, the family care physicians, primary care physicians, are in the forefront of the healthcare services. We worked continuously for days together, away from home and away from our children. During this process, many of our doctors have lost their lives. They sacrificed for the cause of the suffering, the cause of the patients. We have made significant changes in clinical practice. We stood by Hippocratic oath to look after the communities that we live in. And today, the main goal of us is to defeat the pandemic, consolidating the gains that we have achieved so far. We would like to advance further for a better healthcare system. With this lofty aim, we are organizing our national conference where all the issues related to the healthcare system will be discussed, and we will rededicate ourselves to the cause of the patient care and the well-being of the people. Thank you.
Affection lies in small details. Comfort lies in small details. Confidence lies in small details. Beauty lies in small details. Welcome to Microlabs, where health lies in small details. It was with this core value that Microlabs was incepted in 1973 by the late Mr. G.C. Surana. Today, Mr. Dilip Surana and Mr. Anand Surana bear the torch of creating a healthier world by making Microlabs a growing transnational organization. Ranked 10th in prescriptions and 20th in sales. Microlabs has a brand portfolio that comprises many top-notch brands in various specialties. We focus on building mega brands which trifurcate into the acute, chronic and specialty segments. Our numerous products range from oral solids, oral liquids and topicals to injectables in specialties like cardiology, diabetology, CNS and many more. The Indian market is a key operating area, reaching out to a large customer base of 200,000 from super specialty to family physicians. Our reach spans from metros to towns, living up to the core value of providing good quality medicines at affordable prices. We believe that an eye for small details paves the way for better quality work. We value every vial, every medicine that leaves this organization. As a result, our quality control measures have received several accolades. Attention to detail is the soul of our R&D. Our dedicated R&D centers have 1 API and 3 formulation centers. The research team consists of more than 200 scientists, pharmacists, analysts, chemists, and microbiologists. Microlabs has bagged prestigious regulatory approvals from the USA, Australia, New Zealand, Canada, South Africa, the UK, Colombia, Indonesia, and WHO. Ample testimony to our world-class quality. Understanding and managing people lies in small details. The Micro Leadership Academy is one such place where internal talent is identified and groomed to lead the company to exemplary success. It is this attention to details that has led to many achievements. Mr. Dilip Surana, CMD of Microlabs Limited, received the Dynamic Entrepreneur of the Year in 2010. Microlabs Limited won the Company of the Year. And amidst our proud achievers is Dolo, an award-winning brand highly prescribed for fever management. Even as we take great pride in our achievements, we take pause to also give back, making significant contributions towards the betterment of society. From the Micro Knowledge Academy, where scientific programs, CMEs, etc. are conducted for the medical fraternity, to the Sri Parshva Sushil Dham in Bangalore, managed by a trust founded by Mr. G.C. Surana, to the Surana College, an initiative by the managing trustee, Mrs. Archana Surana, carrying forward the vision of providing high-quality education at undergraduate and postgraduate levels at a nominal fee. Today, we at Microlabs are fueled by a single zealous vision of attaining the $1 billion mark by 2016. We are confident that we shall achieve our ambitions because attention to details is given utmost priority. Thus, at Microlabs, safety lies in small details. Clarity lies in small details. Dedication lies in small details. Perfection lies in small details. Microlabs. Health lies in small details.
So welcome back, delegates. We are moving on to the next session. So now we are going to have the session by Dr. Indu Raji. Get your calculations right. Calculators and scoring systems in GP. Dr. Indu completed her MBBS from Coimbatore Medical College in the year 1994. Worked as resident in the Department of General Medicine, Luth Hospital, Ernakulam, and completed her DNB Family Medicine from the same hospital in the year 2009. She was involved in establishing a curriculum for family medicine residents, peripheral health centers, and also a family medicine department at Luth Hospital. She did a fellowship in intensive care from Apollo Hospitals, Bangalore, and now works as a critical care consultant, Luth Hospital, Ernakulam. She is also a practicing family physician in Vijayalakshmi Medical Center, Ernakulam. She is a training center coordinator, BLS, ACLS, PALS instructor at Luth Academy of Clinical Training, LACT, the International Training Center of AH. She has presented various presentations, conducted workshops, and has many publications to her credit. Dr. Indu is currently the president of AFPA Mid-Zone Kerala chapter, conducting academic activities regularly, and was awarded the best zone for year 2018. Our chairpersons today are Dr. Venkateshan Shankarapandyan, working as a faculty in the Department of Family Medicine, Preston Medical College, Vellore since 2005. Dr. Venkateshan is interested in family medicine service, undergraduate and postgraduate training in family medicine. He has done a fellowship in medical education from Pfimer, Philadelphia. His areas of interest are teaching undergraduate students about whole person care and comprehensive care, and developing a program of competency assessment in postgraduate education in family medicine. His vision is to establish family medicine as a specialty for UG and PG education in India. That 50% of the graduates can choose post-graduation in family medicine each year. Our other chairperson is Dr. Joyce Joseph. Dr. Joyce did his MBBS from Government Medical College, Thrissur, and DNB Family Medicine from CSA Kalyani Hospital, Chennai. He has won gold medal in DNB Family Medicine examination held in December 2016. Currently, Dr. Joyce is working in ICRA Community Clinic, Kallai. So over to Dr. Indu.
Good afternoon, all. Thank you for the kind introduction. My topic for today is calculators and scoring systems in GP. I realized the importance of clinical scoring systems and the risk calculators when I started working, managing ICUs and OPDs alone, actually. Actually, we come across a lot of scoring systems in ICUs and calculators also for dose adjustments and scoring systems like Apache, SAPS, mortality prediction models, SOFA scoring, etc. And these are all actually not taught in the preclinical years, and it's essential to have a experience in this, in learning this scoring systems, so that you will be able to manage various scenarios and also have a corresponding treatment plan. And these are all evidence-based. So coming to my topic, clinical scoring systems are algorithms designed to predict outcomes, aid decision making, manage clinical risk, or improve efficiency. And it should be user friendly. See, routinely, you need to have the routinely accepted variables or which is available immediately. So suppose you order for a blood test, it will take time. You cannot apply the clinical scoring system at that time. And the scoring systems also need to be managed. Need to manage the heterogeneity of patients that are served for primary care, because irrespective of the age, genders, and also the various comorbidities, you should be able to integrate the scoring systems in heterogeneity in various types of patients. It should be patient-centered. So most of the scores do not predict or take into account the impact of recommendations on the functional status of the patients, and it should be generalizable to the whole population.
And the balance between the clinical recommendations and patient preferences are rarely captured and are explored within the scoring systems. And this always you should have a, while managing patients, always have a clinical point of view also. Do not blindly follow this. And actually, when you blindly follow it, will just become a laborious tick box exercise. And because we have a very short period of consultation, minimum of 3 to 10 minutes, so he may not have much time to look into all that. So always have your clinical judgment in the front. Now, in general practice, I came to actually, recently only I started looking into that. We have many criteria which will be useful in our general practice. So I picked up a few criteria, around 25 criteria, which are from various systems. And I hope this will be useful to you. The first one is the center criteria. Center criteria is for estimating the probability of streptococcal pharyngitis and acute pharyngitis of a less than 3-day onset. And there are a few steps for that to determine the need for testing or empirical treatment for acute pharyngitis secondary to the infection of streptococcal pyogenes. So you're around 6 points, and the center criteria, we have 4 points. You can treat with an antibiotic, and you need no further testing. 2 to 3 points, you can go for rapid antigen test, treat with antibiotic, throat culture. If rapid antigen test is positive, treat with antibiotic, otherwise go for a throat culture. 0 to 1, no further tests are needed, and there is no need for antibiotic. Now coming to the Epworth sleepiness scale, so I think these type of patients you may be getting, people coming with excessive sleepiness in the daytime. So patients with obstructive sleep apnea, endocrine problems like hypothyroidism, patients on psychiatric medications, you need to differentiate what is the real sleepiness and why is it due to. So we have a scale of 8 points where there is, depending on the chance of dosing, you grade them into 0 to 3. So this is used widely in the field of sleep medicine and as a subjective measure of patients with sleepiness. So just grade them. If it's 0 to 7, it is unlikely that you're abnormally sleepy. 8 to 9, the average amount of daytime sleepiness. It can be for as usual for any human being. 10 to 15, the patient is excessively sleepy. Depending on the situation, you consider seeking medical attention. 16 to 24, that means you're excessively sleepy and you should consider medical attention. The start back screening tool. This is also patients you get with low backache, non-specific backache. You don't know whether you need to intervene or not. Always look for the red flag signs also. If anything present in the red flag signs, you need to refer the patient immediately. Here, this low back pain non-specific, for the last 2 weeks, you asked about the patient's way of living, how it was, how the patient was able to manage. So there are 9 points. And the scoring system, this was developed by and validated by the Keele University. And this score identifies the level of risk that patients have of developing chronicity of the low, medium, and the high risk. So total score of 3, low risk, or less, more. It's 4 or more. You go for a sub-scoring for the between 5 to 9 for the 5 to 9 points. If it is 3 or less, medium risk. 4 again, high risk. The patient needs to be investigated. The modified MRC scale, this has been used for COPD. This scale measures the perceived respiratory disability. It allows the patient to indicate the extent to which the blood pressures affect their mobility. It's graded from 0 to 4. So along with that, you have to do a COPD assessment test also. So this is there are 8 questions from 0 rated from 0 to 5, and the total of 40 points. If the higher the number, the serious the impairment. So both MMRC scale and the CAT test, along with that, you do a spirometry test also and find out the FEV1. So based on that, you can classify them into A, B, C, D. That is based on the MMRC scale, the CAT scoring system, and with the exacerbation history, you can grade them. And each grade A, B, C, D, they have different ways of different treatments advised, and all are evidence based. Now coming to the MIDAS, that is scoring system, migraine disabilities assessment questionnaire. So we have lots of patients coming to you with headache, and it's a headache for all of us. So you need to know whether this patient has got a migraine or any organic cause for headache, or if it's an infection related or vascular headaches, or like vascular headaches is called a migraine disability. Migraine, it's called a migraine, and other causes like vasculitis, I meant. So here you have questions, 5 questions where you need to for how many days in the last 3 months you have been disabled due to this headache. So 5 questions are based on that. So it can improve the doctor-patient communications, and the patient can also easily answer them, because in the last 3 months, suppose 10 days you are not able to do work, so it's a very significant number. So based on the 5 disability questions that focus on 3 domains, whether the school work is affected, the work for pay is affected, household work or chores cannot be done, family, social, leisure activities are you are unable to do. So 5 to 10 indicates little or no disability. 10 to 20 is moderate disability. More than 20 is severe disability. So based on that, you can decide on the treatment. You can go for further investigations. Now, gout is also another type of patients. You come with severe joint pains. So to know whether it's a suspected gout, this tool is very useful. The patient is a male or a previous arthritis attack. Onset is within 1 day. Joint redness, the first metatarsophalangeal joint is the commonest joint affected. Any other comorbid factors, uric acid level. So it's not just based on the uric acid level. All these together, this gives a possibility of gout or not. So gout is unlikely the score is less than 4. Gout is likely if it's more than 8. 4 to 8, you need to have a further testing, like joint aspirations or other tests. Always look out for gout mimics like pseudo gout, septic arthritis, cellulitis, stress fracture, rheumatoid arthritis, psoriatic arthritis. And this comes under the differential diagnosis. Ottawa knee rule is done for patients with a knee trauma. You need to think of, because sitting in a peripheral center, you need to think whether your X-ray machine is not available. So whether to take it or not, you need to decide. So it's needed only for a patient if it's age 55 years or older, or isolated tenderness of patella, or tenderness at the head of fibula, or inability to flex for 90 degrees, inability to bear weight immediately or in the emergency step. Even 4 steps, the patient is not able to move forward, you have to think of an X-ray, do an X-ray. Ankle root, similarly, is the point after trauma, there is a tenderness at the tip of the lateral malleolus, medial malleolus, the base of fifth metatarsal, navicular bones. You definitely need to, then history-wise also, inability to bear weight immediately or in the emergency department, you need to take an X-ray. This MCHAT modified checklist for autism. So we manage a wide range of patients from pediatrics to the geriatrics. So these patients also the mother may come and tell that your child is not having eye contact, is not playing with the peer group, or social contact is very less. So it is very easy. It's not very clear in these pictures. We go to the net, you can find out. There are around 23 questions the parents have to answer. This has been developed by neuropsychologists Diana Robbins, Deborah Payne, clinical psychologist Marian Barton. So out of which, so a total of less than 3 points. Okay, that's not much of risk. 3 to 7, you need to have a follow-up. If you have scored more on the 2 more points on that on the follow-up, then definitely needs intervention. More than 8, bypass the follow-up, go the refer immediately for evaluation and further intervention. The generalized anxiety disorder assessment. These group of patients also come telling that they have panic attacks, they feel that they are unable to do their work, concentrate, always feel the tension, sweating, everything. So these type of patients, you can, in one word, you can tell anxiety, but you need to classify them whether they need help or not. You just can't tell that control yourself or something like that. You need to intervene by using all these scoring systems. So 7-item instrument used to measure and assess the severity of generalized anxiety. It's a validated diagnosis tool. A score of 10, reasonable cut point, the patient has got a generalized anxiety disorder. So the cutoff point of 5, 10, 15, interpreted as mild, moderate, and severe levels of anxiety. So you can intervene at that point of time when there is a moderate anxiety disorder, if you feel so. This is the patient health question, which is developed to detect 5 common mental disorders in primary care: depression, anxiety, alcohol abuse, somatoform disorder, eating disorder. There are 9 points, scoring from 0 to 3, based on how many days in the last 2 weeks they have been bothered by any of these problems. So it's a self-report questionnaire, and scores are between 0 to 27, score of 10 or higher. Moderate to severe depression, you need to intervene. You need a psychological assessment and also psychiatric intervention. MMSC is a mini mental state examination. I think people coming to you with memory loss, or you feel the patient has got dementia. It's usually for age-related changes. You can put this scoring system. Mini mental state examination is a structured way to observe and describe the patient's psychological functioning at a given point of time, and also used to estimate the severity and progression of cognitive impairment in older adults. So again, it's a 30-point questionnaire, and where you look into the orientation of time, place, and space, everything, registration, attention calculation, recall, language, and also the cognitive skills. So based on that, you can assess the patient has got a dementia or not. The Wong-Baker Faces Pain Rating Scale. So this is a self-assessment tool, and these are all used in the ICUs also, whether on the post-operative setup also. It was created by Donna Wong and Connie Baker, 1983, to help children effectively communicate about their pain. So in the beginning, it's used between the age of 3 to 18 years. The scale shows series of 6 phases ranging from happy phase that is 0 to a no, that is no hurt, to a crying phase at 10. Okay, so children can easily, so parents can easily point out this, at what level the child is hurt. So based on that, you can give intervene and give treatment. Now coming to the TIMI risk score for unstable angina and NSTEMI. This is also very important because patient coming to you with chest pain needs thrombolysis, or whether the patient needs to go revascularization. It's not for STEMI actually. It's for unstable angina and NSTEMI. So you need to know whether the patient has to be referred to the higher center immediately or not. This estimates a 14-day mortality risk in patients with acute coronary syndrome based on the age, BP, risk factors, presentation, etc. So it's used to stratify patients and guide initial therapy. So the score, TIMI score is more than 3. The patient needs early invasive management, that is angiography and revascularization. So medical management will not work in these cases. So you need to refer the patient immediately. The CHAD DS2 VAS score is a validated score tool to predict the risk of stroke and systemic emboli in patients with non-valvular atrial fibrillation. So if it's 0 or 1 in a female, 0 in a male, then there's no need for anticoagulant. 1 is a moderate risk, oral anticoagulant to be considered. More than that, high risk oral anticoagulant is recommended. So it's for to predict the risk of stroke in non-valvular atrial fibrillation. HAS-blood score also, the mnemonic HAS-blood, hypertension, abnormal renal function, stroke, bleeding, labile, INRs, elderly, drugs, alcohol. So this scoring system is developed to assess the 1-year risk of major bleeding in patients with atrial fibrillation or anticoagulation. So major bleeding per intracranial needing hospitalization, HP decrease of more than 2 needing transfusion. A score of more than 3 indicates high risk, and it can be used along with the CHAD DS2 VAS score. Curve 65 is a very common score, all of you know. This estimates the 30-day mortality for community acquired pneumonia. So it also helps to determine if the patients can be treated as an outpatient, whereas inpatient, or for ICU admission. So curve score, the word itself says C for confusion, U for urea levels, R for respiratory rate, B for BP. So the age 60, more than 65. So 0 to 1 is a low risk, consider home treatment. 2 is probable admission or close outpatient management. 3 to 5 patient needs admission, could be managed as a severe, may need ICU admission too. Now this is the well score for DVT. So this estimates the DVT in patients, particularly in the emergency and the outpatient settings. So you have around 9 points. So so if you have less than that is 1 point or less, so we can exclude the need for a duplex ultrasound. More than 2, there's a DVT is likely. Suppose you suspect a pulmonary embolism, again you have the modified score, well score. So if it's more than 2, pulmonary embolism likely. Less than 1, you go for the pulmonary embolism rule out criteria. It's called the PERC criteria. If it's no to any of these points, the patient is less than 50 years, pulse is less than 100, saturation is more than 95, no hemoptysis, no hormonal treatments, no previous embolism surgery, or no unit-like. If it's no to any of it, then you will have to go for a quantitative whole blood D-dimer assay. If it's positive, go for imaging. It's yes to all, that is patients less than 50 years, pulse less than 100. No further investigation is needed for pulmonary embolism. Now coming to the Rifles criteria, it is used in the field of nephrology, where you can classify the patients, classify the severity of acute kidney injury by the GFR criteria and the urine output criteria. So it is used to determine the severity and prognosis of acute kidney injury. So R is for risk, I is for injury, F is for failure, S for loss of kidney function, E is for end-stage kidney disease. So it has got important role in deciding whether the patient has gone into end-stage or a acute renal failure. The child bug score is used in gastroenterology. It's used to assess the prognosis of chronic liver disease, mainly cirrhosis. Now, it was originally used to predict mortality during surgery. Now, it has been used to determine the prognosis as well as strength and treatment and the necessity for liver transplantation. So, you have around 5 points, out of which there's a clinical, based on the clinical and the lab criteria, scoring from 1 to 3. So, 5 to 6, the class A, 1 year survival is 100%. 7 to 9 is class B. It's moderately severe liver disease. Survival is 80%. 10 to 15, it is very severe liver disease. 1 year survival is 35% or less. Ranson's criteria, as you know, it's used for pancreatitis associated mortality. This has to be done at admission and also within 48 hours of admission. There's a gallstone induced, there is a substitute. Where you need to look into the add the total number of signs at 48 hours, and you need to look into the mortality rate. So here there are 5 parameters which have been assessed at admission and 6 parameters at 48 hours. And modified Ranson is used for gallstone pancreatitis. Now coming to the medical calculators, actually I'm not going deep into that. These are all, you have a lot of apps which can be downloaded and kept in your mobiles and laptops where, and it can be used then and there if you need to know the creatine. So various, I just taken a few: creatine clearance, calcium correction for hypoalbuminemia, mean arterial pressure, absolute neutrophil count, sodium correction for hyponatremia, BMI, and atherosclerotic cardiovascular risk calculator. So actually you need not by heart all this, just apply it into this equation and you can decide on the creatine clearance. Based on that, you can also think on adjusting the renal, give a renal dosing for the drugs. Actually, there's no point in underdosing or overdosing. You need to give the correct dosing, so always use the calculator for GFR. Calcium correction when the patient has got normal albumin or a low albumin. So, if the patient has got a low albumin, correct according to the this formula: corrected calcium, you put in the plasma albumin and then get the corrected calcium, and then if it's less, corrected. Mean arterial pressure, all of you know, I'm not going deep into that. And the absolute neutrophil count is for patients on chemotherapy or neutropenic sepsis. Just apply it into your app, and so that you can get the absolute neutrophil count. Hyponatremia, acute and chronic. So based on that, also the correction should be very careful. For chronic hyponatremia, you should not give a fast correction. There's a chance for pontine malanolysis. Acute hyponatremia, you can do a fast correction. So based on the formula, you can just put on the the equation and find out the deficit and correct accordingly. BMI, weight by height in meter square. You can just apply that and find out. Now, a atherosclerotic cardiovascular risk calculator. This is to estimate the 10-year primary risk among patients without pre-existing cardiovascular disease between the age of 40 and 79 years of age. So, based on that, you can giving high intensity or moderate intensity statin to prevent the cardiovascular strokes and also strokes. So that are the few calculators are written. There are many calculators for each systems and each system. So I mean, for pulmonology, for primary care, geriatrics, cardiology. So a lot of calculators, and we need to just download that app and just calculate immediately at that point of time itself, so that there is no confusion in the dose adjustments and also the calculation of the risk. So coming to the conclusion, scores are rarely able to consider the patient in totality and tend to be more useful in acute specific illness. Scores should reduce the uncertainty and prompt misdiagnosis and increase efficiency and improve outcomes. So further work is needed to understand the challenges and practicalities in balancing this. So they have a definitely good role in primary care, and always I suggest that a clinical algorithms are rarely superior to clinical judgment, and clinicians should use a clinical experience to collect multiple points of information and balance the risk and benefit and to integrate the patient's perspective in a holistic way. So I think further work is needed to understand the changes and practicalities of balancing additional workload burden compared to the potential benefit in everyday primary care practice for both clinicians and patients. I hope I was able to make you understand a bit of this. Now I think the session is open for questions. Thank you so much for your patient listening.
We have already reached 2:30 p.m. and I have not seen any questions so far. Shall we go to the next talk and collect the questions together?
Okay, remember.
Dr. Venkatesh? Dr. Joyce, your comments, please.
Can you hear me?
Yes, I can hear you.
Yeah, okay. No, it's 2:30 p.m. already.
Yes, yes.
Shall we go to the next talk and
yeah, okay.
complete it and maybe get the questions together?
Okay.
I have not seen any questions so far in the chat box.
Oh. So our next speaker is Dr. Sangeeta. The topic is an eye for both eyes, common eye conditions and prevention of blindness. Dr. Sangeeta graduated from Government Medical College, Ernakulam, and did DNB Family Medicine from Aster MIMS, Calicut. She has completed MRCGP International from Royal College of General Practitioners in UK. She was an organizing committee member of the first state conference of the AFPA Kerala chapter held in 2015 and is currently treasurer of AFPA Kerala Mid-Zone. She has chaired sessions and has been faculty at various conferences of family medicine. Currently, Dr. Sangeeta is working as registrar at Mass Leva Medicity, Pala.
Good evening, everyone. Am I visible and audible?
Yes, ma'am, you are visible and also audible.
Okay. Okay, coming to my session, common eye conditions and prevention of blindness. Eye conditions are very common in our day-to-day practice, actually. And as of any other system, thorough history taking and examination is very important in ophthalmic cases also. We have to correctly diagnose the patient, and most importantly, we have to know the red flags and know when to refer the patient. That is actually very important in ophthalmic cases. So what are things you need in a basic setup for an ophthalmic examination? First of all, the room should be very, very well lighted, a good torch, then direct ophthalmoscope, then Snellen's chart, and if possible, a short tonometer to measure the intraocular pressure. These are actually the basic 5 things which are recommended in a private clinic for ophthalmic examination. And coming to the history taking, this is very important. Most commonly, patients present with complaints as pain, redness, watering, discharge, and so on. But from the history, we can get correct clue about the diagnosis. That is, if the patient has photophobia, that if complaints of difficulty in watching the light, it may be a clue that the patient's cornea, there is a lesion in the cornea, or if the patient is having headache followed by photophobia, it may be indication that the patient is having glaucoma. And if the patient is using contact lenses and then presenting with pain, redness, or other difficulties, it may indicate that there is a chance of keratitis or corneal abrasion or development of a corneal ulcer. So from the history itself, we may get a clue to the diagnosis of the condition. And duration is also important. And previous similar symptoms are very important, because in cases like subacute glaucoma, the patient may be asymptomatic between the attacks, but during the attack, they have all the symptoms. So you have to ask the patient whether they are having similar symptoms in the past, whether it is unilateral, bilateral, if there is any history of recent eye trauma, eye surgery, foreign bodies, or if the patient is having any other illnesses, for example, diabetes, hypertension, or collagen vascular diseases. They are all very important in ophthalmic cases. And family history of eye disease. For example, certain conditions runs in families. Glaucoma, some are glaucoma, keratoconus, retinitis pigmentosa. So the family history is also important. And finally, the drug history, whether they are using any drops, steroid eye drops, or any other drops, that is very important. And coming to the examination part, first inspection of the eye, the thorough examination, that is starting from the eyelids. You have to invert the eyelids, see the both inner aspect of both upper and lower conjunctiva, cornea, pupils, whether they are equal or any, whether they constitute equally to light, eye movements, everything is important. And most important thing is examination of visual acuity. For this, we actually use Snellen's chart. There are various types of Snellen's chart available. I have shown one example. So visual acuity is actually referred as a fraction. The fraction is the numerator represents the duration at which the patient sits, and the denominator actually represents the line on the Snellen's chart that the patient is reading. If you sit the patient at a distance of 6 meters away from the chart, and if you're testing the right eye, you have to ask the patient to close the left eye and read the Snellen's chart from above. Like if the patient has read the first line, it is 6 by 60, second line 6 by 36, and so on. So up to 6 by 12 is normal. 6 by 12 and less is normal vision. And above, if the patient can't read up to 12, you may have to refer the patient for detailed examination. And same for other eye also. And after reading directly the Snellen's chart, you have to test through a pinhole examination also. That it indicates that if the vision is improving with a pinhole examination, it is an indication that the patient may benefit from, his vision may improve after using glasses or contact lenses. And if the patient is uneducated and can't read the Snellen's chart, there are Snellen's chart available with symbols pointing in various directions, and you can just ask the patient to point out to which direction the symbol is pointing, so that you can assess the vision. And if the patient can't still see the Snellen's chart, only see the fingers moving, you can sit at a distance of 1 meter in front of the patient, close one eye, and ask him to count the number of fingers which you are showing, and which is represented 1 by counting fingers. If he can't see the fingers, can see only the movements of the hand, shadows of the hand, it is represented 1 by hand movements. And if hand movements are also not perceived, you can use it, you can shine a torch light to the eye and see if you can perceive the light. If yes, perception light PL, and if no, it's no perception of light. Importance is that if the patient is having no perception of light, it indicates that the patient vision may not improve to any form of intervention. So that was the examination part. Coming to the few conditions commonly faced in general practice. First one is hordeola. That is, it's a common eyelid infection, common case which are seen in practice. There are two types of hordeola, that is external hordeola and internal hordeola. External hordeola is the most common form, and it is due to staphylococcal infection of a lash follicle or the sweat gland of the eyelids. Patient present with eyelid edema, pain, redness, watering, and important thing is that it is always confined to the skin and always points outwards, and it is very near to the eyelid margin. And the internal hordeola, it is actually from abscess of the meibomian gland. And the difference from the external is that there is less swelling, and also it may point inwards into the conjunctiva or may point outwards to the skin. Treatment is frequent hot compresses, application of frequent hot compresses, and topical or oral antibiotics. Most common topical antibiotics we use are moxifloxacin eye drops, oxyfloxacin, erythromycin, and in children, tobramycin eye drops. And next is calazion. It is actually a complication of the internal style. That is, the meibomian gland is blocked and which will form a cyst. The difference from odeolum is that the calazion is a firm, painless limb and it will be little away from the eyelid margin. It is commonly seen in upper eyelid but can be seen in lower eyelid also. And calazion usually spontaneously resolves. Sometimes it may get infected or become chronic. If infected, treat it as of an hordeolum. But if the cyst is chronic or recurrent, you have to refer for incisional drainage or sometimes marsupialization of the encysted meibomian. Here is that if it is a child less than 7 years presenting with a large cyst, it may affect his refraction or generate amblyopia. So the child has to be referred to an ophthalmologist. Coming to the next one, that is blepharitis or the chronic low-grade inflammation of the meibomian glands and lid margins. Usually the patient presents with a long history of irritable, burning, dry, red eyes. If you closely examine, you can see small scales on the eyelashes. And the most important thing is that blepharitis is always associated with commonly with either dry eyes or seborrheic dermatitis. You have to look for that. And treatment, you have to educate the patient that the blepharitis will not resolve soon. Prolonged treatment over 2 to 3 months with regular eye care 3 times per week is very important, or else relapse will occur. So main 3 points in the treatment are application of warm compresses, massage on the eyelids with a cotton bud to release the secretions of the gland, and proper hygiene of the eyelid. You can use tea tree oil or diluted baby shampoo for cleaning the eyelid margins. And if there is exacerbation of the symptoms, topical antibiotics are recommended. For example, erythromycin or dacitracin ointment. And if it is not respond to lid care or topical antibiotics, oral antibiotics, which is recommended is doxycycline 50 mg OD for 3 months. Topical steroids are sometimes recommended in the treatment of acute exacerbation of blepharitis, but ideally it is not recommended to use topical steroids for long. And if the symptoms are not resolving, it will be better you refer for further evaluation. And next is dry eye or keratoconjunctivitis sicca. It is usually occurring due to the disturbance of the lacrimal functional unit. Tears actually decreases with age. So dry eyes most commonly are due to 2 causes, either due to reduced tear production, as in the case of advanced age or Sjogren's syndrome, or it may be due to increased evaporation of the tears, as in the case of exposure keratitis. The symptoms the patient present with eye irritation, redness, gritty feeling of the eye, and occasional blurring of the vision. In severe cases, there will be reflex watering of the eyes also. And I have already mentioned dry eyes are always associated with blepharitis. And for the treatment part, it is the application of artificial tears only. And we have to apply throughout the day and night. And lubricant ointments are available for application at night. And another thing is that try to avoid excess exposure of heat to the eyes. You can use humidifiers to reduce the tear loss and treat associated lid diseases as blepharitis. Refer if there is continuing symptoms. Next is dacryocystitis. That is the inflammation of the lacrimal sac. It is usually caused by obstruction of the nasolacrimal duct followed by bacterial infection, commonly Staphylococcus, Streptococcus, and Pneumococcus. The importance of dacryocystitis is that acute dacryocystitis can spread and to nearby organs, and it can cause lacrimal sac abscess, orbital cellulitis, or cavernous sinus thrombosis. So treatment is important. And acute dacryocystitis is present with pain, redness, and swelling over the inner aspect of the lower eyelid. You can see from the picture the exact position of the lacrimal sac and the swelling. Treatment is systemic antibiotics. The recommended antibiotic is flucloxacillin, and you may have to continue for 10 days for the complete resolution of the acute dacryocystitis. And if there is abscess formation, you have to refer for further treatment. Chronic dacryocystitis presents with watering, mucopurulent discharge. And the important thing is that there will be regurgitation of the pus through the puncta on pressure over the sac. For chronic dacryocystitis, the treatment is either syringing of the lacrimal system or surgery. So, ophthalmic involvement is, ophthalmologist involvement is important. Another common scenario that we face is a infant born with persistent watering of the eyes. This is commonly due to obstruction of the lacrimal duct, that is congenital nasolacrimal duct obstruction, sometimes due to delay in canalization also. So the child present either with a persistent watering of the eyes due to backflow of tears or sticky eyes due to secondary infection. The most important thing is that we have to differentiate it from infantile glaucoma. There is no corneal or conjunctival involvement in infantile dacryocystitis. That is the differentiating point. And from the treatment part, usually congenital nasolacrimal duct obstruction spontaneously improves during the first months of life. But you have to educate the parents about the importance of direct digital massage. That is steady pressure at the inner canthus followed by downward pressure towards the nose so that the fluid will come through the nasal opening. That is very important. Educate the parent about the correct method of direct digital massage. And antibiotic eye drops are usually not indicated in infantile dacryocystitis unless there is a clear sign of infection. And 4% fail to clear by 1 year and may need probing of the duct. Coming to acute red eye. Some of the causes, these are the differential diagnosis of acute red eye, and some causes I have already mentioned, stye, callus-and blepharitis, and these are the other causes. So coming to the, and before coming to the causes, what are the red flag signs? Reduced visual acuity, pain deep in the eye, significant photophobia, absent or sluggish pupil response, or corneal damage on fluorescent staining or opacification, and history of trauma. These are very important. If any of these red flag signs are seen, you have to refer the patient immediately. Coming to conjunctivitis, which is the most common cause of red eye. It is the inflammation of the conjunctiva. It can be divided into infectious or non-infectious causes. Infectious, it is commonly due to viral or bacterial and sometimes gonococcal. And these are there are non-infectious causes of conjunctivitis too. The importance of infectious etiology is that they are highly contagious. And one common problem we face in our practice is whether to differentiate between bacterial or viral conjunctivitis. Actually, it is very difficult. Both can occur after a viral upper respiratory tract infection. Both starts with acute red eye unilaterally and may spread to involve the other eye also. There will be eye discharge, sticking of eyes, especially on waking. And there is one important thing there is no change in visual acuity. Cornea is not involved. And some theories say that mucopurulent discharge is most commonly seen in bacterial conjunctivitis, and in viral conjunctivitis, symptoms are less and there will be mucoserous discharge. And preauricular lymphadenopathy is most commonly seen in viral conjunctivitis. But it is difficult to differentiate between bacterial or viral conjunctivitis. And the treatment is application of antibiotic eye drops. Initially, for the first 2 days, you have to use it every 2 hours or so. And after 2 days, you can increase the duration for every 4 hours, and then after every 6 hours, and stop till when the eye symptoms are stopped. And at the night time, antibiotic eye ointments can be used. Usually, conjunctivitis is self-limiting. Use of antiviral drops are not recommended in the general practice unless you are very much sure it is a viral conjunctivitis. And if not better in 2 to 5 days, it will be better to refer the patient. And as I have already mentioned, infectious conjunctivitis are always contagious, so prevention is very important. These are the points we have to follow. Wash your hands, try not to touch your eyes, avoid contact lens use during the episode of conjunctivitis, avoid sharing personal objects. And about allergic conjunctivitis, the important points are it will be always bilateral, seasonal symptoms, and there will be usually a family or personal history of atopy, bronchial asthma, allergic rhinitis. And the signs are follicles in the lower conjunctiva, and on inversion of upper eyelid, you can see the cobblestones with flat top. Treatment is topical or systemic antihistamine. And coming to another cause, subconjunctival hemorrhage, it is usually spontaneous, but can occur following trauma, surgery, or following straining. The main associations of subconjunctival, if it's spontaneous, are high BP, elderly, and clotting disorders. So, if the subconjunctival hemorrhage is severe or recurrent, you have to check BP, CBC, and the clotting stream. And coming to keratitis, that is inflammation of the cornea, which is actually due to secondary to infection from bacteria, virus, or protozoa. Usually, the patient present with reduced visual acuity, circumcorneal injection, and small pupils. And on fluorescent stain, corneal ulcers can be seen. And corneal ulceration is an ophthalmic emergency.
Please unmute. Please unmute Dr. Joyce.
Right.
Yeah, thank you.
The talk is over. Hello? I thought it got disconnected. Okay. It was a very comprehensive presentation about the ophthalmic conditions in family practice. Can you hear me, Dr. Shobha?
Yes, you're audible.
Thank you. One thing I would like to add is that how to instill eye drops that the family practitioners need to know. There are steps of installation of eye drops. You can refer to that, and also about corneal ulcer. It's important to identify early and refer appropriately. One thing, you can start an antibiotic drops before you refer and instill an atropine ointment, because the cycloplegia helps in pain relief in corneal ulcer. So even if you are living in a remote area, sometimes you can't refer the patient. You may have to start a combination of antifungal and antibiotic eye drops, because ideally you should do a smear to find out whether it is a fungal infection like a KOH smear, or a gram stain to find out it's bacterial. But if you can't do that, you can add 1 ketoconazole tablet into a ciproflox eye drops, shake it well and use it hourly, 2 drops like that, along with an atropine ointment. You can start that and refer also. So otherwise, Dr. Sangeeta covered most of the common eye conditions. And for the PG registrars, I would like to say that ear, nose, throat, ophthalmology, dermatology, and psychiatry may not be very important for exam, but they are very important for your day-to-day life. So please read well these 4 eye, ENT, and dermatology and psychiatry for your practice. And please do ask any questions if you have. Thank you. We have 10 minutes, I think, for the questions on eye conditions as well as on calculators and scoring systems.
I have a doubt. I have a question. Can you hear me?
Yes,
yes. You're audible.
Yeah. So in Dr. Sangeeta, for hordeolum externum and internum, where do you apply the topical antibiotics? Is it on the lid, or we are using eye drops. On the lid, eye ointments, or you can use eye drops also.
On the lids, you can use eye ointment, sir, and eye lids are applied inside the eye.
You need both.
Yeah, yes, both you need.
Usually, we use only the I did not see anywhere that eye drops are used, because we use hot compresses or and eye ointments because it's not inside the eye. Venkat sir, both are needed or only one?
Generally, nighttime we advise an ointment because the ointment is likely to stay for a long time. In the daytime, if you can apply frequently, you may have to use eye drops. The problem with eye drops is that you may have to apply maybe hourly because it won't stay for a long time. And washing of the stye and blepharitis is also important. All the lid conditions. I think she explained that.
Cold or hot? Some patients ask cold or hot.
Hot warm compresses are recommended, sir.
Ice is not recommended.
No. Already it is inflamed.
Any other questions? About another question for Indu madam. I'm here.
Yes, we are here together.
Okay.
Something happened in between.
Ma'am,
yes, I have more slides to present, but I think the battery, some problem happened.
Ma'am, I use the Curious 3 calculator for CVD risk.
Okay.
How is that different from ASCVD, and in what cases that do we?
I have never used it, to tell the truth.
Yeah, I have not used this one. That's why
I have nothing to tell about it because I work in a setup of ICU. So I was just a learning point for me, this presentation. Sector criteria and all, I came to know only after when I started learning to present for this conference. So I think you use all this criteria. I really don't have any idea.
Yeah, I use the Curious criteria, ma'am, to convince patients to start statins.
Okay.
Because in our area, they don't start. Yes, sir.
I'm very much familiar with Apache, so SAP, SOFA, and also. So when I got this topic, I felt so interesting. So I thought I learned this. It's a lot of scoring from A to W. You see, there are around 100 scoring systems. So I took just a few to create awareness. I think primary physicians should, learn more into this.
Yeah, it's very useful also. Venkat sir?
I use ASCVD risk score for starting statins because more than 10% risk in the 10-year risk is more than 10% is a indication for statin. But you have to read in your app. There are next steps, evidence given about each scoring system. For example, ASCVD score is an American score. It is designed for Americans. It's written inside. It cannot be applied for Asian American and especially South Asian because our risk is more. And this scoring, ASCVD score, can be applied only after 40 years of age. So, for example, I have a patient who has come. He is only 33-year-old, but he came to me saying his brother had a MI at the age of 42. Now, this guy has obesity and his BP is 140/100, and he has hyperlipidemia, and also he is a smoker. Now, if I put it, actually, he is not a diabetic. The risk cannot be calculated because he is less than 40 years. Even I made the age 40, the risk comes to some 3%. But I have to now apply the context. This man is very anxious. I suggested weight reduction, diet, and treatment of hypertension, and also started a statin, which is not there in the ASCVD calculator. So, but this person.
Curious, I think.
Okay, so we have to see the context, and each score there are limitations. You have to read about that.
Ma'am, in Curious 3, I use the Curious 3 calculation. It's available on our mobile and net instantly also. There is no need to install any app. just a page. QRISK3 you type, you will get. And there there's an option for race. We can use Indian, Asian, in any person, any age we can use, and we can give the, it's just tick 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 for each and every point. And again it comes to 7.5-10%. We can start statin. Here it's very difficult to start statin for patients because patients won't start. They'll come with report showing, sir, cholesterol is normal, I shall stop. Yeah. They don't know it's for a prevention of MI and CVA.
Nowadays, what I see is past 2 years, I've been seeing people less than 35 years coming with acute MI, that to females. There is no hypercholesterolemia. Maybe there are a few smokers, that's all I can say. But no family risk also. But some, I think these females are taking some hormonal therapy or something like that. One female was taking hormonal therapy. Otherwise, there are no other risk factors at all. So I don't know whether treating with a statin will prevent MI. I think this we'll have to find out. That was in the Indian population.
We can also estimate homocysteine levels.
Yeah, that's also that.
Some high-risk individuals.
Yeah. But people coming at such an young age, 20, 22, 28, 30, this is the age group we are getting for the past 2 years.
Maybe the stress levels are too high.
High sedentary. It was not hypercholesterolemia. There was no dyslipidemia.
And one thing about the calculators, for example, Centar's criteria, if you keep using it, you will know the content. It is basically describing the symptoms of tonsillitis, bacterial tonsillitis. So after some time, you know the calculator by yourself. So with that, now it's time to start the next session. Shall we end this session? Thank you.
Yes. Thank you, Chairpersons, Dr. Venkatesh and Dr. Joyce, and thank you, Dr. Indu and Dr. Sangeeta. So we'll be moving on to the next session.
Good afternoon all. Next we have Dr. Muhammad Jasim for the discussion on the topic rheumatoid arthritis, sharing the patient care, GP and the consultant. Dr. Jasim graduates from Trivandrum Medical College and did his post-graduation in family medicine under National Board, New Delhi. He has a special interest in clinical neurology and rheumatology. His focus of work mainly involves medicine, rheumatology, headache, diabetes, obesity, and primary care. Dr. Jasim holds many national and international publications to his credit. Currently, Dr. Jasim is working as consultant in Department of Internal Medicine and Rheumatology, VPS Lecture, Kochi. Welcome you, sir. Chairpersons are Dr. Soumya Vivek and Dr. Nadeem Mabudi. Dr. Soumya Vivek is an MBBS DNB graduate, also completed her CCAMS, CCCMD, and she is presently medical superintendent and consultant in family medicine in Transplant Hospital, JC Road. Dr. Soumya is currently academic head of AFPA Karnataka chapter. Dr. Nadeem Mabudi, following his medical graduation, he has done DNB in family medicine from Medical Trust Hospital, Kochi. He was initially working in Kerala Health Service, following which now he is working as consultant family medicine specialist in Joskiri Hospital, Talasheri, and Hidden Hill Clinic in Talasheri. He has pursued a PG diploma in diabetes and fellowship in diabetic food management. He is an executive member of IMA Talasheri and a basic life support trainer for the same. He has won Young Doctor Award in the 4th National Conference of Family Medicine held at Bangalore in 2019. Welcome, Dr. Nadeem and Dr. Soumya. Over to you, Dr. Jasim.
Thank you, Dr. Soumya. Hope the screen is visible.
Yes, sir, it's visible.
A very great afternoon to all of you. I would like to thank the FPA Kerala chapter for this academic feast. So let's see how can we approach the rheumatoid arthritis as a primary care physician. Coming to rheumatoid arthritis, as we know, it is a systemic autoimmune disease which is characterized predominantly by inflammatory arthritis. It also has extra-articular involvement, and the process of the disease is chronic. Coming to the natural course of rheumatoid arthritis, it starts in small peripheral joints, which is symmetrical, and it progresses to proximal joints, resulting in joint inflammation, joint destruction, cartilage destruction, and finally bone erosion. With regard to symptom duration, we can classify rheumatoid arthritis as early RA, where the symptom duration is less than 6 months, and established RA, where the symptom duration is more than 6 months. Coming to the pathophysiology, it's mainly attributed to rheumatoid factor and antibodies to citrullinated proteins, which we call as ACPA or anti-CCP, complement activation. So depending on the presence of antibodies, we classify them as seropositive rheumatoid arthritis, and depending on the absence of antibodies, we call it as seronegative rheumatoid arthritis. Now, anti-CCP can be present in serum up to 10 years before the onset of clinical symptoms, and with the time, the concentration of ACPA increases and the symptoms also manifest accordingly. Coming to the etiology, it's still unknown. The most discussed and studied etiology is actually the interaction between patient's genotype and environment. Rheumatoid arthritis is indeed heritable, 40 to 60% in seropositive RA and 20% in seronegative rheumatoid arthritis. And it has epigenetic relation with HLA-DR-B1 alleles, B1, 4, 1, and 10. Coming to its epidemiology, it's prevalent 0.24% worldwide. It is more prevalent in females than males, and the peak incidence is 65 to 80 years of age. This is an interesting slide where you have the risk factors which increases the risk of rheumatoid arthritis. High caloric, less fiber diet actually increases risk, and obesity also increases the risk of rheumatoid arthritis, whereas long chain omega-3 polyunsaturated fatty acids decrease the risk of rheumatoid arthritis. Coming to cigarette smoking and rheumatoid arthritis. Actually, cigarette smoking is an environmental risk factor. It induces peptidyl arginine deaminase in the alveolar macrophages, and it converts arginine to citrulline in the airway, resulting in the formation of neoantigen and ACPA. This is indeed another correlation with gut microbe and rheumatoid arthritis. Actually, as an autoimmune process, a decreased gut microbe diversity results in rheumatoid arthritis, majorly because of dysbiosis. The commonly seen gut bacteria are actinobacteria, Collinsella, Agarthala, and Faecalibacterium. Among this, Collinsella increase the rheumatoid arthritis disease severity. Coming to the symptoms, as we know, rheumatoid arthritis presents with joint pains, joint stiffness, morning stiffness, and morning swellings. The onset of symptoms is slow and insidious, and in some cases, you can see episodic pattern of appearance of symptoms. Such type of rheumatoid arthritis are known as palindromic rheumatism. Coming to physical examination, when we see the patient, we notice tender joints, synovial thickening, boggy feel of joints, synovitis, and in advanced cases, you can see ulnar deviation, metacarpophalangeal joint subluxation, swan neck deformity, boutonniere deformity, and bowstring sign in grossly advanced cases. Coming to the joint involvement, the most commonly involved joints are metacarpophalangeal and proximal interphalangeal joints of hands and metatarsophalangeal joints of feet. Then comes knees, ankles, and wrists. Then shoulders, elbows, temporomandibular joint, acromioclavicular, and sternoclavicular joints. When you see this, the axial skeletal involvement in rheumatoid arthritis is rare. And another thing is distal interphalangeal joint involvement is also not seen in rheumatoid arthritis, while it is common in osteoarthritis. So this is a typical PIP joint swelling seen in rheumatoid arthritis. This is the ulnar deviation of hand. Also the joint swelling, you can see metacarpophalangeal swelling, and here you can see left wrist swelling as well. This is the classic boutonniere deformity where you have hyperextension, hyperflexion at the proximal interphalangeal joint and hyperextension at the distal interphalangeal joints. Whereas in swan neck deformity, you have flexion at distal interphalangeal joint and hyperextension at the proximal interphalangeal joints. This is
a patient where you have both swan neck deformity in this finger as well as bottiner deformity here. Another clinical finding is rheumatoid nodule. These are small subcutaneous nodules present at extended surface of hand, wrist, elbow, back in rheumatoid arthritis. Characteristic feature of rheumatoid arthritis, and it's a marker of disease activity, and it can be present even if other features of rheumatoid arthritis are absent. So common sites include the proximal interphalangeal joint, the wrist area, olecranon area. These are the common areas for rheumatoid nodule formation. Rheumatoid nodule results in venous stasis, arterial insufficiency, neutrophilic infiltration, and it presents with features of vasculitis as well. Coming to extra-articular manifestations, as we all know, rheumatoid arthritis can affect almost all systems. It can involve ophthalmologic symptoms like scleritis, iritis, uveitis. It can result in interstitial lung disease. It can cause hepatitis. It can result in renal manifestations, nephropathy. So extra-articular manifestations are present in 30 to 40% of rheumatoid arthritis. It may occur even prior to arthritis. And patients that are more likely to get extra-articular manifestations are those patients with high titers of RA factor and anti-CCP, HLA-DR4 positive, male patients, early onset disabled patients, and those patients in whom there is history of smoking. So how will you approach a patient with symptoms and signs of rheumatoid arthritis? We will begin with our blood counts, where you can see anemia of chronic disease, thrombocytopenia, and neutropenia, which is seen in Felty syndrome, and elevated ESR and CRP, which are the acute phase reactions. Then come the serology. In 45 to 75% of rheumatoid arthritis, you can see RA factor positive. 50% of the cases have anti-CCP positive. RA factor is seen in other connective tissue diseases as well, as you see in Sjogren's, vasculitis, sarcoids, etc. Coming to synovial fluid examination, you can see leukocyte count 1,500 to around 25,000 per millimeter cube, neutrophilic predominance. And there is a characteristic thing which you will see in synovial fluid examination. When we see the serum of rheumatoid arthritis patient, you will notice that C3, C4 complements are elevated, but in synovial fluid, the complements are low. Coming to radiology, the characteristic finding is bone erosion. Apart from that, you can see periarticular osteopenia, uniform symmetric joint space narrowing, marginal subchondral erosions, joint subluxation, joint destruction, and collapse of the joint. Ultrasound detects early soft tissue lesions. MRI has greater sensitivity when compared to X-rays to detect synovitis and marrow changes. So this X-ray shows joint space narrowing, subchondral erosions, joint subluxation. And here you can see ulnar deviation of the joints and erosions and collapse of the joints. It's a grossly advanced case of rheumatoid arthritis. Coming to the diagnostic criteria for RA, as by ACR criteria, it is by a total score of greater than or equal to 6, classify the patient as having rheumatoid arthritis. The scoring is done depending on the number and site of involved joints, serological testing for rheumatoid factor or anti-citrullinated peptide or protein antibody, number and site of involved joints, and elevated acute phase reactant and symptom duration. So when you see one by one, if there are 2 to 10 large joints, we give it as 1 point, 1 to 3 small joints, 2 points. And when the number of small joint increases, the scoring also increases. So if there is greater than 10 joints, including at least 1 small joint, you give it 5 points. If anti-CCP antibody or RA factor is low positive, you give 2 points, and high positive 3 points. Acute phase reactant, if it is elevated, you give it 1 point. And symptom duration, you give it 1 point. Now coming to the management of rheumatoid arthritis. The main focus in the management is relieving pain, preventing damage or disability, educating the patient about the disease, physical therapy for stretching and range of motion exercises, occupational therapy for sprints and adaptive devices, and treatment. The crux lies that the treatment should be started early and should be individualized. So early aggressive treatment is the crux in the management of rheumatoid arthritis. The medications include NSAIDs, steroids, disease-modifying anti-rheumatoid drugs, biological therapies, and surgeries. NSAIDs reduce pain and swelling by inhibiting COX, does not alter the course of the disease, and chronic use should be minimized. Most common side effect being GI tract irritation. Corticosteroids, of course, is a wonder drug as far as rheumatoid arthritis is considered. It can be given both systemic and intra-articular. Indications for systemic use of steroids in rheumatoid arthritis is during flares and exacerbations, when you have extra-articular manifestations of rheumatoid arthritis, can be used as a bridge therapy. When you begin DMRDs and till the DMRDs act about 6 to 8 weeks, you can use steroids as a bridge therapy. And even maintenance dose of low dose steroids, 10 milligram of or less of prednisolone, you can use in daily patients with active RA. And in pregnancy, when you cannot use other disease-modifying drugs in rheumatoid arthritis, you can consider steroids as well. Coming to disease-modifying anti-rheumatic drugs, it is a drug which actually alters the disease course. It should be used as soon as diagnosis is made, and the benefit may be delayed for weeks to months. And NSAIDs must be continued with them until actually you get a true remission, but not progressive use of NSAID is advised, but you can use intermittent usage of NSAIDs along with steroids depending on the symptoms of the patient. Commonly used DMRDs are methotrexate, hydroxychloroquine, and leflunomide. DMRDs are indicated in all patients with rheumatoid arthritis who continue to have active disease. And as far as spontaneous remission is considered, indeed, there are cases in rheumatoid arthritis where you get spontaneous remission, even though it is rare. For example, there are certain, when you focus on rheumatoid arthritis, certain females with rheumatoid arthritis undergo spontaneous remission, maybe after pregnancy or delivery or postpartum phase. Coming to methotrexate, it is actually the most commonly used DMRD because of rapid onset of action and patient tolerance and cost considerations, and easily administered. Once weekly oral administration is required. Now the question is whether single DMRD or combination. Actually, methotrexate acts as an anchor drug in the treatment of rheumatoid arthritis, and DMRD combination with methotrexate is found to be most effective. Methotrexate with leflunomide has synergistic action. The limitations of DMRDs is onset of action takes several months, and only partial remission is achieved in most of the cases, and the substantial toxicity which requires careful monitoring and tendency to lose effectiveness with time. And here comes actually the role of biologics. We have a wide range of biologics now, starting with anti-TNF agents like infliximab, etanercept, and adalimumab, interleukin-1 receptor antagonist, interleukin-6 receptor antagonist like tocilizumab, anti-CD20 antibody like rituximab, and T-cell co-stimulatory inhibitor like abatacept. Among the biologics, as per evidence-based medicine, as per this studies conducted among these biologics, the most effective one is thought to be etanercept. And in complicated rheumatoid arthritis, of course, rituximab and adalimumab have an upper weightage compared to the other biologics. This is with regard to the disease activity, which actually ACR 2012 update, where this shows approach to rheumatoid arthritis depending on the disease activity. If the disease activity is low, single DMRD can be used. And if it is high with features of poor prognosis, you straight away go to biologics with or without methotrexate. And if the features of poor prognosis are not there, in high disease activity cases, you can proceed with combination therapy with DMRD. And those cases where you have moderate disease activity with features of poor prognosis, you can combine DMRDs as well. Coming to treatment continuation, how long should you continue the treatment? Actually, long period maintenance dose may be required till the remission is achieved. And in certain cases, the relapse occurs in 3 to 5 months. But if methotrexate is stopped, relapse occurs in 1 to 2 months as well. DMRDs are discontinued by patients because of the fear of toxicity and secondary failure, and such patients might have to shift over to different DMRDs over 5 to 10 years. And disease flare require escalation of the DMRD dose with short course steroids as well. Coming to surgery in rheumatoid arthritis, actually synovectomy is not recommended in rheumatoid arthritis as it gives only transient relief. But synovectomy of the wrist is recommended if the disease is grossly advanced, where you have the wrist swelling and swan neck as well as botulinum deformity with joint collapse and destruction. And total joint arthroplasties are successful in knee, hip, wrist, and elbow, where the joint either go into avascular necrosis or severe erosions and advancement of the disease is seen. And in certain cases where you have a severe wrist involvement, you can have carpal tunnel syndrome as well. In such cases, carpal tunnel decompression also do have a role. And as far as rheumatoid nodule is considered, excision of symptomatic nodule is advised. Complications of rheumatoid arthritis, opportunistic infections as the patient is on immunosuppression. Steroid use results in osteoporosis, fractures, pleuritis, pulmonary embolism, peripheral vascular disease, and the chronic phase of rheumatoid arthritis may lead to depression in patients as well. Coming to prognosis of rheumatoid arthritis, as we all know, there is no cure. It's a progressive disease. There is multiple exacerbations, and it can ultimately lead on to increased disability and mortality. So as a primary care physician, what we can do is early diagnosis of the disease, early treatment to improve functional capacity and decrease the disease activity of the patient. So let's find them and be a helping hand to them. Thank you.
Well, Dr. Jasim, that was a fantastic presentation. Congratulations to you. A couple of points, because there are no questions as I could see, which the patients with rheumatoid arthritis, as you would also agree, they come with a lot of co-infections. Okay. So what do we do when there are some co-infections, may it be UTI or viral or perhaps COVID?
The patient on immunosuppression. So for example, if the patient is on methotrexate as well as hydroxychloroquine and steroids, any infection, you should stop methotrexate. Hydroxychloroquine and low-dose steroids can be continued in infections as well. And the prime importance should be given to the treatment of the infection at that time. And once
Correct. We do a baseline complete count, and if there are no cytopenias, we definitely would not want to stop your DMRDs. Yeah. I totally agree with you. But basic, a complete count is a must to rule out any cytopenias or suppression of the marrows of any of the cell line lineages. And suppose if there are cytopenias, then definitely, as you said, we would want to stop the DMRDs and think of putting them on other medications and treat the infection per se. And of course, if there are severe cytopenias, definitely we cannot treat, and we would want a specialist and a multi-team approach. So we'll refer them to hospitals. So what are your comments on COVID positive patients and DMRDs?
COVID positive patients, as far as rheumatoid arthritis is concerned, if the inflammatory phase is prominent, it is better to hold on DMRDs like methotrexate and put the patient on steroids, because steroids will have an upper hand over rheumatoid arthritis as well as COVID.
Yes, correct. And some of them do come to you for vaccination issues, right? COVID positives, rheumatoid arthritis, and they would want to get vaccinated. What's your advice to them?
Actually, if they are asymptomatic or if their disease is in remission at that time, they can stop methotrexate for about 2 weeks, take vaccine, and then after 2 weeks, they can restart. But if the disease is active at that time, no need to stop DMRDs. They can take vaccine with DMRDs.
Usually, live vaccines cannot be given when the patient is on DMRDs because of the immunomodulatory effect of DMRDs. And another thing is, as general practitioners or family physicians, we also have to look into the caregiver issues here. Because as you would also agree, rheumatoid arthritis is a chronic with the waxing when waning pattern, and definitely we have to look into the financial aspects, the mental status of the caregivers and the providers, as well as the patient, give them a good social support, discuss the financial aspects of it, and also occupational rehabilitation, if the situation demands for that particular patient. And of course, rheumatoid arthritis, relatively young patients, when they do become pregnant, we also tell them to get abortions, especially in the first trimester, if they are already on methotrexate or on leflunomide, right?
Yeah.
So only in second and third trimester, we would recommend the usage of steroids, right?
Yes.
Those were my points. And anything Dr. Nadeem would want to add?
Jasim, you have well explained the basics of RA, which is pertinent to GP. And Madam has already discussed the point. I was actually planning to ask that regarding the pregnancy, the DMRDs in pregnancy. And I also want to clarify, you have mentioned that incidence of age is above 60, like that one slide. Whether it is above 60 or it's detected late.
No, the thing is that actually it is above 60 when you take the majority of rheumatoid patients. But early onset rheumatoid arthritis is also seen.
Okay. And also one thing in routine practice, what we see is how to differentiate the methotrexate-induced pulmonary changes and the RA-induced extra-articular changes, that is interstitial fibrosis. How, is there something clinically to differentiate the both?
The most important thing is that before starting methotrexate, you should have a basic pulmonary workup. You will have to get a chest X-ray. In our setup, it is the most financial and cost-effective thing is chest X-ray, and you will have to rule out TB. You should ask incidence of TB or history of TB in the past, and if the patient was having TB, you should get a baseline CT as well to rule out fibrosis at the time of initiation of methotrexate. When this patient is kept on, we follow up this patient, and if they develop pulmonary fibrosis later, that can be taken as methotrexate induced or rheumatoid arthritis sequelae.
Agreed.
The problem in our practice mostly is that once a primary practitioner will start on methotrexate, patient will be better in 6 months' time. The pharmacy people will say it's some analgesic and they will stop it. And they will come after 1 or 2 years to you with these changes sometimes, or with the original disease progress.
Yeah, that's true. That's the other thing which we see. It is not because of analgesic. The pharma people will induce fear in the patients, telling that this is a drug used for cancer. Yeah. So that is what we see more common, and they will stop the medicine also. And once such patients come back, most frequently the methotrexate will not act in such patients, and we will have to think of other DMRDs at that time.
I think it's our importance lies in that part, that to convince from the treatment part that these drugs are used mainly for such and such things, and it's not an analgesic. And we want to convey all these things. Yeah. Because sometimes the rheumatologist sitting in a busy OPD might not be communicating in the detail, and they will not be adherent to the treatment.
Yeah, that's a true
part. Much better.
So, Dr. Nadim, counseling plays a very important role in such patients because of the chronic illness. Just one more point, Dr. Jasim, would you like to advise PGs on what blood tests do you recommend and how do you monitor in patients on DMRDs?
DMRDs, of course, our routine CBC and basic liver function, AST, ALT, creatinine, and to understand the disease activity, of course, ESR also has a role.
And when do you think that SGPT would be significant and concern area with respect to a patient on DMRDs?
Definitely, at least once in 2 months, you will have to see SGOT, SGPT levels, and depending on onset of viral fever. For example, a patient on DMRDs is acquiring dengue fever. At that time, LFT values has a very important role because dengue itself can produce dengue hepatitis.
Correct. And even in the absence of fever, if they are on DMRDs, and if there is at least a 2-fold elevation, you would have to keep a close watch on that. Yeah. So constant, when to return and what are the concern areas needs to be discussed with the family as well, right?
Monitor blood sugars also, because steroids
steroids and supplementing calcium, supplementing antacids if required, especially patients on steroids is a must. And also on bedridden patients, because counseling about bed sores, counseling on how to take care of catheter, how to prevent, recurrent lung infections and, hypostatic pneumonias in such patients, and bed sore care with, probably airbed, all these issues needs to be discussed, because this especially, I don't think so many specialists have, can give adequate time. I think as family physicians, we can.
Our role comes mostly in the counseling areas and telling them about the disease as well as telling about the medications as well.
Okay, totally agree.
Jasim, one more question, whether there is a cutoff for adding DMRDs, 1 plus 2 plus like that. Is there
If the patient is seropositive rheumatoid arthritis, I would prefer, means most of the guidelines say that you can start with methotrexate and another DMRD combination. But if the patient is seronegative and if the symptom presentation is minimal, it is better to start one DMRD and a low dose steroid.
Thank you.
I think there is a question. Do negative RA factor and anti-CCP rule out rheumatoid arthritis? No. There is a category of patients known as seronegative rheumatoid arthritis where you can have negative RA and anti-CCP, but they will be having severe symptoms. Synovitis will be there, acute phase reactants will be there. And such patients are termed as seronegative rheumatoid arthritis and they require treatment.
And it's also sometimes seen that all RI positive patients is marked as rheumatoid arthritis and treated sometimes in the periphery.
Yeah, that's also a fact.
Okay, I think if we do not have further questions, thank you, Dr. Jasim, for a wonderful presentation.
Thank you.
I think we can go on to the next topic because I cannot see the comments or questions in my chat box. Dr. Nadim, anything from your side?
1 minute, madam. I'll just check. That was the question already answered by Dr. Jasim.
Okay, okay, thanks.
Next, we have a discussion on the topic Intimate Hygiene and Comfort, Vaginal Discharge, When and What to Treat by Dr. Anu Peter. Dr. Anu completed her MBBS from Father Muller's Medical College, Mangalore, and DNB in Family Medicine from Luth Hospital, Kochi. She was presented a paper on scope of family physician at the World Rural Health Conference in 2018. Dr. Anu is ICMR STS Award winner for community-based research in 2008, which was published in AJPS in 2015. She is currently coordinator of AFPA Educate Chapter, and Dr. Anu is presently working as assistant surgeon in the Department of Health Services, Kerala, and is involved in COVID-19 control activities as a part of Primary Health Center, Vannaparam, Idukki. Welcome, Dr. Anu. Chairpersons are Dr. Soumya Vivek and Dr. Nadeem. Over to you, Dr. Anu.
Everyone, thank you for the kind introduction. Today, my topic for discussion is intimate hygiene and comfort, vaginal discharge, when and what to treat. So let's move on to the topic. I'll share my screen. Yes, so the topic is vaginal discharge. So to give you an overview of what I'm going to talk today, vaginal discharge is the commonest complaints that is seen by a family physician in his or her OPD. And it is most difficult to solve if it is a recurrent or a persistent complaint. And it is very important to make a proper diagnosis and to differentiate between abnormal, whether it is physiological or it is a pathological discharge. It may present at any age.
Sorry to interrupt.
Okay. It may present at any age, but it is very common in reproductive age groups. So the first step in diagnosis would be to determine whether the discharge is a cervical or vaginal in origin. So the two most common causes of vaginal discharge are either a physiological discharge or an infective vaginitis. So let's move on. In family medicine, always we have a diagnostic strategy model, how to approach to a patient with a complaint. So here, the probability of our diagnosis would be either it is a normal physiological discharge or it is vaginitis. Now, vaginitis, mostly bacterial vaginosis, which amounts to 40 to 50% of cases, and less likely are candidiasis and trichomonas. Now, in the strategy model, there are some serious disorders that we should not miss, which is neoplasia, a very important part. We should not miss out a malignancy, a fistula, and sexually transmitted infections, which could be gonorrheal infection, a chlamydial infection, or herpes simplex type 1 or 2. Now, another important thing that we should not miss is any sexual abuse, especially in children. Now, there are other causes which can result the patient coming into our OPD, a tampon toxic shock syndrome, which is due to a staphylococcal infection, or a streptococcal vaginosis, which we see mostly in pregnancy. We'll come to this in detail later.
Dr. Anu, can I interrupt?
Now, there are often some pitfalls that we may miss.
I can't see your slides.
We should always ask for history, and we should go into a thorough examination to rule out all these factors.
You can see the slides.
So it could be a chemical vaginitis by using excess of perfumed products. It could be a retained foreign objects, which is again a tampon in situ, an IUCD in situ. It could be endometriosis, which might result in a brownish discharge. It could be an ectopic pregnancy, which again causes a prune juice discharge. I have put a picture of that to make sure the color of the discharge. And poor toilet hygiene is another issue which can result in a vaginal discharge. Latex allergy while using contraceptive devices. It could be genital herpes. It could be an atrophic vaginitis, especially in later stages in a woman's life, or it could be a threadworm infection. Now, checklist. Now, always when you ask for history, always take a history of diabetes mellitus, which is very important for an excessive vaginal discharge. Any drug intake, long-term drugs, any immunosuppressant drugs, any steroids, and any association with urinary tract infection. Now, another very important part of our history taking should be a careful consideration of the patient who may be trying to tell that she is having a sexual dysfunction. So these things should be kept in mind. Now, what is a physiological discharge? A normal physiological discharge would be a milky white or a clear mucoid discharge. Now, where does it come from? It could be from cervical mucus. It could be a vaginal secretion, the vaginal squamous epithelial cells, the cervical columnar epithelial cells, and the resident commensal bacteria. So what is a predominant bacterial flora in the vagina? It is lactobacillus. And what does it give? It gives an acidity to the vagina. And for the normal physiological discharge, you don't expect to have any odor. There are no associated pruritus. Now, there's a term called leukorrhea. What does it mean? Leukorrhea is defined as an excessive normal vaginal discharge. Now, what is it? An excess secretion would be evident from a persistent vulvar moistness or staining of undergarments. Either it could be brownish yellow on drying, or a need to wear a vulvar pad. The discharge is so much that they need to wear a vulvar pad to prevent it. Now, this leukorrhea is again non-purulent, it is non-offensive, it is non-irritant, and it never causes pruritus. So it's just an excessive of normal discharge. Now, what is an abnormal vaginal discharge? It could be non-infective. We classify them as abnormal vaginal discharge just to inform that if it is non-infective, it is again coming under leukorrhea, and the cause could be again vaginal cause or the cervical cause. And again, we have another important things to keep in mind: an infective, which could be a specific or a non-specific entity, a neoplastic cause for an abnormal vaginal discharge, and a foreign body in situ. Now, this is a life table of abnormal vaginal discharge. So, an abnormal vaginal discharge could occur at any stage of life. So, in early neonatal stage, it is again just leukorrhea. It could be hormonal, mostly from the mother, and a period up to pre-menarche. It is usually due to an ill health, a foreign body in situ. The little children are usually susceptible to put things into the vagina, which gets retained there, and later an abnormal or offensive discharge would probe into the matter, and we could find some abnormal foreign body sitting inside. In pubertal time, it is again excess of hormone. The estrogen production causing excess of discharge. Now, reproductive age group, they have again divided into non-pregnant, which is again related to the menstrual cycle and the hormones. In pill users, during an antibiotic therapy can cause decrease in the lactobacillus, which is the normal flora of the vagina. So that is again susceptible to infections. Then diabetes, it can cause glucosuria, which is again causative factor for an abnormal infection at that point of time. Then again pregnancy. In pregnancy, we have again leukorrhea, or it could be related to any of the candidal infections, which is again a common issue. Now, postmenopausal woman is usually, it is atrophic vaginitis, senile vaginitis. So that should also be kept in mind. Atrophic vaginitis again could lead to infections creeping in and causing an abnormal vaginal discharge. So from this picture, you should always look into the age factor also to assess what should be our diagnosis. Now, how do we evaluate a patient who is coming with a vaginal discharge? First, take up the detailed history. What was the symptoms with which the patient came to us? Then the discharge, what is the duration of discharge, the type of discharge, any itching associated with it. Now, is the symptom associated with dysuria, dyspareunia, pelvic pain, any contraceptive device that they are using, how is their sexual behavior, and any previous episodes of similar complaints. So that is other part of history. Now, coming to physical examination, again look for the general condition of the patient, whether the patient is in ill health, whether they are just having a poor nutrition. And abdominal examination, please going to look for any tenderness at any point, mass per abdomen. Going on to vulvar infection, what could be the discharge character? Any genital ulcers on inspection should be looked for. Go on to speculum examination, again look at the vagina, look at the cervix, is there any ectopy, and even look at the discharge, whether it is coming from vagina or from the cervix. Go on to pelvic examination, any tenderness, any pelvic mass, any foreign body that is seen should be considered. Now, then we move on to investigations. So the discharge is taken for wet film examination to rule out trichomonas vaginalis, bacterial vaginosis, etc. We have KOH test. All these I'll come to in detail in the coming slides. Now, discharge can be taken for gram staining. A pap smear should be done according to the age group to rule out any upcoming cancers. Urine for a routine and the culture to rule out any associated urinary tract infection leading to the vaginal discharge. HIV serology to look for the immune status of the patient. And blood test when indicated. If a pelvic inflammatory disease is suspected, always go and do a blood test. Now, this is just an overview of what is wet mount preparation. You place a small amount of discharge on 2 slides, add 1 drop of sodium chloride on one and KOH on the other. And then first view the saline slide. Let the KOH slide sit there for 1 to 2 minutes, which will help dissolve or allow the solution to dissolve the cell membranes. Then look at it. Now, what do we see in wet mount preparation? We see normal. If it's normal, you see normal vaginal cells. You see clue cells with cucubacilli, which is suggestive of bacterial vaginosis. You see hyphae of the candida. You can see flagellum, a motile protozoan flagella called trichomonas, which are responsible for Trichomonas vaginalis. Now, KOH slide, what do you see? When you place the vaginal discharge on the slide and mix it with 10% KOH, the KOH kills the bacteria and the cells from vagina and leaving only yeast for easier detection of an yeast infection. Now we'll go in detail about the infective causes of an abnormal vaginal discharge. I'll rush through the slides. Bacterial vaginosis, which we mentioned earlier, 40 to 50% of cases, we get bacterial vaginosis. So what is it characterized by? It is replacement of the normal vaginal microflora, as I said earlier, the lactobacillus, with the mixed flora of Gardnerella vaginalis, anaerobes, and Mycoplasma hominis. Now, this would account for alkalinity of the vaginal pH, because if it was lactobacillus, we could have retained our acidic pH. So, what could be the clinical features? Grey, watery, profuse discharge. It is malodorous, no obvious vulvitis or vaginitis. The term vaginosis itself indicates there is no obvious vaginal inflammation. That is why it is not vaginitis, but vaginosis. And it could be associated with dyspareunia and dysuria, and pruritus is uncommon. Now, what are the complications of bacterial vaginosis? The recurrent infections could lead to a pelvic inflammatory disease, and it could lead more often to a pregnancy complications like miscarriage, PROM, preterm birth, and endometritis. Now, bacterial vaginosis, its diagnostic criteria is called Amsel's criteria, where we have four criteria: a thin white homogeneous discharge, presence of clue cells in the microscopic examination. You can see the clue cells in this picture. This is the normal vaginal cells. When the cocobacilli surround the normal epithelial cells, obscuring the borders, it looks like a stippled granular pattern. Now, these stippled epithelial cells are called clue cells. So, that is again an important criteria for more than 20% of clue cells would help us in diagnosis of a bacterial vaginosis. So, the first criteria is thin white homogeneous discharge, presence of clue cells in microscopic examination, pH of the vaginal fluid goes more than 4.5, and there is a fishy odor to vaginal discharge on addition of 10% KOH. This test is known as a whiff test. So, during a whiff test, if it gives an amine or fishy odor smell, it is again characteristic of bacterial vaginosis. Now, let's move on to the treatment of bacterial vaginosis. It is metronidazole. Tap metronidazole 200 mg thrice daily for 7 days. We can also use a metronidazole gel, a 0.75% gel, which is 5 gram gel, 1 full applicator intravaginally once daily for 5 days. Again, clindamycin 2% intravaginally at bedtime for 7 days. Now, here, make sure that the sexual partner is also treated simultaneously. Now, another important infective cause is vaginal candidiasis, which is most common also. Now, it is due to infection with fungus, Candida albicans. Now, what are the clinical features? There is intense vaginal and vulval pruritus, and the pruritus is out of proportion to the discharge seen. Now, it is a white curd-like discharge. You can see in the picture, it is a curd-like discharge. And there is discomfort with coitus, there is dysuria, dyspareunia, vulval soreness, vulvovaginal erythema, brick red color, and there is vaginal excoriation and edema. Why? There is intense pruritus. Sorry. Now, what are the factors predisposing to vaginal candidiasis? We can classify them as endogenous causes and exogenous causes. Endogenous, the patient might be having diabetes mellitus. Patient might be in an immunocompressed state, AIDS syndrome, maybe a pregnant lady, or any other debilitating disease person. Now, exogenous causes, it could be intake of oral contraceptives. Again, antibiotics can decrease acid-forming lactobacillus. Any immunosuppressants, orogenital or anogenital intercourse, an IUCD in situ, or tight-fitting jeans, nylon underwear, humidity, or a wet bathing suit. All these are exogenous causes for a predisposing to vaginal candidiasis. Now, what is the treatment? Correction of the predisposing factors that we said earlier. Now, intravaginal fungicidal preparation, azole group, that is clotrimazole, butaconazole, miconazole, or a specific, kept for 1 to 7 days. Now, clotrimazole 500 mg vaginal tablet is available as a single dose or 100 mg vaginal tablet for 6 nights. Clotrimazole 2% creams applied to vulvovaginal area 8 hourly or 12 hourly. Now, what if there are recurrent infection? You can try giving nystatin pessaries twice daily for 7 days. Nystatin vaginal cream twice daily for 7 days. Now, if intolerant to vaginal therapy, you can go on to oral fluconazole 150 milligram as a single dose. Now, vaginal candidiasis is a very common complaint that you see in OP. So, what is the advice you can give to the patients? Bathe the genital area gently, dry the area thoroughly after bathing, wear loose fitting cotton undergarments, avoid wearing tight jeans or tight undergarments, avoid intercourse during the infected period, and don't use vaginal douches, powders, or deodorants. Now again, so we discussed bacterial vaginosis, we discussed vaginal candidiasis. Now the third one is Trichomonas vaginalis. As I said earlier, causative organism would be Trichomonas vaginalis, unicellular flagellate protozoa, which is an actively motile protozoa. So it is the most common infection seen in childbearing period. What are the clinical features? A sudden, profuse, and offensive vaginal discharge. There is irritation and itching within and around the introitus, and it is associated with urinary and the frequency of micturition and dysuria. So in the picture, you can see Trichomonas vaginalis, the protozoa, and the typical vaginal discharge. You can see a frothing pattern. On examination, what do you see? Vaginal discharge is thin, greenish, yellow, frothy, and offensive discharge. The vulva is inflamed and there is evidence of pruritus. Vaginal examination may be painful for the patient. There could be multiple punctate hemorrhagic spots seen. Now, similar spots on cervix on speculum examination would reveal or would generally give us a picture of a strawberry cervix. Now, how do we diagnose? By hanging drop preparation, you can see the actively motile flagella. And if not seen, you can give the discharge for culture. Now, treatment again, metronidazole, 200 milligram thrice daily for 7 days. Or you can give a single dose, 2 gram per oral of metronidazole, or a single dose, 2 gram per oral of tinidazole. Both are effective. Now, the partner should be given the same treatment for 1 week, and he should wear a condom during intercourse until his wife is cured. So these are the 3 things that we discussed for the infective cause, bacterial vaginosis, where we saw thin off-white discharge with fishy odor. There is no inflammation. Thin yellow-green malodorous frothy discharge seen in Trichomonas vaginalis. There is vaginal inflammation there. Candida vaginitis, thick cottage cheese discharge, again with vaginal inflammation. Now, lab findings we have discussed, bacterial vaginosis, you see clue cells, positive if test, cells criteria, Trichomonas, again you see motile trichomonads, Candida you see pseudohyphae. Now, how is the treatment? Bacterial vaginosis, we give metronidazole, Trichomonas we give metronidazole, treat the sexual partner, Candida vaginitis you give fluconazole as whole group. Now, again, few important things are group B Streptococcus vaginosis, which is seen in pregnant women. This could be due to a serious infection in the neonate, where we need to give IV benzyl penicillin. Again, retained vaginal tampon is very important. Please see to it that get a good history. On examination also, you should find out a retained vaginal tampon, which could be in situ, maybe knowingly or unknowingly. Now, tampon toxic syndrome, again, due to the retained vaginal tampon, it can be caused by staphylococcal infection. This can result in acute fever, vomiting, diarrhea, hypotension, even to the point of death. So be very careful. Now, the last slide, when do we refer? If you feel there is evidence of sexual abuse in children, please see to it. Recurrent or recalcitrant infections, which you cannot treat. Presence of cancer or fistula, please do refer to the concerned specialty. Again, staphylococcal toxic shock syndrome, which needs an expert and immediate care. So thank you for your patient listening. Thank you.
Thank you, Dr. Anu, for a very simplified presentation on a very important topic in our family practice. Just looking into the box. Dr. Anu, definitely, you know, a lot of counseling is required, right? In especially young girls coming with wide discharge. And off late, the number of youngsters coming with wide discharges has increased, definitely because of the dressing pattern. You know, the old long skirts and saris are definitely more favorable than the tight jeans and the leggings, which the young girls, especially teenagers, go in. And very important to educate them on vaginal hygiene, right? How do you counsel a patient on this, on vaginal hygiene aspects?
Yes, ma'am. As you am I audible?
I think both your modes are on. If you can switch off one of them.
Ma'am, as you said, counseling is a very important part, especially in family practice. As a lady family physician, I think there are so many cases that I have encountered with vaginal discharge. Many of them would open up to a lady physician about their concerns. So most of them at this point of time are thinking about a malignancy even when they suddenly come across a vaginal discharge. So here, as I said in my slide, we should first look at the age factor and then explain to them into the age what would be the reason the vaginal discharge. And most of them with reassurance should be able to cope with their condition. And only if it is an infective cause, we need treatment. So most of the time, counseling give them an assurance.
Correct. And also you look into some general disorders which can cause vaginal discharge, right? As simple as anemia. Anemia patient who is very anemic can have a physiological excessive vaginal discharge. So that's it. And also in our country, not only to think about malignancy, but in older individuals, we should also keep genital tuberculosis in mind, not to forget that. And also, whenever we have a chance, we should counsel these youngsters on wearing cotton panties and loose underclothings, especially to prevent recurrent infections, and not to use exogenous hormone supplements. You know, that is the new norm in many of them to maintain their skin texture or the body weight. A lot of hormones are being used, which can have some harmful effects and also can cause discharge. And what about vaginal discharge in pregnancy?
Vaginal discharge in pregnancy again a concern. They would be always concerned about their the neonate
baby.
Or the baby, the embryo that is growing inside. So we should again reassurance should be enough, and but we should always look for any other factors, like most of the time asymptomatic bacteriuria, any urinary tract infection associated, and if there is actually an infective cause, we should treat them, because if it lead to complications in pregnancy like preterm. These things can again cause a very or maybe just one proper diagnosis and proper history taking, proper examination, and coming to a proper diagnosis can help the baby grow better and would avoid the complications that can occur in pregnancy.
Yes, yes, and also educate them on to avoid excessive douching, as you said, which they commonly done activity, and also not to use exogenous washes. You know, there are so many liquids available like dash washes, etc., for which will help, but definitely not advisable. And also one area is syndromic approach to these. That is, a bacterial vaginosis can coexist with, chlamydia or gonorrhea. So it's very important for us to put this speculum and make sure that, yes, this is vaginitis and not a actual PID, and how to go about. And definitely in pregnancy, as FPs, we will avoid some medications like fluconazole for obvious reasons and try to rely on metronidazole. And in other individuals, non-pregnant individuals, if fluconazole is not, metronidazole is not tolerated well and tinidazole gives a metallic taste, even drugs like secnidazole 2 gram stat can be used for the treatment. Anything Dr. Nadeem would want to add? Only ladies speaking about the topic. So
it was a nice presentation, actually, well covered within the time and beautifully presented. I would like to add, if in non-responders for this treatment for vaginal infections, just look into the cervix also, because infections like chlamydia, gonorrhea, something can be there in the background and can miss that vaginal. It can be presenting as a vaginal discharge initial stages. And also one thing, that syndromic management, what madam has pointed out, is also a important thing in our resource limited settings. And again, in the present era of SGLT2 inhibitors, where in and out lot of SGLT2 are used because the cost has came down. So a lot of genital infections are coming apart from the diabetic status, due to iatrogenic drug-induced genital infections are common nowadays. So we want to look into that also. I also have one question for you, that the role of pre-probiotics in this vaginal infections. Can you just enlighten?
Pre-probiotics would definitely help for a normal, healthy vaginal epithelium. So that should definitely help in promoting healthy vagina as preventing infection setting.
And also, is there any age bar for using this intravaginal preparations? Because sometimes the teenagers will come with this candidal infections, and is there something, some age group where we cannot use intravaginal preparations?
After setting in of menstruation, they can actually use intravaginal preparations. And then, so age factor is very much important. The age of menarche is also important. And then, according to the age group, we can definitely prescribe vaginal preparations.
Medico-legally, I think the preservation of hymen becomes very important, and young girls may not know the appropriate application of intravaginal preparations. So I would probably avoid until they can understand, and I would probably use in young girls who have already had a sexual contact. So that history also becomes important. And
Dr. Anu, there is a question in the chat box. Dr. Prashant has asked to explain about the menstrual cup use. I think the benefit of it in such patients.
Menstrual cup use, yeah, the newer generation is coming up. They are more likely to use the menstrual cup. There are a few advantages, like it is cost less of a wastage. They can be reused, and if used properly and in a hygienic manner, they can be used for more often. So I think the present generation is moving on from pad use to menstrual cup use. That's a good sign.
Yeah, but the only disadvantage of menstrual cup is, one of the disadvantages is that it cannot be used in, the compliance is very poor in ladies who have undergone LSES, because the introitus will be very small and they will not be comfortable even on repeated trainings. This is in the, this is from practice perspective. Logically, you can explain them, but they will not be comfortably using it. People who have had vaginal deliveries are more comfortable in using this.
Is there a benefit in using menstrual cup to avoid these frequent infections instead of pads?
If used in a proper manner in hygienic conditions, I think it should help in avoiding vaginal infections.
Okay, again, is there any implication in using in teenagers, whether we want to avoid it in, before the first intercourse or something like that?
No, they can use even in teenagers. The newer generation is using menstrual cup.
Soumya, madam?
I think I am done with my set of questions or discussions.
Thank you, Dr. Aneurysis, for this wonderful presentation, and Dr. Soumi and Dr. Nadeem for sharing this session. Before moving to validative function, there will be some announcement about the upcoming national conference.
Good afternoon. Now we come to the conclusion of the virtual AFPICON Kerala 2022 We are sure it was a wonderful event and it was a great learning experience for all of us. We would like to thank all the eminent speakers, chairpersons, and the participants. We express our gratitude to Magica Health Event Management Team for setting the platform for us.
We would like to thank our sponsors for their support. And finally, we thank all the committee members, mentors, teachers, and residents for their well-coordinated arrangements and teamwork. As you're all aware, winners of our quiz competition are: first prize was backed by Dr. Labiba and Dr. Krishna from Medical Trust Hospital. Second prize by Dr. Nasiba and Dr. Fatima Lafna from KIMS Trivandrum. And third prize by Dr. Minu Thomas and Dr. Anaga Vijayan from Luke's Hospital. Now, I invite Dr. Sangeeta to announce the winners of poster presentation.
The winners of poster presentation. Third prize goes to Dr. Navina Prince Chandi from Luth Hospital, Kochi for her poster titled Spectrum of Dermatological Problems in Family Practice, a Case Series. Second prize goes to Dr. Ashwini G from Luth Hospital, Kochi for her poster Perceptions and Practices Among Mothers of Children with Febrile Seizures. And first prize for the poster presentation goes to Dr. Anuna Vinod, Luth Hospital, Kochi for her poster titled Profile of Acute Respiratory Infection in Children aged 1 year to 5 years. I congratulate the poster winners. Now, over to Dr. Serin Kuriakos for giving feedback to our residents about posters.
Thank you. Thank you, AFPICON Kerala Organizing Committee for this, for giving me this wonderful opportunity to be a part of this mega event. Thanks to all organizers. I would like to share some thoughts regarding poster presentation. All presentations were good. I congratulate on behalf of scientific jury, but I would like to share some concerns as well. There are a few points. Actually, when we present a poster during a family medicine conference, what is our primary objective? We may be seeing so many cases, but through your poster, what you are actually, what do you want to convey to your audience from a family medicine perspective? There are so many things, and there may be so many complicated, so many fancy diagnoses and all. But as family physicians, what is relevant to us? We are worried about what, and what is the take-home message for us? This should be the highlight of these presentations. In many of these presentations, though they were very relevant to our subject, many candidates were lacking that how this can be related. That part was missing. And regarding the design of most of the posters, I am really disappointed to say that the standard of the level I was expecting was much more higher. When we compare the previous episodes of this AFPICON and other family medicine conference, the standard of posters are a little bit disappointing. You people, I mean, those who presented should seriously think about how much time actually you spend to design all these posters. This is actually these posters are a scientific presentation, scientific product. At the same time, it is also an art. So you have to consider that also. What do you want to convey through your poster? That is one question. Do you want to clutter your poster with so many things? And what are the, or do you want to specifically convey some important messages? What are your priorities in that? If you want to convey some story, there should be, it's just like a story telling. The flow of events should be there, and what all important points you want to convey, what are the relevant pictures, graphs, investigations, etc. There should be a minimalism. So you have to limit your colors, selection of colors, background, and it should be readable. And the font pattern, at least the font pattern should be uniform. Anyway, thank you. Thank you for giving me this opportunity, and congratulations to all. When we conduct a competition, we will be forced to select some of the presentation as the awardees. So it doesn't mean that the others are bad, all are good, but these points are really concerned. You have to really focus on designing and how you are going to convey your message. Thank you.
Please log into the event platform anytime after 5 p.m. today to download your conference certificates. And please note that you will be able to download the certificate only after submitting the feedback form. Thank you.
Thank you, Dr. Saran sir, for giving us the feedback about the posters. And once again, thank you all on behalf of Organizing Committee AFPICON Kerala 2022 for attending the conference. So with this, we are concluding our virtual 6th annual state conference, AFPICON Kerala 2022. Hopefully, we will meet next time on a physical basis. Hopefully, if the situations are favorable. Thank you all.